Good morning, Mark.
Good morning, Councillor.
Perfect. I just want to make sure everything's working on my end.
Yeah, and we are streaming on YouTube.
Perfect.
Morning, Jenna.
Good morning, Teresa. I've got a different setup this morning, so bear with me.
Okay.
You in the writing office, Jenna?
I am, yeah. Better internet and no children to distract me.
Morning, Chair.
Good morning, Vice Chair.
I just want to let you know I forgot to tell you this because I didn't find out till yesterday. I'm going to have to jump out for about a half hour around noon for a COVID meeting with the mayor and Dr. Etches.
Hey, thank you.
But maybe we'll be done by noon.
Maybe we will.
It's got to be less time than yesterday. I hope. It was a long one yesterday.
It was a long one.
Lou off on all his questions.
Don't think I was part of the problem yesterday.
You know, I was going to say, Matt, you have to stop posting all those pictures with your really cute baby. People are going to want to vote for her and not you next time.
She'll be knocking on doors with me. She'll be three by then, so it should be fun.
Wow.
It's
Wow.
crazy how fast it goes, eh? I know that didn't your daughter just celebrate her like 13th birthday?
Yeah.
That's crazy.
Yeah.
First
It is
time I
fun.
ran, my youngest son knocked on doors with, well, they all did, but in one case, my youngest son knocked on doors with me, and he was 9, and one guy just slammed the door, right? Wouldn't even talk, just slammed the door, and so my 9-year-old says, "I don't understand, Dad. Aren't people supposed to want to vote?"
Aw.
And I said, "Yes, they are supposed to want to. Doesn't always work that way, unfortunately."
Aw. Cute.
My baby son will be 37 tomorrow.
Holy moly.
Well, he can knock on doors.
Oh yeah. Well, he's in Winnipeg at the moment, but yeah. No, I brought my grandkids canvassing. They were great.
Cute.
Oops.
Morning, new chief.
Good morning.
Now make sure to give Tony a run for his money, eh? That's why you're in there.
That's not hard. I was a slacker.
All right. Good morning, everyone. We are live on YouTube and we have reached 9:30. I'm just taking a peek. I think we're all here. Yes. Okay. Fantastic. So with that, we might as well get started. We do have a lot of territory to cover today. So perhaps start, if I can ask Mark, committee coordinator, just to do roll call.
Yes, Councillor. Councillor El Shantiri.
Yes.
Councillor Deans. I think she's not here yet. Conseiller Fleury.
Bonjour.
Councillor Lulov.
Ici.
Councillor McKenney.
Present.
Councillor Meehan.
I'm here, thank you.
Councillor Kitts. She hasn't joined yet. Councillor Deans is here now. And you have quorum, Madam Chair.
Thank you very much, Mark, and good morning, everyone. Welcome to the Community and Protective Services Committee meeting. I will call the meeting to order. The meeting is being held remotely through Zoom, which is necessary in these times of physical distancing to keep everyone safe. Please note that those who do not need to participate in the meeting can also watch the live stream on Ottawa City Council YouTube channel. And a reminder to participants to please keep your microphones muted until I call on you to speak. And then, of course, the reminder to turn your microphones on when you do speak. I'm sure we'll go through that again today. I will provide each committee member with the opportunity to ask questions or comment on each item in the order in which they raise their hand in Zoom. Committee members will be called on first, followed by any other members of council who have joined the meeting. For panelists, the raise hand option is found at the bottom of the participant list. For attendees, you'll find the raise hand button at the bottom of your Zoom window. For those who are calling in, you can press *9 to raise your hand. And Mark and I will be watching for those cues. The usual 5-minute speaking limit does apply. Members are also reminded to submit any motions, visual supports, and declarations of interest in writing to Mark at their earliest convenience. Although the deadlines have passed for residents to register to speak to this committee, Residents may still make written submissions prior to council on October 28th. And for the benefit of council and committee members, all presentations from today have been shared in the shared drive and also on SharePoint. If you have any technical difficulties signing into the meeting, you can contact the clerk's office at committees@ottawa.ca or by calling 613-580-2424, extension 28821. We have a busy agenda this morning, but before we get on to our first item, I want to offer a few comments. First, I wanted to congratulate Pierre Poirier on being named the new chief of the Ottawa Paramedic Service. I know all of us know Pierre because of his tireless work as the manager of security and emergency management, a job that has proven to be very challenging and unpredictable with floods, tornadoes, and now, of course, the pandemic. Certainly not an easy role. Pierre has previously served as a deputy chief and is a trained advanced care paramedic who brings a long list of qualifications to his new position. So Chief Poirier is here with us today and will be presenting the Paramedic Services 2019 annual report. As my colleagues will remember, the Paramedic Service annual report was deferred from the last meeting to today to ensure that we could hear directly from our local area hospitals, who I'm happy to have join us today. Cameron Love, the CEO and President of the Ottawa Hospital, Dr. Andrew Faulkner, CEO and President of the Queensway Carleton Hospital, and Dr. Bernard Leduc, CEO and President of the Mount Fort Hospital, are all here with us today. I have asked that they make a brief presentation to our committee to outline actions and next steps that the hospitals will make to minimize offload delays. I know we all have a shared interest in ensuring that residents of our city receive the best possible care. Appreciating, of course, that our health system has many challenges, and COVID certainly has not been easy. However, I will remind my colleagues and the public that the information that will be presented this morning from the Paramedic Annual Report was 2019, so we will be discussing the materials that happened prior to the pandemic. I know there are some concerns amongst us with some of the information that we'll be hearing and discussing here today. Response times have begun to erode as a result of offload delay, specifically for CTAS-1 calls, which are life-threatening. The report shows how Ottawa paramedics spent over 53,000 hours in offload delay. And these lost hours are equal to a loss of 64 FTEs, which cost the city annually $7.7 million. And that was for 2019 last year. As detailed in the report, industry practice, best practice is to transfer over the care of the patient in the hospital within 30 minutes at the 90th percentile. And this is not currently being met, which is worrisome. We will hear more about the factors that go into offload delay and what can be done to minimize it. For the benefit of those that are following the discussion today, it is important to note that Council has continued to make investments in our paramedic service, including the hiring of 78 paramedics since 2015, and additional response vehicles to account for the increase in our call volume. This is in addition to a number of mitigation strategies that our paramedic service has carried out over the last handful of years. So with that, I think that we will move on and move into the presentation. Paramedic offload delay, it continues to be the largest issue impacting paramedic services across Ontario. Ottawa is not alone in this challenge. And today we are calling on our local hospitals to make the changes necessary to offload patients in the emergency department at a quicker pace. This will free up resources necessary to provide residents with the service that they rely upon, and further help to modernize our operations and improve service delivery, which will reduce some of the strains on our hospitals. Before I pass it over, I do see that Councillor Kitts has joined us. Welcome, Councillor Kitts, to the committee, your first committee meeting. And again, congratulations on your election, and I look forward to working with you. With that, I will now hand it over to Mr. Demonte and Chief Poirier for the presentation on the annual report.
Chair, just to remind you, we still have the declarations of interest and the minutes.
Oh, apologies. Thank you. I'm getting ahead of myself. Thank you very much. So as mentioned, so there's no regrets this morning. Thank you. Are there any declarations of interest? Seeing none. And confirmation of minutes, the minutes of Thursday, September 17th to 2020. Are the minutes confirmed?
Okay.
Confirmed. Thank you.
Madam, I have questions. I'm sure I have questions on the inquiries. Is it possible to pull the item?
Yes, apologies. I'm just getting my notes here. And the inquiries, I believe, are at the end of the agenda, but yes. So we'll, Councillor Fleury, we'll get to that at the bottom of the agenda.
Oh, usually we need 2/3 to bring it on, and then yeah, I'm looking to you and the clerk just to advise me, but I do have questions on the inquiry.
Okay, so we'll get to that at the end of the agenda, if that's all right with you. Okay, and then with that, again, I do invite GM Demonte and Chief Poirier to present the 2019 annual report.
Thank you, Madam Chair, and good morning, everyone. And on behalf of staff as well, welcome to Councillor Kitts to our committee. She's actually my ward councillor, so it's a pleasure to have her on our committee. Madam Chair, as we always do, and the EPS services are a little distinct compared to other departments, we have mandated legislative requirements to report to our community through you as our elected officials annually our status. And that comprises for all our services, so the fire service, bylaw, regulatory services, our Office of Emergency Management, and today the paramedic services fulfilling that function. Normally we do it in spring, and as you've said, this has been a special year with COVID, so it's been delayed till fall, but we are pleased to present to you the tremendous work the men and women of our paramedic service and what they have done to provide service to this community on your behalf. As you indicated, today our new chief will be doing the presentation. And before I turn it over to him, I want to also thank, I know he's not with us this morning, but the Deputy Chief Peter Kelly, who again, this is the second time in his career stepped up when I asked him to assume the acting role. I know he's got a long runway ahead of him, so I know one day he'll be officially sitting in the chief's chair, but he's returning as part of the executive team in his deputy chief of operations role and be supporting our new chief. But I want to thank him publicly this morning for all the tremendous work he's done. So thank you. With that, I'll turn it over to the chief for the presentation. Thank you, Madam Chair.
Thank you, Madam Chair. It's with great pride that I'm here today. My presentation today is really about celebrating 2019 and the fantastic work that the paramedic service does. You know, it really is a moment of pride for myself to come full circle, having worked for the service for a number of years and seeing the progression and the maturity of the service. And probably one item that'll be on the agenda a little bit later is, as good as this service is, there's external factors that are impacting its ability to even excel to a greater degree. And we'll be talking about offload delays a little bit later. But first, with respect to 2019, as we move to the next slide, it's important to note that in terms of the service we provide, and many of you have seen this before, we provide a service to an urban area, a suburban area, and to a rural area. And we have over 600 employees, and our budget is just over $100 million. What's a particular note is that 63 million comes from the province, And the Central Ambulance Communications Center is 100% funded
Pierre,
by the province.
I apologize. If I can ask you to speak up just a little bit.
Sure thing.
Thank you.
I'll increase the volume here. So as I was saying, is that a little bit better? Thank you, Chair. With respect to the Central Ambulance Communications Center, it also provides service to Eastern Ontario, not just the city, and that's an important distinction. And the fact that the province does contribute to the overall funding of the service. As we move to the next slide, it's important to note that year over year, the call volume has been increasing. And if you see over the last 5 years, it's been a 9.3% increase. We're up to over 146,000 calls. And what is driving that isn't just the overall population growth, but the fact that as the population ages within our community, those patients over 55 years old represent 57% of our total call response. And this isn't unique to Ottawa. This is something that is noted in all communities across this country, where patients that are over 55 are a disproportionate number of the calls. And it does make sense. As people get older, they do need more healthcare, and the paramedic service is here to provide that service. The next slide with respect to our response time standards. These standards are based on the Canadian Triage Acuity Scale, CTAS as it's called, and there's a ranking of the priority of patients. And the reason that is done is so that we're able to provide the highest level of service to the most critical patients, or the ones with the highest medical acuity. And we do have a ranking of these patients. Those patients are ranked in terms of CTAS 1 through CTAS 5. And we do have criteria for those patient groups. And then you'll note as the last item, sudden cardiac arrest is also recorded in a separate way, partly because the intervention of paramedics can make such an incredible impact on the lives of these individuals. So that is overall the response time standards as a grouping. And as we move to the next slide, you'll see what our targets are and the performance. And if you take a look, that the city continues to meet its mandated required response times. And just an important note here is this is the response time for us, the service, for the paramedics to arrive at the patient side. And that's kind of a critical piece here, is that the time that it takes from the call to 911 to the time that we arrive at the patient side. And you'll see that on the most life-threatening, the CTAS ones, we're still meeting the 75% the 8-minute target. And you can see as the level of acuity of our patient groups, the timelines vary, but we're continuing to meet our performance targets on all of those categories. And really that is a credit to the service and the design. If you have questions regarding the overall, how are these established, this council, or sorry, the councils previous have had an input into the determination of these rankings. And that's an important distinction to note, that the city has been involved and council has been involved in determining what the performance benchmarks are. As we move to the next slide, an important feature here is offload delay. And you can see that it is actually the single largest issue impacting paramedic services in Ontario. And the data here is that we lose 147 hours per day in 2019. And when we've actually gone back to take a look at what this translates into, it's the equivalent of 64 full-time equivalent paramedics for a cost of $7.7 million. And this really is one of the most important issues facing a service. And it is critical to the service as we go forward, that if we can find a resolve to this, this will put paramedics back on the road. This will put paramedics or make paramedics available to provide service to our community. And once again, those performance benchmarks should improve with the addition of the services being put back on the road. It's unfortunate that offload delay is something that really does drain the service of its ability to provide that high quality service and be available to provide service. The next slide is with respect to the impacts to our community. And you'll see that we've had an increase in the number of level zeros. And a level 0 is that there's no ability to transport patients. There is no paramedic unit available. There's no paramedics available to provide care to that next call for service. And this really is something that keeps us up at night. It really is an issue that is significant to the community. When somebody calls 911, be it a family member, be it your mother, your grandmother, there's an expectation that there is somebody that is available to respond and to provide care. And this really is a significant impact on our community. The next piece is that there's a limited coverage in communities across Ontario. And non-threatening emergency calls are held for up to an hour. So as the number of available units or paramedics decreases in our community, we're making tough decisions. And when there are no units available, we will hold calls in a queue. And it's unfortunate that for somebody who's had a fracture or a fall, that the paramedic service response can be delayed. And that really is kind of disheartening for the paramedic service. It's disheartening for paramedics. And it really is something that's difficult for the individual at the end of the line, the individual who's actually calling for help. Another unintended consequence of this is that when there are no units available or paramedics available in our community, we will ask neighboring communities to provide that service. And you can see that this is not a good scenario for us because of the impact on the other communities as well. So Renfrew County, Prescott Russell, their units end up having to provide service within our community. If this was once in a blue moon, if this was once a year, it may not be an issue. But when it's a regular occurrence, it really is difficult to equate or to support the practice. It really does lend credence that this issue does have to be resolved. And then the last piece is the human impact. So you have frustrated patients, and it really does affect our staff morale and labor relations, where it really is disheartening for these events to happen. And worst of all is that we're not providing the appropriate service, the timely service to the patients. When there's a clear understanding and expectation from somebody who dials 911 that the paramedic will be on their way. And the idea that it's delayed is very disheartening. Next slide. So as much as we recognize the problem, it's, we often say, what have you done to improve the situation? So in 2019, these are all initiatives that are taking place, that have taken place, that are in place to try to mitigate the issue of offload delays and also provide the high quality service to our community. We have single paramedics that are in a paramedic response unit who are able to respond. We have the offload nurse program that was initiated with our paramedic service and the province, where money was forwarded from the province to the paramedic service. And we've enhanced our community paramedicine partnership with West Carleton. We've developed a targeted engagement diversion program here in downtown Ottawa. The business intelligence and public safety has been for us to share information with the hospitals so that we have a better situational awareness, so that we can appropriately direct patients to the right hospitals, and have good information with respect to which hospitals may be, we'll say, overloaded, and that we are a partner in this to try to find solutions. Other initiatives include the Heart Safe City, the Neonatal Transport Team Pilot Program, and the Ottawa Birth and Wellness Center Partnership. So these are all initiatives in 2019 that were undertaken and really highlight the quality, the high-end service that the paramedic service provides. Next slide. With respect to, we've talked about how the Ottawa Paramedic Service has fantastic initiatives that have taken place to help mitigate issues with respect to offload delay. And I mentioned that the staff morale was impacted by this. It's important to note that the service has taken many initiatives to support our staff. And recognizing that with respect to that, there's the First Responder Mental Health Network, and that has been a very effective initiatives with the fire service and with the police service, and that we have a peer support program in place as well. And then initiatives that are, that are part of our community and that the paramedic service has really taken to heart is the Diversity Champion Program, and supporting our service and recognizing that we have a responsibility to, within our service, to reflect how diverse our community is. And we engage in building relationships with communities across Ottawa, and that our recruitment and retention strategies are looking at improving our diversity within our community. Important initiatives that were undertaken and continue to be in place in support of our staff, but also recognizing how important that our service reflects our community as a whole as well. And starting in 2019, if we move to the next slide, there really was an initiative recognizing that the paramedic service headquarters and the physical assets that the city has, that we've actually outgrown our building and our headquarters. And we've had a significant increase in the number of staff, and we really do need another physical site to support it. If anyone's been to the service, vehicles are stacked. Staffing is, we keep on shrinking the size of their workspace, and really the facility has been outgrown, and this probably goes back several years. So there's an initiative to develop a West End deployment facility, and this is also from a service and from an operational point of view is really a good idea to be able to balance our service and our deployment with respect to how we deploy paramedic units across our community. So we're currently working through the process of following a request for expressions of interest as the first stage of a three-step procurement for a new facility. So this is something that is very important to the service, and recognizing that it's a plan that's in the works. And if we move to the last slide with respect to looking ahead, it really is a fantastic team of dedicated professionals that really deliver high quality clinical care to our community. There's also a good recognition that with the consistent investment by council and the mitigation strategies implemented by the service, that we will continue to meet our response times across all the CTAS categories. So thank you very much for the opportunity to present today. We'll take questions. Thank you.
Thank you very much, Chief Poirier. Certainly appreciate the presentation and all the hard work that went into it over the course of 2019. So procedurally, next we are going to go to our delegations, the CEOs of the 3 hospitals that have joined us, and then following that, we'll have questions to the delegation and then questions to staff on the reports. So with that, I would like to welcome, as I mentioned, so Cameron Love, President and CEO of the Ottawa Hospital, Dr. Andrew Faulkner, President of the CEO of the Queens by Carleton Hospital, and Dr. Bernard Leduc, the President CEO of the Montfort. So if we could, oh, I see them here, and I believe, is it yourself, Cameron, who's going to lead through the presentation?
Actually, all three of us are going to make some comments on the presentation, but Bernard's going to start us off.
Fantastic.
Oh, thank you, Chairman. Thank you, Chairman Suds and members of the Community and Protective Services Committee, General Dimanti and GM Dimanti, sorry, and congratulations to Pierre Poirier, the new Chief of Paramedics. And I can assure you that all three of us will be looking forward to our full collaboration. Thank you for the opportunity given to us to speak to the committee about the subject that is very important to both the hospitals and the city of Ottawa. So again, my name is Bernard Leduc. I'm a family physician by training, and I've been the CEO at Montfort since 2010, and happy to be with my colleagues Andrew Faulkner from QCH, who's also an emergency room physician with a lot of experience, and Mr. Cameron Love from TOH. Next slide, please. We thought it would be important to actually give you a bit of context in terms of where our patients are coming to at the hospital. So they're either coming from the left side from home, either walking, being admitted to our own hospitals for procedures or surgery, either walking or getting by themselves to the emergency room, and or taking an ambulance in some cases. The same with residents, residential homes. Most of the long-term care patients are transferred from ambulances. And as you can see from the numbers getting in the hospital, we see about 72 to 83% of our hospital volumes in emergency room that are coming as walk-in, compared to between 17 and 28% that are coming through paramedics. I think it's important also to state that the organization also is receiving not only ambulances or paramedics from the city of Ottawa, but also from the other counties, Renfrew counties, Prescott Russell's, and Stormont Dundas and Glengarry. Out of those patients that are coming to the emergency room, I'd say 85 to 90% are discharged either back to their community or home, or residential home or long-term care. We do admit between 10 and 15% of those patients to the hospital. There's also a component after that of discharge from inpatients that are actually going back to their community home, retirement home, or some of them need extra services as home and community care. Next slide, please. So again, our inflow of patients to the hospital are coming from emergency room visits and elective admissions, or in the case of the maternal and newborn, coming in for delivery services. We are patients that are coming in for same-day surgery, but also we do, to maximize the utilizations of our bed now, don't admit patients the night before the surgery. So we do same-day admissions for patients that require surgery, and that will end up requiring an acute care bed. And we're also receiving interfacility transfer. I guess TOH is receiving the most because of their tertiary nature, but we all three participating in critical care. Ontario, receiving patients that need access to our facilities for limb and life situation. Again, our outflows patients are either back home alone or home with home care, alternate facilities, discharged to other hospital. Again, for us, the important factor which is really impacting the flow in our healthcare system is the availability of being able to put the right patients in the right bed at the right time. Next, please. So these are the emergency departments overview. So there are two at the TOH, of the Civic and the General, and you can see here the amount of ambulances and visits that all of our facilities are receiving for 2019, coming from the pay for result, P4Rs, pay for results, the government of Ontario giving incentive to hospital to improve in their KPIs about the emergency room flow management. Thank you, and I'll switch and I'll pass it to my colleague, Dr. Faulkner now.
Thank you, Bernard, for that very important context setting. Next slide, please. I wanted to tell you what we're doing about it essentially, and I wanted to describe our activities in terms of initiatives within the emergency department, initiatives within the hospital to support capacity, and some regional collaboration efforts. And then I'd like to turn it over to Cam, who will sort of discuss ideas that we have on how we can work together to support the citizens of Ottawa. May I have the next slide, please? Actually, this was before I get to my bit. This slide was to demonstrate these are actual offload times, and you can see that about 85% of ambulances offload within 60 minutes, and so 15% of the time they're offloading in greater than 1 hour. And you can see that tail is very, very long in terms of, once offload times reach an hour, they can go on for significant amounts of time. Next slide, please. So first, let me say that all three of us feel that level 0 is an unacceptable situation for our citizens. It does frighten all of us to think that there may be times where there are no paramedics to answer those very important 911 calls. And in fact, the Ministry of Health has set ambulance offload times and time to inpatient beds, which is the amount of time from when a patient's first seen in the emergency department to when they're actually admitted to a bed, as key performance indicators for our boards. And these performance indicators are on our executive scorecards. So clearly something that's front and center to the hospitals at this point. In terms of emergency department initiatives to improve offload times, as you know, we have ministry funding dedicated to an offload nurse. This is essentially paramedic comes in, and when there are no beds in the emergency department, there's a nurse that will look after the patient within the emergency department, liberating the paramedics to get back out on the street. We have a funding request into Ontario Health to increase this resource, hoping to provide it 24/7. Pending that funding request, hospitals are actually using our own funds to enhance this service. So we've established more hours for offload nurses that are not ministry funded. They're funded from the operating budgets of the hospital. In addition, we're creating more space for offload. So we're creating space within the emergency department where a paramedic crew can come in and offload the patient and get back out to the street. We've implemented a vertical offload program, and what that means is select patients that meet certain criteria are able to get off of the ambulance stretcher where they're horizontal and become vertical where they're standing, and then go to our waiting room where they will be with the others that have come in through the front door of the hospital. That's a new initiative that I think has a fair bit of potential. The Ottawa hospitals also receive volume from Renfrew and Eastern counties, and we've reached agreements with those to initiate medical directives, which give our nurses the ability to start some important testing, to differentiate causes of chest pain and such things, which does allow for quicker turnover of those patients. We're also hiring additional staff to support emergency department flow and offload, ambulance offload times. So there's a lot of resources going into our emergency department to improve flow. In addition, there are many looking at capacity, and really the root cause of delay in ambulance offload is that there are admitted patients in the emergency department that are occupying beds that would otherwise be used by our ambulance traffic or by those that come in from the front door. So we're in the process of monitoring ED's distribution of activity, and I'll get into this a bit more in a moment. And all three hospitals have implemented unfunded surge beds. That is more beds within the hospital where we can admit patients to keep them out of the emergency department, essentially. We've all expanded our offload and bed capacities in the emergency department also. And there are some regional initiatives underway. The ministry has funded Fairfield Hotel in Canada, which is a Queensway Carleton initiative where we're looking after 28 of our alternate level of care patients in the hotel, keeping them out of our inpatient beds. We're in the process of opening a facility called Greystone, where over 100 ALC patients from the Ottawa Hospital, Queensway Carleton, and Hôpital Montfort will receive their care. So we're working towards a zero offload pilot at the Civic Campus, where ambulances will simply offload directly to the nurse in a new space. On the regional collaboration side, I'm quite excited by this. The Ottawa Paramedic Service has been very collaborative in coming up with a different way to distribute ambulance traffic to the various facilities. So there are times where one hospital may be simply overloaded, and if we bring more ambulance traffic to that hospital, they're simply going to end up waiting. This algorithm will allow us to distribute patients to the emergency department that's most able to accept it. Pierre mentioned the dashboard that are in the emergency department. So we have line of sight of how many ambulances are in each facility, but we're working towards a process where we can proactively manage surge when we're running low on ambulances. So at this point, level 0, clearly unacceptable, but I think we all know that we start getting nervous when there are fewer than 15 ambulances on the street. So we're working at ways to identify early what activity we need to do at the hospital to proactively manage surges. So with that, I'll turn it over to Cameron. And next slide, please.
Thanks, Andrew. So good morning, everyone. And first off, to echo Bernard's recognition, Pierre, congratulations on your new post. And we all look forward to working closely with you, building on the work we've done previously with Peter and Tony. So I'm going to wrap up with some comments on the context that Bernard and Andrew have outlined. And I think, ambulance offload is a significant concern for us, obviously locally, and as well as Tony and Pierre had said, it's a significant provincial challenge. But the real major concern is making sure we manage the risk and making sure the paramedics get to the community as quickly as possible. And one of the sort of founding components that we run as emergency departments is we spend a huge amount of time making sure that we're triaging people appropriately based on their acuity. And part of the context of this is really around how we create bed capacity together as a community. And when you look at those graphs, when we have very good bed capacity, not only are we able to get to urgent surgery more effectively, we're able to get Pierre's team back out on the road more quickly. We're able to improve the flow through ED so people aren't sitting in the emergency department waiting for a bed for upwards of 72 hours at times in real peak periods. And it's very seasonal. If you park the pandemic for just a moment, the winter season is typically our most challenging time of year for all of us. We've got a lot more exacerbation of disease. We have a lot more injuries coming in, and we have a lot more ambulance traffic. And so part of this is the points that Andrew and Bernard raised of using those to create surge capacity in the winter months. But one of the biggest pressures that we have as a community is access to beds. And I think the real driver on this is if you look at the hospitals, we have enough acute care capacity and bed capacity to manage access to acute care, which allows us to let Pierre's team get back on the road very quickly and offload. It's when our post-acute or our ALC activity climbs. And over the last 5 years, it's grown by 50%. So to give you as a practical example, if you look at TOH and you take our organization 5 years ago, we would have been very challenged with about 140 ALCs. The last month, we've ranged between 220 and 260. So that by virtue of that, part of what we have to do is continue to support the growth and capacity of beds in the region, within long-term care and within post-acute care, so we can keep the system flowing to allow us to address ambulance offload while we put in these other measures. And it really is the primary reason why we have ED wait time and ambulance offload challenges. And so a lot of the work that's come to light through the pandemic, which has been a great opportunity, is Number one, the team's capability in terms of triaging activity is just incredible. From the paramedics to our emergency staff, our physicians, our surgeons, they do a tremendous job at triaging based on acuity. Part of what we have to do is create the capacity so that for the least acute activity that tends to be the longest waiting, we allow that activity to move. And so while we've seen increases in ALC, I think we're also seeing a growth in terms of the incidence of disease, the age of the population, and the amount of volume that's coming both to the emergency department, and you can see the numbers there, at the same time that Pierre and Tony are dealing with increases in terms of ambulance volume. So as a community, we really have to take a look at how we continue to increase our bed capacity and take very much a health system planning approach. And the work we've done previously with Peter and now with Pierre is built very much on that. And I think one of the silver linings to the pandemic is we've been able to put together plans around highlighting to the province the capacity that's needed. And hence we've got in Greystone, as Andrew said, the hotel. We're looking at trying to get additional bed capacity approved so we can do the zero offload pilot at the Civic, which means with those beds in place, any ambulance that comes in, we can basically take them off the ambulance stretchers and let the crews leave. And if that pilot works well, then try and roll that out at General and Queensway and Mofor in a very systematic way as we build more bed capacity. And then I think the final piece, and Andrew touched on this thing, is one of the other pieces that has been the EMS group has done a tremendous job at is the data that they've able to produce in terms of real-time data and the tracking of ambulance offload. So with that in place, part of this is we know we've got challenges in terms of capacity as a community. We know we're going to have moments where we've got, just a bolus of activity coming in amongst traumas and other activity. But if we can actually use the data, forecast it, smooth out where ambulances are going between the sites so that we distribute the activity to decrease ambulance offload. But also, if we know what's coming, to Andrew's point, start to have a different surge protocol so that we avoid at all costs the zero delay, which are probably the highest risk situations, and then create these plans by month in terms of a surge response. So all that to say, I mean, I think we have as a group, we've made some tremendous progress over the years, and while it is not where any of us want to be, I think with the recent bed announcements and some additional bed approval and getting the Civic pilot up and running, we can take a next step in terms of improving ambulance offload delay. So maybe we'll stop there, Councillor Sudds, and I assume you want us to take some questions.
Terrific. Thank you very much to all three of you for your presentation. You're correct. I see a number of hands up from my colleagues with questions. And I'm going to apologize ahead of time to my colleagues. I wasn't paying enough attention to the order that they came in. I was so enthralled by the presentation. So bear with me. I'm going to go with the order that I have here, committee members first, and then our other colleagues who have joined us. So I'll go first to Vice Chair Aglai.
Thank you, Madam Chair, and thank you to our presenters. Good to see you again, if only virtually. This is becoming a bit of a habit, Dr. Love. You coming to committee and answering questions. So again, bear with me. I'm not a doctor, but I spent a lot of time on this file over the last number of years, and a lot of time with our paramedic people. Going through the problems, the issues around this, and perhaps I'm making this more simple than it is, and I'm sure there are nuances that I'm missing here. But the way I understand the problem is when someone is dropped off at the hospital by a paramedic, they cannot be left alone. That makes perfect sense. There has to be a handoff of the patient to someone of equal or higher medical training. So either to a hospital paid paramedic, a nurse, or if there happens to be available, a doctor. I see you all nodding your heads. So far I think I'm correct. And so the issue seems to me to be, and the solution, and again, maybe I'm looking at this in a way too simple fashion, is the hospital needs to have a body in the emergency rooms 7 days a week to take care of that handover from the ambulance personnel. And if there's a body there to take that, whether it's a nurse or a hospital paramedic, then that ambulance and those paramedics that have dropped off the patient can get back in their rig, get back out on the street, and deal with the other calls that are out there. So to me, and I'm making a bit of statement, but we'll get to the question, I promise. To me, it seems it's a resourcing issue. If the hospitals had the money, and maybe you do, maybe you don't, I'm not going to get into that, but to hire that staff person or staff people to be there, I think the ratio is something like for one nurse, 4 patients, something in that range. If the bodies were there to take the handover, then the ambulances get back out on the road, and we don't have these same problems, and we avoid having this zero level happening. So I'm happy to hear what I've missed in the process, but it seems to me if you hire people to be there to take the bodies as they come in, then Pierre's team can get back on the road right quick and get to residents that need their assistance. So please tell me what I've missed.
So maybe I'll start with that one. So you're right, it is a matter of resources, both health, human resources, and space, actually. And several of the initiatives that I've described are actually addressing that very point, Councillor Eglag. So the initiatives to create space for offload within the emergency department was mentioned. And this ambulance offload nurse, which is currently funded at a certain number of hours per day, also mentioned. And the request for funding that we've submitted to actually provide another resource, whether it be a med tech or a nurse, to exactly handle that handover that you described. So I know at the Ottawa Hospital, they've actually funded that health human resource with their own funding. And we're looking at the same sort of thing at the other hospitals. So yeah, I think you've captured it. Some of the initiatives we tried to describe were to address that exact point. And if there's further clarification, I'm happy to try to assist.
Well, I guess my frustration and the frustration of the people sitting around council, and we've had this discussion several times over the last number of years, is we all seem to know what the solution is, and and yet we're discussing this year over year over year over year, and it's really not getting better. So if we all agree that it's a question of getting some additional bodies into the hospitals to do the handover, and I know there's some provincial funding for it. Maybe the issue is there isn't enough provincial funding for it. But what can we do as a committee and as a council to bolster your discussions with the province, if you will, to get those resources in place? Because I think we all understand what the resources are that are needed. We've been talking about it for years. The dialogue hasn't changed. We need to have bodies in hospitals to take the people, and they don't seem to be there, or they don't seem to be there in adequate numbers, which is then having Pierre and his people sit and wait while we have kids with broken legs at hockey arenas, or people who are having asthmatic attacks, or whatever the case may be, for far longer than they should. So again, I guess my big question is, what can we do to assist you to make that ask to the province that that's what needs to be done, to get you additional resources, to pay for that extra nurse, med tech, paramedic, whoever you want to use in that role? What's it going to take? Because we know what the problem is, and frankly, we know what the solution is. So just if you could tell us this morning how we can help you to make that happen.
So maybe I can add. So the process, and I think Cameron did actually talk about it, is that it's not just only having the human resources. We need space in the emergency room, and every system has bottlenecks. Our bottlenecks is getting patient out of the emergency room. So this, 80% or 85% that we're sending home, it's not an issue. Seen by a physician, go home. It's the ones that need to have access to a hospital bed. So they stack up in our emergency room, which then makes it impossible. We could have a body looking at taking end off, but we would have no place to put the patient because all the stretchers are used by patients awaiting access to an inpatient bed. So it's all related to flow, and flow is, the emergency department flow problem is not an emergency room department problem. It's a hospital problem, and the congestion in the hospital is not a hospital problem. It's a health system-wide problem. So again, if we get stacked up, and we indicated that our patients that are waiting in our beds to access to other beds in the community have increased 50% over the course of the 5 last year. It's just that element that provides us. So even if we had staff to take more of the ambulance offload, if we don't have any place to put the patient because our stretchers in emergency are full with patients awaiting a room in the hospital, that's the situation that's causing that particular bottleneck.
So maybe Councillor Egley, I can just add to reinforce what Bernard's saying. I think there's an element here of getting support to get additional dollars to help with the ambulance offload. There's no question that helps because we can hire dedicated people. But I think the piece we have to continue to move on is that expanded bed capacity in the community. So if you take today in this community, there are 850 long-term care beds that are closed. That is a direct impact on the bed pressure in the hospital, and the emerge team that we staff is staffing, at least this morning at our place, an additional 30 beds in the emergency department that should be on the floor but can't get to the floor because the ALCs can't get to the community. So part of this is continuing as a community to build the plan around the additional capacity required to deal with the ALC pressure, which tend to be our frail elderly that need that support, and then investment into the ambulance offload with the space that allows for that to be freed up. Those are probably the two principal things that we just have to keep moving forward with. And so the recent announcements help with the bed plan. If we can get some more investment around dealing with ambulance offload, but Bernard's right, there is a point in time. And the other thing I think we have to be very cognizant of, and Pierre's team does a great job when I saw that data on the CTAS 1s and 2s. Similarly, if you take all of our emergency departments, and I'll use a practical example, last weekend, fully plugged 250 ALCs, 4 traumas come in within 20 minutes. In all situations, our emerge teams do a tremendous job of making sure the most acutely ill get through. And so that whole team moves from dealing with whatever they're dealing with to deal with the traumas. And so this system issue of creating bed capacity allows that to move. And when you look at all the data that I suspect Pierre and Tony and Peter presented previously, on times when we have low occupants in the hospital, the ambulance offload is virtually nil for the CTAS 4s and 5s, and 1, 2s, and 3s, they always get in because they're the most acutely ill. So our teams together do a tremendous job at triaging. What we're talking about is the tail end on the 15% that we have to build bed capacity in to keep that flow moving.
So just a very quick follow-up. So, and I know it's a ways off, but there's a brand new hospital coming. It's going to be state-of-the-art. Is part of that state-of-the-art going to be taking into account these issues that you've indicated you have around flow? So when that hospital is built, and again, it's in the future, but when that hospital is built, we're not going to be having the same discussion around ambulance offloads at that new location.
I'm going to say yes, but if our ALCs go from 250 to 400 by the time we open, that's why this is a health system planning issue, to Bernard's point. If the province is planning and investing in building, I think it's 10,000, it could be 20,000 long-term care beds, more assisted living based on what the city does in terms of that to capacity, more behavioral management capacity for our patients that unfortunately suffer from mental health disease. If there's not capacity in the community and all those patients are going to be managed within the trauma center, We can build the emerge as big as we want. If we can't get the beds in place to keep the flow build moving, we are going to have challenges in terms of bottlenecks. That's no different in Toronto, Hamilton, or London. That is, and in Ottawa for sure, that is the piece that we have to continue to focus on.
Thank you. And again, I want to reiterate, and I don't want to speak for the chair, but I'm sure that, you know, if there are things we can do by way of vote or direction or whatever, this committee would be more than happy to assist you in making that case for additional funding or resources to deal with your bottlenecks and your flow issues. Thank you.
Thank you, Vice Chair Eglai. I was about to cut you off with your 5-minute limit, so perfect timing. So next I will go to Councillor Lulov.
Thank you very much, Madam Chair. Bernard and Cameron, thank you so much for your help throughout this pandemic. I know, Cameron, we spent quite a bit of time on the phone together, and I really appreciate your collaboration and your help with, getting, with Bernard getting our care center set up here in Orléans. I really appreciate it, Monsieur Leduc. Your staff is incredible. They've been great to work with. Thanks. I hope that you're going to take the same proactive and collaborative approach to dealing with the challenges that we're facing with offloads. Honestly, the bottlenecks, Monsieur Leduc, that you described isn't our problem as a municipality and as a paramedic service. It's your problem as our hospitals and as a healthcare system, one that's the responsibility of the province. And I get that. But it's a problem that we are paying for as a municipality. And frankly, as the vice chair pointed out, this is an ancient problem, one that needs to be sorted out years ago. So working towards a plan isn't really what we want to hear. What we want to hear is that you have a plan, that we've defined the issue very well, which we did today and last year and the year before that. But I need to know how we're going to fix it. We've done our part as a municipality, over 70 new paramedics, on one of the paltriest budgets of the lower order of government. We managed to pull that off. That's a feat. How many emergency nurses have your hospitals hired in the same amount of time? And how many do you plan to hire moving into the future on the same and on what timeline?
Let me start that one, Bernard. So it's a good question, Matt. I might provide a slightly different context or a set of questions back. So I completely agree with you that the hospital has a responsibility in terms of supporting anybody coming to the organization to give them access to care. But would you agree that, based on what Bernard described, that it's probably not right for the hospital to be managing between our 3 sites, probably 400 patients that can be cared for in the community?
I would agree that the hospital needs to be able to have the capacity to deal with the demand on the system.
So here's my point, and this is where I change what you've said. I think we definitely have a role in terms of doing everything we can to support ambulance offload delay, 100%. And you can see the things we're doing, and we've, I want to give a shout out to both Peter previously and now with Pierre and Tony. There's been a lot of work trying to do absolutely everything we can to manage surge and wait time. And wait time, unfortunately, is a reality within healthcare. Cancer wait times, eye care, surgical, et cetera. And I think as a community, we've done a tremendous job of moving the bar in terms of addressing these things, but we haven't got the bar exactly where we need to get it to in terms of ambulance offload delay. And so I'm 100% committed to trying to, all of us are, all of our partners, to trying to figure out what are we doing next to build that. The only thing I'd suggest to you is that I think there's a role for the community, including the city and as councillors, to help us build that capacity in the community. So the city owns and runs long-term care homes. The city deals with assisted living. The city deals with hostels. The city deals with various establishments to deal with mental health populations. Part of this is our plan is not only what are we doing with short-term goals in terms of what are we going to do to improve ambulance offload. I can speak for myself, and Bernard and Andrew can comment. I've hired nursing staff and staff to staff about additional 100 beds. I promise you that's more than the 7.7 million on the ambulance side. And I'm not faulting that, and we're going to continue to do that. But we've ramped up incredibly, and now we're starting to talk about hiring paramedics to deal with ambulance offloads so we can get them out quicker. So we will continue to do those things. But I think my point to Keith's question before, or comment, we have to, as a community, come up with our plan of what we're going to build community capacity, because 3 or 4 years from now, if we don't have that capacity in the community and the hospitals are required to deal with it, what we don't want to be doing is causing ambulance offload. And when we have that pressure, canceling the community member surgery because they can't get access. And those are our 2 biggest concerns in terms of risk. Okay. And so I think working with the city, and Peter and Tony have been tremendous on this, around what are we doing to expand capacity? And those are the plans that we're putting in. So we're upwards of almost 200 beds approved as part of this pandemic, which is great. We have to continue to move that bar while we put in these initiatives to make sure we get Pierre's teams out as quickly as possible. And our real challenges, and I think the system they've put in to sort of smooth where ambulances go. So if the Civics jam and the general has no one there, send them to the general and use that forecasting capability. But our real challenge is that 10% in the winter where all sites are jammed and we've got a bunch of traumas coming in. And what are we going to do to surge, and how do we create that capacity? And those are the things that Andrew spoke of that we're going to do this winter. But we really have to focus around this bed capacity plan as a community so that we actually eliminate ambulance offload. The idea would be is like 20 minutes is the 90th percentile for the C task 4s and 5s, and everybody else is flowing through. That's in essence where we want to be.
I'll put a bit of a fine point on it. Like I know what a level 0 looks like. It looks like my newborn daughter desperately struggling to breathe at the birthing center and needing a CPAP. And it looks like a helpless family needing reassurance and NICU care. The paramedic that night did their part, and they provided a tactical medic as an interim measure. But he was as helpless as we were without a truck because they were all stuck on offloads. Your presentation and your responses provide me little reassurance because I just don't see the concrete plan that's needed. And maybe you're not the right person to be bothering about this. And I want to work with you in any capacity that I can to help you fix it. So what can we see in the short term then? Like what concrete actions are we going to see in the short term to make sure that no other family in Ottawa needs to go through that? What was supposed to be one of the happiest nights of my life is always going to be scarred with the anxiety of an entirely preventable level 0.
So I can the concrete things that you're asking for in the short term we're doing is we're going to get this level 0 pilot off at the Civic, which is going to help. The Civic's the site we collectively have to try and decant the most because it is the trauma center. It's where our sickest people are coming. So I think doing that level 0 plan, getting that bed capacity that we're working with ministry on in place, that in itself will make a tremendous difference in terms of that.
Is that the hospital in your system that is experiencing like the most delays and the most?
The Civic and the Queensway tend to be the 2 hospital sites that have the most duress in terms of volume of ambulances. And then the general and Montfort. But the interesting thing is you can trend it for a year, but on any given day, any one of them can be under tremendous pressure. So I think part of this is building that capacity each of those sites to offload. So the things that Andrew had highlighted, I do think are going to make a difference in the beds we're putting in place, will allow us to make improvements through the winter without question.
Okay. So like obviously a nurse can care for more patients than a paramedic can. A paramedic is tied to one patient, whereas a nurse can look at several patients. And I hear that we need a space for patients to be transferred to, and I know how these capital costs can really rack up and how difficult it is to get these plans in place, and that for the most part, the TOH system doesn't quite exactly have the land to be building on top of to get these spaces built, right? So I'm glad that you have a plan for this, but how long are we going to have to wait for this space to be established and built, and what's the process moving forward? I get it. Healthcare is the responsibility of the province, and it's going to be delivered by your hospital, and that you need that funding, but we can't continue to download this burden to the municipality. I get it. $7.7 million to a major organization like you guys isn't really that much, but it certainly is for us. It's the equivalent of 64 FTEs. And this is a really unacceptable burden that our paramedic service is having to bear. So how do I help? What's the plan moving forward to create this space? What does that look like? And how are we going to get there together?
Yeah, so we're very close on getting the approvals in place on this. Based on where we're at, and Tony and I have had a number of discussions on this, I'm pretty confident saying by Christmas we're going to have that in place. So we're talking about a couple of months here, and that'll be a short-term initiative that's going to help move this forward. And then we've got to move on to the next. And if it works well, then the goal has really got to be to get the similar type of support and approval in place to deal with the Queensway General MOFOR. And get those types of capacities in. But if we can get the Civic dealt with, if the Civic's dealt with and Tony and Pierre's systems in place that allows them to move the ambulance to the place with the lowest offload, that will make a tremendous difference.
Okay. I understand that you are between a rock and a hard place and that the province is a rock and that, we're a hard place. So I get it. Do any of the other presidents want to comment on this line of questioning before I wrap up?
No, I just want to echo Cameron that we've all increases in terms of nurse at the hospital for looking at overcapacity. Last year, even before COVID, we were operating at 110 to 115% overcapacity, which means that we've opened bed, but we're pretty much close to having any physical space for beds now to increase. And if you look at the increase in patients that should not be in the hospital right now, it's like we can hire more nurses, but it's a reduction. It's like the region in Ottawa has been reduced by about 150 beds compared to 2 or 3 years ago. It's not that we have extra capacity in the hospital, we have less capacity in the hospital. So, but we're committed as a group to work diligently with the council. And I think any help that we can get from the committee in terms of advocating for not just necessarily staff in the emergency room, but the system overall to allow the hospital to do what they're built for, look at acute care patients.
Well, I offer any support that I can to the chair and to you guys to getting this fixed. I
think we've lost.
That we'll be able to work on, and let's work together on this thing.
Terrific. Thank you very much, Councillor Luloff. And next I'll go to Councillor El-Shantiri.
Thank you. Thank you very much, Madam Chair, and thank you specifically to Dr. Love, which is we heard from at the OPH not too long ago. And so you heard from my colleague, and I don't want to repeat from the question. I think one of the largest frustration in the rural area, and I'm sure some of you will heard about it, is the neighboring municipality picking up one Ottawa paramedic on, not be able to serve this community, or it happened to be level 0. So then we are really dependent on a neighboring municipality, and the neighboring municipality, I'm sure you heard from them, you heard from the minister, you heard from many times, the mayors around Ottawa, they are frustrated with the status quo or what's happening, and how many times they have to help Ottawa. So I'm not sure who's going to ask the question. We heard you loud and clear what you're saying about the offload, but that doesn't really help the community who is. I have to admit it. I represent a large rural area in my area alone, larger than the city of Calgary by 50 square kilometers. I get that. I know the response is going to be slower than what it is in other part of the city. But when we hear the rural municipality serving us more than our own city paramedic, there's a lot of question to answer here to my community. Can you help me? Tell me, and I know all the steps you're taking is going to help, but I mean, is there specific help for this area?
Yeah. Did you want to go, Bernard?
Well, I guess every initiative that we're looking, I don't think we're triaging ambulances that are coming. I think we need to increase our flow for all ambulances that are coming here. So obviously, if we can reduce the number of level 0 time where you need to call on the other community, I think it's important for us to work. Again, our commitment is to work diligently with the paramedics and try to increase as much as we can and reducing as much our services and reducing as much as we can the offload ambulance time.
So let me ask you again, and I mean, you heard from the paramedic presentation, you heard the good questions from my previous colleagues talking about this. So if you have a meeting today with the Premier and the Minister of Health, what would you be asking or her, or both of them, him and her? What would you be asking for to solve this issue we have in Ottawa?
I guess I'll leave Cameron to ask, but we're in constant conversation with now Ontario Health, with the East region lead about the problem of our capacity, acute care capacity, and how do we build extra capacity in the meantime. Even though the province has announced 30,000 long-term care beds, even though the province has announced some change in home and community care, I mean, we haven't seen any of that actually materialize in the area. So that's why collectively we are working with our partners and our Ontario Health to have funding to increase temporary capacity. So go through the pandemic, we can go through the influenza season, and that will allow us to improve our capacity to take charge of the ambulances that are coming. So it's not that we're not actively having conversation with the powers to highlight the issue, highlight the problem, and trying to find solutions. And they've been very active since the beginning of the pandemic to recognize that. And Cameron's is constant conversation with our lead with the Ontario Health.
Yeah, Councilor Secretary, I agree with Bernard that has been our entire discussion, and the ministry's been very responsive and it's been very good. That's why we've gotten a bunch of these beds approved. It's that bed capacity. I can only speak to the organization I run. I suspect Bernard would echo this for the MOFOR. If we had 100 less ALCs today, I would pretty much be able to guarantee that we will have very few offload issues with that drop in pressure. It's 100 beds, which means I've got 35 admitted this morning without a bed in emerge. That team's having to manage that activity, plus the 300 patients coming in, and the probably 30 to 40 ambulances. If all that activity is moved and moved through, then ambulance offload is something that indirectly improves because of that capacity, which means the first question you raised, if they're back out on the road, then their ability to respond to rural areas is better than what it is today. And so our focus has been just trying to move to get those beds and get the 850 long-term care beds, at least half of them back online, which is not really a hospital responsibility, but it is a community responsibility as hospitals we have to help with.
And Dr. Love, you heard from all of us, we like to help. We want to be part of the solution. But why the 100 bed is not the story, is the paramedic stuck in the hospital is the story. Why that should be the burden the city to bear with $7.5 million and so many paramedics could be back on the road, taking the pressure off their colleague and from the neighboring municipality. Why can that be the story versus people driving by the Civic, taking a picture, send it to me, here's the 24 ambulances waiting at the Civic site to offload. That's what's been played in the media. And the municipality is picking the slack, and my community, I have to tell you, if you see the number, the average, if the number looks good for the urban core, I have to tell you, it does not look complementary to the rural area. But I don't want to take the discussion just area specific. This is all of us as a city and as a neighbor municipality as well. So why cannot that be the story, the shortage of bed, the shortage of a long-term care? This is what needs to be addressed on that level.
I completely agree with you. I mean, much like we talked about when I was last at your public health board with Councillor Egley, the system is very much integrated from the point of view of how patients flow through and how these things get twined together. Trying to do something to fix ambulance offload specifically without dealing with the system capacity issues is a patch in the short term without a solution for the long term. And so we need to do this short-term piece to make sure we keep the risks that Pierre highlighted very much mitigated while we build the capacity on the other side, because not unless two factors, not unless number one, the population and the incidence of disease decreases and the number of people requiring care decreases and the growth in the population decreases. This is very much a capacity management piece. And I think I heard in Pierre's presentation the number of investments that have to be made based on the growing demands. If this city continues to grow, this is about a capacity management issue of how we grow beds and capacity and ambulance capacity if more and more calls are made. So we've got to find the right balance in that. But in the short term, we've got to put in some short-term measures to deal with the risks that that your committee, or in particular Pierre and Tony, are dealing with, while we continue to build the bed capacity that allows us to give us a more sustainable solution. And that's in essence what we've been trying to do, quite honestly, over the last couple of years. But you're absolutely right. The issue of ambulance offload is a symptom to a bigger problem, and it should not be the focus of the discussion. It should be the discussion on the capacity in the system we need.
Okay, thank you very much. Thank you, Madam Chair.
Thank you, Councillor El-Shantiri. And the next is Councillor Fleury.
Merci, Madame la Présidente. Merci à Monsieur le Duc et puis à tous les PDG. Je vais débuter avec vous, Monsieur le Duc. Je pense que des trois hôpitaux, vous êtes celui qui performait le mieux, donc une situation intéressante aujourd'hui. Mais il manque un quatrième PDG, puis ça, c'est celui de CHEO, qui, quand on regarde statistiquement, CHEO semble avoir la cote pour le processus. Moi, j'aimerais comprendre de votre perspective, qu'est-ce que nous, au niveau des services paramédics, on pourrait faire dans la situation actuelle pour vous aider? Puis, si vous étiez dans notre rôle, nous, on est des élus, mais on est un petit peu le Board of Directors des services paramédics. C'est notre service. On est le conseil d'administration. Si vous étiez dans mon rôle aujourd'hui, qu'est-ce que vous me recommandiez? Parce qu'on se retrouve dans une situation un petit peu inconfortable, je dois vous avouer. Vous êtes en mute. Je vous vois parler, mais on ne vous entend pas.
Merci, c'est pas la première fois que ça m'arrive. Merci, conseiller Fleury. Alors, j'ai pas personnellement, on n'a pas revu les trois PDG des hôpitaux, les données de CHEO pour pouvoir, en tout cas pour ma part, être capable de comparer puis de commenter à ce moment-là sur la performance. Dans votre rôle, je pense que l'appel à l'action qu'on vous dit, c'est de... Nous, on s'engage à collaborer avec l'équipe de paramédics pour trouver des solutions à ce problème-là qui nous tient à cœur. Je ne veux pas que vous ayez l'impression que ce n'est pas important pour nous non plus. De travailler à ce niveau-là. Mais je pense que c'est encore là, si on peut faire des représentations conjointes, la ville, les hôpitaux, pour justement obtenir plus de ressources sur la capacité pour nous de pouvoir décanter les patients qui n'ont plus besoin de soins aigus maintenant, mais qui ont besoin d'autre chose comme hébergement que de retourner à la maison, soit avec des supports, pour qu'on puisse augmenter cette capacité-là. Je pense que c'est là probablement qu'on aurait le plus d'impact sur notre solution. Présentement, on travaille sur des solutions alternatives qui vont être temporaires pour 12 à 24 mois en relation avec la pandémie. On ne sera pas en période de pandémie tout le temps. Je pense que quand on va traverser la période de pandémie, on va se retrouver dans une autre ère où là, à ce moment-là, on va avoir la capacité de sortir des patients de l'hôpital puis de nous aider. Mais on a encore, pour l'instant, besoin de solutions temporaires et on travaille à tous les jours là-dessus. Encore là, si on a besoin de l'appui de la ville, de votre comité pour faire l'argument, les présentations, ce serait de pouvoir faire le démarchage avec nous.
Oui, regardez, c'est une situation particulière. Moi, je ne suis pas sûr de notre responsabilité face à ça. C'est une situation un petit peu unique. La province nous donne des fonds pour gérer les paramédics. On a un montant d'argent qui est attribué aux paramédics. Puis de l'autre côté, on se retourne de bord pour... On se retrouve en situation d'aller voir la même poche, là. Parce que nous, si on regarde juste statistiquement, on aurait besoin de 66 nouveaux employés au niveau du paramédic, plus les véhicules, juste pour répondre à l'attente dans un hôpital. Il y a quelque chose qui ne marche pas dans le système. À un moment donné, I'll switch to English because I want the other CEOs to jump in here. the city of Ottawa is comparable to the Ottawa Hospital. We have, give or take, the same amount of employees, around 15,000 employees, give or take. I might be off a few hundreds. If a situation happens, we shuffle. I mean, your groups have had to shuffle over the last number of months because of COVID. I don't understand why we can't see the same type of service reallocation and resourcing for this particular issue. In the same vein, the city of Ottawa does when there is floods, when there is, when there are tornadoes, when there are, if there were a massive power outage, we adapt our workforce and align it to where the emerging risks is. So I guess that's where I'm conflicted, and I don't understand why such a large organization that does great work, don't get me wrong, but can't reshuffle a priority of FTEs and resources to address this particular issue. Sending local elected officials who are board members to the paramedic service, addressing a hospital issue, that to me is going down the wrong path. We own the response in the community of picking up the emergency call, driving the individual and stabilizing them to get to the hospital. After that, that is in your wheelhouse. And you know, yesterday we were in council, many council members they say to us on different topic, stay within our bailiwick, make sure that whatever we have to do at the municipal level, we do well. And that stops when we show up at your door. So it's not that as a resident, I don't advocate for better services of the Ottawa Hospital, but I don't think it is our role to lobby with you for additional resources, because ultimately you're a very, very large organization. So I don't buy the numbers. And I have to say, we're a growing population, we're an aging population. So the numbers growth you're seeing and the adaptability you've had to do, yeah, it doesn't take a PhD to realize that. I think it's pretty obvious that and people are less healthy. We have a lot of situations in our community. I come from a small health background, not like you. I come from community health, sport health, and we see a lot of the risk factors in communities. And I don't understand why it's like oh, yeah, well, we have high numbers and you have to uphold that problem. I don't understand that. I don't buy that. So explain to me why, with such a large number of FTEs, you can't dedicate the resources right at this point to respond to this issue that we have.
So I think, Matt, it's a fair question. I think the one differentiator for hospitals that other businesses don't have is we can't close the emergency department to control intake. The intake through an emerge is continuous and is growing. And number one, we'd never do it to begin with. But the decisions we have to face if we're going to have to reprioritize, do we cancel surgery and slow down the ORs? So now the wait time in terms of access to things like cancer surgery, eye care surgery, those types of things. So we can do that. We can reallocate staff, but it creates another risk on the other side. The bedded environments, I can't just close beds and not provide care to the 250 people that should be in long-term care just because it would be good to move those staff. So if I've got a growing population of beds I have to manage that are not the responsibility of the hospital, but are the responsibility of the system, and I've got an intake in the other end I can't turn off, and I've got a surgical population that if we do ratchet it down, we're going to increase the risk of morbidity and mortality for our population. Those are the factors that we're dealing with. If we could close the emerge and just have it stop for 6 months, I would agree fully with you. But I think you agree with me that that would present a massive risk for this community in terms of what are we doing for emergency care access. So as the population grows, if we have a fixed capacity, we are into deciding how we move things around, not unless we just, we can never ignore budget, none of us can, but we have added hundreds of thousands, if not millions over the years to add capacity in spots of places where as an acute care tertiary center, we're not necessarily budgeted to manage that, much like you're not budgeted to manage ambulance offload. So it goes back to my very first point that I think it was Councillor Egley that raised, is if we can create the capacity in the community, I unequivocally can tell you, we have of our 1,000 beds and 15,000 staff that we hire to deal with acute care, If we don't have to manage the 250 that are community-based care, we don't have an issue, or the merge volume drops. So that's the big difference. In the city's case, when you reallocate, you don't keep the business running and you just keep doing it. You reallocate. Our challenge in a hospital is we cannot reallocate without a significant consequence in terms of impact to care, which we will not do. So those are the factors that we're dealing with on how to manage it. And that's why we're constantly trying to get additional capacity built in so we can get our surgical backlog through and not compromise care that way. Not close beds and help our long-term care sector, because the care of the elderly is absolutely critical. And at the same time, try and grow capacity in our emergency departments to help Pierre and team get out of the building as quickly as possible to get back into the community. And it's a constant movement of discussion. And thankfully, as a community, particularly with Pierre and Peter and team, we've done a lot of great work together and we'll continue to do it. But that's why we keep pushing on. We've got to build capacity in this system.
If I may, Mrs. Chair, if I may, I would like just a few comments also. So first of all, we saw what ramping down and shutting down all activities for four months when we got into the pandemic as consequences in terms of backlogs and increase in patients coming to hospital right now that delayed access to care. So we fully understand the issue about that, and we've lived it right now. So we're trying to recuperate. But even as we're trying, none of us is higher than what they were before COVID. So the backlog is still continuing to build in terms of procedures and cancer care. The other piece to your point, Mathieu, is that Councillor Fleury, is that we've shown that it's not just a human resources. I think both of us, and with great collaboration from the city, providing space for us to deploy in the testing center during COVID, shows that we're capable of ramping up and getting the health human resources, but we have the space where we can do this. We couldn't have done the assessment center within our own hospital. There's no just physical space for that. But with great collaborations from the city, the paramedics and stuff, we show that if we have physical space and capacity, so it's not just the health human resources, we're able to hire, deploy, and make things happen. Right now, the bottleneck is like our capacity to have patients in beds. Right patients, right bed, right time.
Yeah, but it almost feels like, I have 2 points back, I guess. To me, it feels like today we're talking 100 beds, we'd fill these 100 beds and then we'd start a new pressure point. So that pressure to me is constant. It never goes away. As we're a growing community, it's a false hope to try to, today we go to the province and fix 100 bed because next month it's a different number, or next year it's a different number, or 5 years from now it's a different number. So that from my perspective, but I'd love to hear from you on, you're saying, hey, we have 250 residents here that we're offering care that we think should be, there should be services in the community. And I agree with you. I don't understand why hospitals don't play a role in the community to fulfill those services with community health and resource centers and other health partners. So maybe you can allude me to that. You've identified a pocket here of, a number of residents that could be served in the community. Why aren't they?
So I think, it's a very good question, Councillor Fleury. And I think that's part of the province's direction around Ontario Health and Ontario Health teams, is how do we integrate care between community and hospital? If you look at long-term care centers, there's 28 homes in Ottawa. Hospitals have traditionally had zero affiliation other than the transfer of patient. The city runs some, 3 of the primary extended care runs some, Rivera runs some, all the community association, the community health centers. Hospitals have typically never played a role in running, either not running them, but working closely with them other than how we transfer patients to them. I think part of what you've seen through the pandemic is both the hospitals and the community coming more closely together to make sure the long-term care centers that have gotten into trouble to some extent, the hospital's been trying to help to make sure we don't close those beds so we can get patients transferred. I think over the course of the next number of years through Ontario Health, we're going to see a lot more regional system planning, which we need, because the point you made a couple of minutes ago, and I completely agree with, part of this is creating a health system plan that manages the growth of this community and not just doing it in a reactionary state that when we run into a problem, we try and add capacity. So there's been lots of planning studies where we know we need more beds. And I think that's part of the government's plan to add those 10,000 beds. But what's the plan? When are they implemented? How are they going to run? Where are they going to be placed? The hospitals typically not played a role in that. And part of what we're saying is, look, we don't need to run this, but we will absolutely be willing to help. That's why we agreed to help with the long-term care centers. And to Bernard's point, the assessment centers, that's public health type work. It's like flu shots. But there's a real need to do this as part of the pandemic response. And we had capacity at that time. We don't now, and now we're having to ramp back up further. But it really is around a capacity plan for this community around what are we doing with post-acute care services. I don't know, does that answer your question?
Yeah, maybe the last one that I start with, and Jenna, I know my time, or Madam Chair, I know my time's off, so that'll be my final question. Dr. Love, I want to know from you, and I asked this question to Dr. Leduc, put yourself in my shoe. I'm an elected official. I'm the board of directors of the paramedic service in Ottawa. My problem or my authority is to make sure that we respond to what we have to do within our provision. What do you, if you put yourself in my shoe, what do you say today? And what's the fix to this issue?
Support both what Tony and ourselves are trying to put forward to the government to add beds and add more money into ambulance offload. Very simply, here's what I'm pretty sure on, and not being a statistician, if we don't build and add more beds into this community over the course of the next 5 years, and our population continues to age and grow and the incidence of disease climbs, this problem will get worse. And so we've got to, as a community, build capacity around those beds, support the government in the direction of adding these beds, while we put in process changes as a group with Pierre and Tony to try and deal with a short-term transition. And so if I had to give you one answer, Matt or Councillor Fleury, I tell you, we have to continue to put forward strong positions around adding that bed capacity that allows the system to flow.
Okay, thank you. I'm tough on the COs as a of the no, but I want to clarify. This is not about your work in the hospitals. You guys do tremendous work in hospitals. I'm here as a board member of the paramedic service, really concerned about the relationship and the pressure we're faced. So don't perceive it any other. No,
I appreciate that. Yeah, thank you.
Thank you, Councillor Fleury. So next we're going to go to Councillor Meehan, but as I'm passing over, I'm going to ask Vice Chair Aglai if he can take the chair seat for a few minutes.
Happy to.
Thank you.
Councillor Meehan.
Thank you very much, Chair. Of course, I'm going to unmute and then my dog starts barking. Can somebody else take my place, please? I'll come back to me after.
All right. Well, next on the list, I believe, is Councillor Kavanagh.
Well, thank you very much. It took me by surprise there. I thought some of the committee members would be asking questions first. Thank you. So I've got my mouth full. Thank you very much. I'm just going to follow up on what got started with Councillor Fleury. It's pretty evident that there's a bit of a domino effect here in all that's going on. And one of my big concerns is long-term care and the strain it has put on the hospitals. You were talking that was not much of a relationship before, but now it's kind of, I don't want to say forced upon you, but it's a very necessary step that when you were assisting with the long-term care facilities, and that's obviously put a strain too. I'm very interested in what you were talking about a regional approach, and I'd like to hear more about that, because clearly that's something we have to look for in the future, because long-term care isn't going away. It's obviously part of the backlog that is affecting the paramedics as well. If you keep going back a step, why those beds are being occupied, because people don't have someplace to go. And it certainly concerns me, and I'm certainly concerned about the standards at the long-term care facilities, because that's part of the issue of what putting the strain on the system. So I'd like to hear from you about that, because obviously, this is Mr. Love. I'm sorry I didn't address it, but it's definitely something that we should talk about because it affects us as a city.
Maybe I can start, and then Bernard has had equally the same experience, so maybe Bernard can jump in as well. So just a couple of comments in terms of this. You know, the reason we came in to help was because of the pandemic, and you're really dealing with a virus that causes significant acuity within patients that long-term care is not accustomed to dealing with, because there's some tremendous staff and leaders within long-term care within this community. I think there's two things. The way I'd answer that is, one, traditionally long-term care, it's not that the hospitals haven't worked with them, but our work with them is to transfer patients to them. Yeah. Part of what we're now starting to talk about is the way the patients that we used to admit to long-term care 25 years ago versus the patients we admit to long-term care today are dramatically different in terms of the acuity of the population that's in a long-term care home. A number of them have a number of illnesses that if they're not, if their medication isn't managed properly, if the care is not there, then they just get readmitted back to hospital. So part of this work through the pandemic that's evolving is twofold. One, how do we work more closely with the long-term care sector to make sure that the support they may need from acute care to manage the quality of care within the home, we continue to help with and try and support that evolution of that model. And then the second piece is unequivocally, we could easily add 1,000 beds over the next 2 years as a first phase. And so where do we build those beds? How do we add them? Who's going to run them, and what the model is are two pieces we have to work with that sector. And this is happening all across the province. And what we've said as hospitals is, look, if that support is needed and knowing the impact it has on the health of the population, we're more than happy to help, even potentially looking at building and operating a home ourselves as part of additional capacity, but within an integrated model, so that whether you're in West End Villa, Laurier, Carlingview, choose any of the homes, we start to standardize the model of how the long-term care sector operates based on the types of patients they're managing within the home, which is really the quality of care angle of this.
Okay.
So I don't know what, Bernard, whether you want to add any more to that.
I guess I mean, the pandemic has actually put into perspective some of the flaws of the system and long standing. This is where there's a provincial commission looking at that right now. But I guess for us, the positive side of getting involved with long-term care right now is we get a better sense of, the issues and the challenges that they have. Our issues right now is just that they're basically not admitting all of the beds that were like 4 patient or 4 residents in long-term care can go higher than 2. So again, we have patients that should be admitted that possibly when we get out of this pandemic with a vaccine or something where it can go back to normal, we'll have that capacity now that, like I think Cameron said, that there's like 800 beds in the whole Champlain area that's actually unavailable right now. It's like closing 5 or 6 long-term care beds while we need them the most.
Okay. So you're looking at building more of a relationship, a stronger relationship. I mean, the idea that a hospital could run long-term care is quite fascinating. I think people would appreciate it, given what's going on right now, to make smooth transitions. I know we're not talking about paramedics directly, but I do believe this all connects. This is part of the problem, if I may. This is something that's blocking the flow, as it were, of patients, and clearly the workload is heavier with the number of seniors, as was pointed out. It's something that's happening. I had someone ask me, and I'm just going to throw this out at you in terms of in terms of the emergency room backup, and the fact that people are waiting for hours. I've had to witness it myself, unfortunately, with a family member. And it's, in many cases, it's known that they're going to be waiting for hours. They're even told that. Is there any way, if they have someone with them, that they can have paper signed where they can not just crowd up the waiting room, but to be called back is apparently this is something that's done for long-term care for, just someone who's takes responsibility for the person. This is obviously not for something that is severely acute, but something that where they're already being told they're going to have to wait a number of hours. Does that make any difference in terms of helping with the backlog? Is that something that's considered? I don't know if that's a liability issue or what, but just want to throw it out there.
So maybe two comments, if I understand the question, Councillor Kavanaugh. So with respect to long-term care, we are trying to put in processes where we send care teams to the homes instead of sending them to the emerge, so that number one, it keeps them out of the emerge, and number two, and most importantly, we provide more enhanced care within the home environment for those that may have an acute episode. So whether we use nurse practitioners or there's a number of family physicians involved, that's part of the model discussion that I mentioned before. We're starting to provide some of that support to help the homes in terms of the care of that population. The other piece I think you're referencing is, if you look at, I'll use the Civic just because I know our place so well. On any given day, we may have 300 emerge visits. And of that 300, 15% will get admitted. So that means 240 are coming in and leaving. There's a large portion of them that'll come in as walking wounded. You saw Bernard's numbers before, the number that come in by ambulance. But for those that have come in that have very minor acute symptoms that need management, part of what's being looked at is number one, there's the whole primary care system, and how do we work with that system in terms of them coming to emerge? Can they be supported by primary care, which is an ongoing evolution? But there's other things that are being looked at as to whether we can deal with rapid access clinics where you move them out of the emerge, they have them come back the next day. Because for a large portion of that population that comes in, even if they needed sutures, can they be moved to a clinic outside of the emerge? So a number of us have started in a process around taking a look at how do we decant some of that activity, because while we've got an ambulance offload issue at the front, at the rear of the building, at the front of the building, you can have a 3-hour wait for people that is quite challenging, particularly in a time of COVID when we're trying to keep everybody socially distanced.
Yeah.
So part of these are strategies on how we decant people out of the emerge and prevent them from coming to the emerge. And that, we've done a number of things over the years. What I will tell you unequivocally is what I'm very confident, and this is all hospitals, and I think it's a tremendous reflection of how good the emergency management teams are, whether they're docs or nurses. Anybody that is truly sick never waits. We have people coming in the front door that are sicker than those coming in by ambulance, and they will get the same rapid triage and access to care. It's the ones that Pierre references that are the CTAS 4s and 5s. How do we create alternate mechanisms? So that allows us to decant the emerge and get care to them in a different manner. And so I think that was your question, but that is very much part of this remodeling.
Yeah, it's diverting those that can wait, and if there's and the triage is obviously very important. But it's, and you make a good point about COVID. They're all sitting around with each other, and it would be great to, prevent that. While I have the floor, as it were, I would like to give my congratulations to Pierre. I wanted to give him a special shout out because he's the one that we worked with very, very closely during the flood. I think I called him, hourly and certainly at some points. And he did a great job. He's always calm. And it was the voice of somebody at the other end who got it and understood what the situation was. So I just wanted to give him a shout out, and to the acting chief, Mr. Kelly, thank you for all you've done while filling in that role. Obviously, it's a huge one, and you've done a great job. But I had to mention Pierre because I got to know him very well. He was on speed dial. So thank you very much.
Terrific. Thank you very much, Councillor Kavanaugh. Before I move on, I do want to just pick up on a comment that you had just made, Cameron, and you had just said anyone who needs urgent care doesn't wait, which I appreciate in the context of the hospital. But I think it's important we bring back to committee responsibility here in the discussion now, our responsibility around response times. And so 100% respectfully agree, once you're at the hospital, nobody who needs urgent care is waiting. Our responsibility, again, focusing on those in the community that need that care and the code zeros. I just want to pivot back to that, because I think, you know, that's our responsibility to make sure that that is being addressed. So just wanted to raise that, and happy to take a comment if you'd like to make one.
Yeah, I couldn't agree more, Councillor Suggs. And I think, not knowing the EMS data well, but just watching Pierre's presentation, I'd suggest, just by looking at that one table at the beginning, that Pierre's team is doing a tremendous job of triaging, because the CTAS 1s and 2s, if I saw it correctly, it was 8 and 10 minutes. It's like high 90% compliance of achieving that, which means they're doing a tremendous job of triaging those, getting to those that are most acutely ill. Not unless I was misreading that data, but it doesn't take away from the fact that ideally you want all compliance in all times, and the zero piece that you reference, we shouldn't be having that.
Yeah, agreed. And staff can clarify if I'm correct, but the 2019 report showed for CTAS 1, if I recall, it was we met it 75.1% of the time, and the target was 75%. Is that correct, Mr. Duante?
Yeah, I'll let Chief Poirier, and in fairness to Cameron, I think we've talked to committee. Our response to the call is one thing, and then CTAS is only after the paramedic does the analysis. But so it's not quite what Cameron said. But I'll
Okay.
And that's fair to him, because he's not aware of that. So I'll let the chief talk to that.
Yeah, thanks for that. Yeah, thanks for that. You're correct in terms of the CTAS numbers and our ability to meet our performance targets. But in some ways, I'm not sure that that's actually the overall issue that we're here to deal with, in terms of the number of patients who aren't receiving the service that they request. And I go back to Councillor Luloff's comment with respect to the availability of that next ambulance. And the second piece is, Chair Suds, is that when we talk about the 90th percentile, that is an agreed to benchmark that's been put forward by the province, and if you look at the graphs that were put forward by, I think it was slide 5 or slide 6 from Cameron Love, it shows that the 30-minute benchmark is not being met, and it's consistently not being met. I think we have to take a look back at that issue, and go back to Councillor Luloff's comment with respect to the actual ability for us to meet that next call for request, or that next request for service, which is the most important piece there. That when paramedics, 25 units, maybe at the civic hospital, whatever the number is, we don't have the ability to respond to that next call. And I think the narrative that Councillor Luloff presented was really what goes on a regular basis when we have level 0, is that the stress, that ability to feel like you're left alone and not being serviced by your community is really something that's disheartening. And so that's kind of where I go back to Councillor Luloff and stress the importance of his narrative and his personal story, which reverberates through the community, that we aren't meeting the needs of the community and things have to be done. So, I'll stop there, and thanks for the opportunity to provide that comment, Chair Suds.
Perfect. Thank you very much, Chief. And we will come back to staff as well for questions. So as I'm sure some of my colleagues have questions as well for you. Okay, so I am going to go back now to Councillor Meehan, and following Councillor Meehan is Councillor Deans.
Thank you very much, Chair, and I do apologize for that interruption. It's like Murphy's Law, right? Gentlemen, thank you very much for appearing today. I think we're all and looking forward to finding out exactly what you're going to be doing to mitigate to us is a extremely, extremely serious problem. This has been going on for a decade, and I have utmost respect for our ambulance service and the paramedics, and especially the management of paramedic service. And we have been in discussion with them for years about this ongoing problem. And I believe them when they say that they are doing everything in their power to make it as easy as possible to offload a patient at the emergency department. I know they have. We've got the figures. We know how much we have spent. We know what this is costing the city. What we don't have is a solution from your end. We are upholding our role. The problem is with the hospitals and the emergency department. And long-term care beds, all that is really not our issue. What we have to figure out here is what you're going to do to solve this. You say that you don't have the beds. Well then, let's get the beds. You need a nurse? You've got a large institution? Why don't you hire that nurse? Or, you have to figure out the solution, because whether a paramedic stays in the emergency department waiting a half hour or 2 hours, that patient is eventually going to be absorbed somehow, so over the course of the day. So we're asking you, the pilot project is a great initiative. And I'm wondering why it's coming about at this particular point. Did it take COVID for us to act on this? But we want to know what you're going to do now, because it's unacceptable that we have people waiting at home for an ambulance, and it's just a matter of time before somebody dies. So I'm putting this back into your hands. We want to know, why can't you put what is essential in those emergency departments to let our paramedics get back on the road? That's what we're dealing with here today. So I'm putting this into your court. Tell us what you're going to do, not what the problems are that is preventing the ambulance from moving on. We're doing our part. Now we're asking you to do yours. I know you say it's not that simple, but it's simple. We need our paramedics back on the road.
And I can appreciate that, Councillor Mayhem. And I think we've outlined at the beginning what we're planning on doing. So the reason we haven't done the zero offload is because we haven't had the funding, nor have we had the beds. It's as simple as that.
How much are you requesting of the province right now? You said there's a funding request in.
So we have a funding request in right now to add the beds that we're adding. It's going to be, if we just deal with the ambulance offload piece, it's probably in the $4 million range. That's what's currently being requested to move forward with. And I do think we're going to get that, because we are getting these beds approved. So, while I agree with you, there are elements here. So look, I'm not going to disagree with you. You can put that onto us, and I'm more than happy to say, look, we have a responsibility. I'd argue that I'm not so sure we have the responsibility to manage the entire system across the board, but there's also a responsibility for all of us to come up with surge plans when the system's congested of how we all surge, which is a joint responsibility. So at the end of the day, if we are in periods of time where we've got 20 ambulances at the Civic, none at the General, some at the Mulford and Queensway, it's EMS's responsibility to transfer them to other sites. It's our responsibility to help offload them more quickly. And from a financial perspective, if I can hire a paramedic and staff 4 stretchers with 1 paramedic, we have to look at staffing models across the board. So there's joint responsibility everywhere. And that's the process that we're looking at doing with offload, that if I'm going to take 4 into offload, I will staff them with 1 nurse, not the staffing ratio that we have today. And so there's responsibility everywhere for all of us to surge and create capacity across the board.
We, as a paramedic service, are fulfilling our part of that system. Our role is to respond to an emergency call and get them to hospital as soon as possible.
Yeah.
We are fulfilling that role. We have been staffing your hospital emergency rooms with paramedics to the tune of $7.7 million. That's 64 FTEs that we have been providing you. That hasn't cost the hospital anything. So now it's up to you to figure out how you're going to take on that role.
So would you agree, or do you think that the hospital should be responsible for all healthcare, including the community care?
That's not what we're talking about, Mr. Love, with all due respect.
Well, it is in part
No,
because
we are doing our role. We can't do your role.
no, but our role is to make sure that once they're in the building, we provide proper and safe access for emergency care and surgical care. And I can tell you
that's not what you're doing right now. That's
Oh,
not
yeah.
what you're doing right now. You're holding up our staff from doing their job and potentially saving lives. Your role is to take those ambulances, take the patients as quickly as possible. And you have to do whatever is necessary to get that ambulance back on the road. So if it requires a nurse, it requires a doctor, you guys, you know what the issues are. You know what the issues are. These are not new issues you've been dealing with for over a decade. And I know our paramedic service people, they know that we have been told that you have been dragging your feet for years on this. And we're only starting to see some movement now. So I'm glad to see some movement, but this has to be you. This is in your ball. This is in your court. You've got to come up with the staff and you've got to get the funding in place to take those ambulances and make sure they get back on the road. Because we don't want to be sitting here in this meeting eventually in a year's time and talking about deaths. And that's what we're looking at in the city. The issues that we're facing right now are not new. They are not new.
Councillor Meehan, thank you. I feel your passion and obviously share your frustration. If we could give Mr. Cameron Love a moment to respond.
I shall. Thank you.
So I don't disagree with you, Councillor Meehan. I don't think I need to repeat everything I've said. So we've got some initiatives in place to try and offload. What we will never do is for those patients that are coming to the hospital to prioritize and triage them. That risk strategy we will never decrease, and we will continue to try and work with you and the government to get more capacity so we can offload them. But if your question is, can we close down the service at the hospital to reallocate staff to offload patients, which is in essence what you're saying, hire a nurse, put all the staff in place, and make sure ambulance offload is a top priority. It is a top priority, but it is not the only one from the point of access to care for this community. What we will not do is we will not cancel surgical services for patients that need access to that care to deploy staff. What we have to do is get more investment, ramp up, so we can help Pierre get everybody out. And that's exactly what we're trying to do.
Then do it. We're not asking you to close down services and to triage to the detriment of people who need services. That's not what we're asking. We're asking put in place the services what is essential in the emergency department to allow our paramedics to get back on the road. So
that's what we're trying to do with government in terms of getting those investments approved to move forward.
Okay, we look forward to seeing some movement on this. Thank you.
Mm-hmm.
Apologies, I was still on mute. Thank you, Councillor Meehan. I just want to ask a quick point of clarification before I go to Councillor Deans. We're hearing a lot about beds, and I struggle to get my head around why this is about beds, and I appreciate it's a complex system, but why can't hospital staff not monitor a patient in ER or multiple patients as they're being brought in by paramedics until a bed is ready? Sounds simplistic, but.
So I think if you have, it is a simplistic question. I'll try and provide just a sort of a clear, if I've got 20 nurses in the emerge and they're staffing 40 beds, and now they've got to staff 60 because we've got a bunch of additional people in, it comes down to trying to get the ambulance offload with that number of staff, or ramp up the number of staff, which is in essence the investment piece of trying to grow that service. And to Bernard's point, if we have to accommodate another 20, we can't run them all through the hallways all over the place. It's trying to create the physical capacity to allow for the offload. And I think that's the challenge. Our emerge departments were built, if I look at our civic emerge department, we have 50 bed spaces. If I've got 30 of them every morning occupied by patients that should be on the floor, but I got every bed in the building open with 200 that should be in the community, any patient that comes in that requires a bed has to go into a hallway, and I've got to ramp up staff. And so all the things that Bernard and Andrew said at the beginning in terms of that context, we add that, we're trying to add that capacity in to add basically more bed space to our emerge department.
Okay, appreciated. I'll go to Councillor Deans now.
Okay, thank you, Chair Suds, and congratulations to you, Pierre. I'm very happy to see you lead the paramedic service. And thank you to the 3 CEOs that are taking your valuable time to join us today. This is an important conversation that we've been wanting to have with you. And I know you're hearing the frustration from the committee members. This is something that's gone on a long time. So you're going to hear that frustration, but ultimately I think what we want to do is advance a solution. And to you, Mr. Love, I want to tell you that I've spent a lot of time at the Ottawa Hospital in the past year, unfortunately. And I was one of those cancer surgery patients that you talk about. So I know what you're talking about. I also have had quite a bit of time to observe what's happening in the emergency rooms just by virtue of having been in close proximity. And I have to say it is frustrating to see all those ambulances parked outside the emergency room and see all those paramedics inside the emergency area just waiting. They look like there's a lot of idle time. And it's frustrating when I look, I'm the former chair of CPSC, and this issue has gone on for well over a decade. We started the nurse offload program in 2008. This is not a new issue. It's an issue that has been unresolved for far too long, and it's costly. And I was listening intently to what you said, and I heard what you said about, putting patients at risk. Well, the people that oversee the paramedic service, we too feel that we are putting patients at risk with this. When we get to 75.1, and by the way, we lowered those standards. Under the Fitch report, you may recall, our percentile was 90%, not the 75th percentile that we used to make. Now it's 75 and we're just barely there. And we have made huge investments into the paramedic service. It's just, you hear that sucking sound because it just keeps taking more FTEs and more money, and we're not getting anywhere. These issues are perennial and they're systemic. And I understand your issues with long-term solutions, which makes a lot of sense to me, but those aren't going to happen tomorrow. And yes, the municipality, of course, would be willing to do what we can to help. But in the short run, we need short-term solutions that is going to free up our paramedic system to serve the community that we need to serve. And like, we're the meat in the sandwich. We get a lot of grief from outlying municipalities because we're taking their paramedic service. We don't want to do that, but we get stuck at the hospital an awful lot. So I understand, and you can correct me if I'm wrong, but my understanding is that there is a nursing shortage that's part of the issue as well. But when I say to you that I see those paramedics and there's one paramedic per patient there, I understand if you were to hire paramedics instead of us, that there could be more than one patient per that paramedic in the hospital system, but we aren't allowed to do that in the paramedic system. Is that correct?
I'll have to defer to Pierre. I think the short answer is yes. So we are in the process of hiring paramedics, and instead of staffing an ambulance offload 2 paramedics to stretcher, we'll staff 1 paramedic to 4 patients. So there's an opportunity to change this model. I think there's limitations in terms of what each organization can do, but we are in the process of starting to get paramedics organized to get hired, so that as we ramp up this ambulance offload piece that I mentioned, I think it was to Matt for Christmas, to try and get rid of this with this zero offload program, we will bring in those paramedics as part of staff. So that model is being developed now, and we're trying to get some hired.
Pierre, did you want to add something to that? You're on mute.
Sorry about that. And thanks for the question, Chair Suds and Councillor Deans. That is a possibility. and it is possible for the hospitals to hire paramedics. And this has come forward recognizing that the difficulty in attracting nurses. There are paramedics in the community across this province who are looking for employment. So that is one of those options that hospitals can engage or hire paramedics to provide that service. And recognizing that that would be something that the hospitals engage in. And the paramedic service here in Ottawa, we would support that. Whatever helps get our paramedics back in their ambulance and back in the community. So thank you for that.
Okay, and so Mr. Love, can you maybe go over each of the hospitals, how many paramedics you intend to hire?
You know what, we just started this last week in terms of that model of we're going on the assumption that we have to have at a peak period, we'll get maybe 12 ambulances. I'm always speaking of the Civic, 12 ambulances in offload. So we're trying to create a staffing model that whether it's 1 or it's 12, we can take them all. And so we're hiring the staff up to that level with the understanding that if it's 1, we got to find work for that group to do. But if it's 12, we can take them all away. And if we can get that model in place, run that for December, that'll dramatically improve the Civic, which is the trauma center that has the most ambulances. If it works well and we can get it and we prove that, then try and get funding to do it at the other sites. Now that notwithstanding that we are also putting in a space plan where we're going to create upwards of another 15 beds somewhere in close proximity to emerge, because we got to put these people somewhere. So that's what we're trying to put in place to be done by December. And I think we'll see a massive improvement at the Civic. And then if it works, we've got to look at the general Queensway and Mulver. Queensway for sure is also doing a similar type of approach. The West End tends to have more volume ambulance wise, I think partly because of the differentiation of population, but the Civic in particular, because if you've got a severe stroke or a major trauma, it doesn't matter where you are in the region, you're coming to the Civic. So that's why to start with that site.
And will this program at the Civic be 24/7?
Everything we do is 24/7. Yeah. Okay,
good. Then the numbers that Pierre put up in his presentation seem to indicate the visits to the emergency room were higher at the general. Is that not the case? Or they are higher at the general.
Yeah.
So how long would it take for the general to follow?
If we can get a funding model approved, it's probably about a 2 to 3 month run rate to get everything organized. The Civic gets more ambulances by virtue of we've got the Heart Institute, neurosciences, vascular, stroke are all at the Civic, which tend to be your most acutely ill people in the community that generally come by ambulance if they're in an emergency state. The general gets a lot more walking wounded coming in that have exacerbations of various diseases, and that tends to be our cancer site. So you get more volume, but you get less ambulances. So we have less admissions.
Okay, and what are we looking at in terms of dollar amounts to get this program up and running at all of the emergency rooms in Ottawa?
That I don't have that number. Bernard, I don't know whether you have it for your site. Part of this, Councillor Deans, is we focus strictly on getting the Civic because we've got good support for it and get it off the ground. And then we'll extrapolate those numbers and be able to give you a number as we head into last quarter and get the Civic up and running.
Okay, because we really, you've heard the frustration of my colleagues this morning. We need to see some movement. We're concerned about the risk that we are putting our residents at by virtue of getting to level 0 too often in the community. And we see this as a key element in resolving that issue.
Yeah.
So,
and I do want, I think you appreciate this. We're here because we have the same level of concern. Yeah, we run the hospital. This is a big community issue. And we're going to do our part to try and improve this. This has been a long-standing issue. It's been a long-standing issue for the province. I talk to my peers; they're in the same boat. They've got different things they're doing, but regardless of what happens across the rest of the province, we have to do a better job here in Ottawa on this, and we have to play a part on it. And we've got to try and find either ways to put investment in or change this model while we build this future capacity. So we're 100% committed to improving this. But it's I'm hoping this Civic thing is going to help. And then if it does, then we'll build on that.
Yeah, we can't take another decade. This has been far too long, and we need to see some short-term changes happening now. So I think you've heard that loud and clear, and I hope you'll come back to committee again and tell us about the improvements that we see next time that you come by. So thanks for being here, all three of you.
Thank you, Councillor Deans. And I know Mr. Love has, I think, about 5 to 10 minutes left, and we have 2 councillors left with their hands up. So we have Councillor McKenney next, and then Councillor Brockington.
Thank you, Chair. Thank you both for coming to committee today. I do appreciate hearing from you. Now, I'm not going to go over all of the issues that my colleagues have, but I can't help but point out that we're talking about a service, ambulance service, that was downloaded to municipalities here in Ontario. And what I'm hearing really is that you're downloading to us on the other end of the spectrum now. You're downloading the decisions you're making around, what type of care you offer, and when I hear that, it's exceptionally frustrating. We are responsible as a municipality for public health, right? Health promotion, disease prevention. I would suggest that the $7.7 million that this is costing us annually would go a long way to that, and would actually, you want to talk about surge capacity, would actually take some of the pressure off of you. So we're responsible on this side of that equation, and we're responsible for paramedics, but we are not. The capacity in the system is not a municipal matter, and we cannot be held responsible for it. Because what I see happening here is, I think that in your response to, I think it was Councillor Fleury, you said, well, we can't just reorg the way or, readjust the way a municipality can, because it means that on the other end, we have to make decisions about what surgeries do we do, how do we treat people who are in acute care? Well, you are actually making that decision. You're actually putting that decision on us, because you're saying, city, we're not going to make that decision over here about surgeries, acute care. We're not going to do that. But we're putting on you a level 0, a possible level 0 of service. So how is that fair? I can't wrap my mind around how we can sit here today and talk about an entire system of which we have a piece of, but we are a municipality. We have the resources given to us on a property tax base. Hospitals have got, and I will credit you. I know with our new health teams, we now have a new community health team. I know you sit at that table, and I think that can be groundbreaking. So I do credit you for that. But I guess I just need to hear that you know that you have responsibility for that other part of the system, and that community care is not us. It is not us. We do not have a role. That flow to hospital, to the health system, that system-wide, it is not on us. We do our piece. There are many parts of our piece that we don't maybe do as well as we could, but we do our piece. And I just wonder what your response is to decisions around surgical care and other acute care versus a possible level 0 at times that puts people out in the community at risk that we're responsible for at that point, who have called for an ambulance.
So maybe a couple of comments. I'm sorry if that's the way I left that impression, because that's not the way I meant it. I would never expect council or the city to make decisions on the hospital's behalf in terms of what we're doing in terms of ensuring access to service. That's our responsibility, hands down. Whether we run surgery, critical care, bedded environments, that is 100% on us. I'm not so sure I'd agree with you that we've downloaded. And the reason I say that is what we're trying to do is help. So we're in running long-term care homes now. We're in running testing assessment centers. We're trying to help community health centers. I've got staff deployed. I've got physicians deployed. So's Bernard, so's Andrew. So the hospitals have traditionally focused on acute tertiary care for the sickest people. And now what we're being asked, and what we're more than willing to help because it's needed in the community, is to help long-term care, help assessment centers, help community health centers to try and improve just generally access to care. So I wouldn't suggest we're downloading at all. I'd suggest we're trying to help to as much as we can and start to play a much bigger role in these sectors to help the health of the population. On the ambulance side, I don't disagree with you. We can play a bigger role in terms of improving that. Now we don't have accountability. We don't have decision-making authority. We don't get the funding for it, but we can definitely play a role in terms of trying to build the capacity to help care and team offload. And we're definitely going to play a role with long-term care, which is our issue to deal with. While we don't manage any of those aspects of those regions, we're not downloading. We're trying to integrate and help to allow that flow to happen, which is not the city's responsibility. It's not the hospitals, but if the hospital has a greater role to play in terms of managing the health of the population. So I don't know if that clarifies for you a little bit more, but it.
No, I appreciate that. I just want to be clear. When I hear you say, ambulance offload, capacity system-wide is a joint responsibility. For me, as a municipal official responsible to, our constituency, I hear, what, you're also responsible over here. And that is, maybe download is, not the right term, but it certainly is, it's shifting responsibility to the city that we don't have. And we have held up our end of this bargain. We've invested heavily in it. It's costing us far too much money that could be diverted to other places where we would actually have an effect on your system. We would be able to ensure that there is better health promotion, disease prevention, the things that public health, recreation services, housing needs to do to keep people out of your hospitals. So I just want to be really clear. I appreciate what you've come here, what you've told us you're going to do. I think you've heard from us, frustrated. We need something to happen, but it's to you to go to the minister and tell the minister, you know what? Our system is not functioning. It is failing. And until people with that responsibility do that, we're going to be held picking up the pieces because we're the ones with the person in our ambulance. We're the ones who is not responding quickly enough when we have a level 0.
If I can just add to that, I think the other piece that has been a change for us, and hopefully gives you some reassurance on how committed we are trying to help and fix this thing, is if I look at the last 10 years, we only ever dealt with the Ministry of Health and the branch that deals with hospitals. I spend as much or more time talking to ADM responsible for ambulance services as I do the one responsible for hospital services, because they're coming to us asking, what do we need to do to invest and change the ambulance system to make sure we move ambulance offload? So we're spending a huge amount of time with that division now, trying to get them to understand why they need to invest in these things to improve ambulance offload as a different jurisdiction. So look, at the end of the day, ideally here, we're talking a year from now and I don't think we'll ever have 0 offload delay across the board, but it can't be the situation it's in now. And if we can get rid of the 0, that sort of high risk situation, and we can make some improvements to getting it closer to 30 minutes, those are the 2 main issues that we've got to get resolved. So I've had multiple meetings on them around the model for offload, the triage system, what they're doing in Toronto versus Ottawa. And we're spending as much time with the ambulance service leadership to promote what we need to do in Ottawa as I am in terms of trying to get more capacity to do surgery in this region. So it's very much a continuous effort, and our board and board chair have been very closely involved in this thing. So we are moving in the right direction. It's not fast enough, and I fully appreciate the frustration. I can tell you for our merge docs, they are equally as frustrated because they're concerned for the people waiting to get access. So I think we all share a common goal here. It's just trying to get some of these things in place and get them funded so we can make a dent in this.
Appreciate that. Thank you. Thanks for coming. Thanks for coming in front of committee. I do appreciate that.
Thank you, Councillor McKenney. So we have one councillor left, Councillor Brockington. I'm hoping Mr. Love and Dr. Bernard, and I'm hoping you're able to stay with us for one last delegation, or one last councillor, excuse me.
Oh, for Riley, for sure.
Fantastic. Appreciate it, Riley.
Thank you, Madam Chair, and good morning, everyone. I'm not going to rehash what everyone said. The sentiment is we all need to do better. We're frustrated by our investment. We represent all residents, and we're worried about their health and care, just like you are. But it's taken far too long, and we need solutions today. Okay, that's what we've heard. So my two questions, I've unloaded 8 questions. I've got 2. So one is, Cameron and Dr. Leduc, how are you going to measure yourselves going forward? You're going to institute change, because I think what I've heard is without capacity, without new capacity, we're not going to solve this issue. Even though the City of Ottawa has a list of 12 or 15 things we've done in the community to try and triage and address medical issues before we bring patients to your front door, without capacity, new capacity in the city, we're not going to put a dent in the offload time problem that we have right now. And so whether that's addressed or not successfully, how do your hospital boards measure success or progress on this? How are you held accountable for this matter?
So there are indicators that we have to report to ministry. Ambulance offload time is one of them. So we're monitoring and measuring our performance accordingly and seeing this. We're going to put more in terms of the strategies that have been put in place, hiring more staff to look at that and monitoring this and reporting. And we're reporting to our board these indicators on a regular basis. So, but I do understand, and I do want to validate the frustrations of the committee members. And, you know, we've heard it loud and clear, and we're committed to try to resolve and help that.
Okay, so here's my final question, because colleagues have asked how we can help. Is there any benefit in the committee chair, Councillor Suds, in consultation with the mayor's office, in writing a letter to the Minister of Health and or the Premier to echo exactly what your asks have been on capacity? I know we've been engaged in the past, but to Councillor El-Shantiri's question about how else can we help you, is that our greatest way to help you right now, is to complement your efforts in your outreach with the ministry on funding for capacity? Is that how we can help you?
Yeah, I think so, Councillor Brockington. And I gotta give the mayor full credit on this. That he has been doing that since the start of the pandemic. I think that's part of the reason why we've been successful in getting the beds we've got and the next iteration of what we're trying to do for the Civic. So I think once we've got that in place, we've got that implemented, I think coming up with what the next evolution is in terms of investment and having either Councillor Suds or definitely through the mayor's office, that support is tremendously helpful, because it's a community support that's required, and one as a municipality with the province to support what the hospital's doing. So I think the short answer is yes, but I don't want you to leave you with the impression that it hasn't already started, because I think the reason we've got some of these beds approved is because of those interactions and support from the mayor's office.
That's great. That's great. Thank you. Certainly, Madam Chair, when you look at this past August, we had over 50 level zeros. When you see the number of ambulances lined up and waiting at hospitals, the Civic just borders my ward. To me, it's all about risk, and we don't want people in Ottawa or even our counties whose own ambulance service is serving Ottawa residents to be put at risk because there are no available ambulances. And one of the main contributors is the offloading time at our hospitals. So we're all in this together, but you've heard today that we're very, very concerned about the risk to our residents because of this challenge. And so that's why we want to know if there's any other way we can help you address this problem, which we believe is your problem. We're here with you. So thank you for coming to face us. We really meant this as a dialogue, and we appreciate your efforts moving forward. So thank you very much.
Terrific. Thank you very much, Councillor Brockington. And thank you, of course, Mr. Love, Mr. Leduc, or excuse me, Dr. Leduc and Dr. Faulkner for being with us. I think, as you've noted, there is a lot of concern amongst myself and my colleagues here, but also a lot of respect for the important and critical work that you and your organizations do in our city. We are, although you'll be leaving us, we will continue this conversation. We have an opportunity to ask questions of staff next. But for your information, this report, the paramedic service report, will rise to council in 2 weeks. I believe it's October 28th. And I expect between now and then, myself and my colleagues will certainly continue this discussion and reflect what we've heard today and what we are hoping to see as we move forward collaboratively. So my thanks again. I appreciate all your time this morning.
Thanks very much. Have a good day all.
Good continuation of meeting. Thank you.
Thank you.
Okay, bye.
Excellent. And so now I'm paying attention to the order in which you raise your hands, I promise. And now we're going to questions to staff. And I see Councillor Fleury first, followed by Councillor McKenney.
Merci, Madame la Présidente. Premièrement, Pierre, félicitations. Déjà plusieurs années qu'on travaille ensemble, puis je suis heureux que tu, dans ton nouveau rôle. Je t'encourage fortement de parler en français au comité. C'est important pour la communauté francophone qu'aussi que notre leadership francophone au sein de la ville parle français. Donc, je sais que tu parles bien français, je sais que tu es capable, donc je t'encourage. Pour revenir au sujet de l'heure, regarde, moi, je suis intéressé de savoir votre proposition de dire que ça nous coûterait 66 nouveaux employés. Ce n'est pas une solution réelle. Puis ça, on le soulève au niveau juste de donner un coût sur l'impact. Mais moi, je veux comprendre, on est votre Board of Directors. Qu'est-ce qu'on fait là? On a évidemment une situation, un point de tension entre l'hôpital puis nos opérations. On a été très patient depuis 2015. On a pris notre part de responsabilité. Moi, je veux comprendre, on en est où? Je suis tanné de on va signaler aux provinces, on va avancer ça. Moi, je veux savoir, là, comme Board of Directors, comment on peut, toi, t'équiper et l'équipe pour qu'on puisse avancer ce dossier-là et une fois pour toutes le résoudre. Les impacts là, sur le nombre de gens dans les hôpitaux, franchement, c'est un problème de société. Ce n'est pas votre problème comme service de paramédic.
Bien, merci, le conseiller. Puis, je suis très fier d'être ici, puis d'être capable de vous en discuter en français, parce que nous autres, on représente notre communauté aussi. Au sujet que tu nous parles de notre défi, puis qu'est-ce qu'on comprend comme initiative pour travailler avec des hôpitaux. On travaille toujours avec la province qui nous donne des avis. Nous autres, on prend soin de toutes nos affaires opérationnelles où on peut faire de mieux la manière qu'on donne notre service aux communautés. So I just like to also state that we've been doing our part in the background, and honestly, we have been working with the hospitals. We speak to them regularly, and we're very much committed to finding a solution there. I think Chair Suds and Council today, you represented well the impact on our community and the
truthful part is that at the end of the day, we've done our part. And I would also say council in terms of supporting the paramedic service, that the discussion really did come back to what is important, that the hospitals take responsibility for what they're expected to do. And I don't want to get into too much detail, but at the front end of COVID, the offload times dipped significantly. And if people investigate what happened there, the hospitals were actually able to take our patients. So many things may have changed between here and there, but it comes back that it is still their responsibility. We continue to work on different initiatives to improve our service. And that is with respect to how we provide the service, but also how we work with hospitals. So I don't want to overplay the part, or I really want to remain laser focused on the idea that what many of you stated today is a hospital problem. It truly is a hospital problem. So thanks for the opportunity. Merci, le conseiller Fleury. Puis on travaille toujours à ce sujet. Puis quand je pense à tout ça, c'est toujours le défi le plus important au service des paramédics en présent. Merci.
So maybe the last question on this for me, after that, I'll just wrap up with a few comments. I want to understand, we have a percentage that is close to risk, right? The 75% that council adopted. It's sort of, we reacted in 2015, adjusted resources. I believe from the rumors I'm hearing, there's more resources coming in this year's budget ask. We'll see what that will mean in a few weeks for paramedics, which I'll be supportive of. But where do we go from here to respond to our duties as a board of directors to make sure that the targets that we've set as an organization are upheld? I want to be reassured, and I want us to reassure the community that that won't slip our minds and that we won't change the data just based on this pressure.
Chair, if I may, and I'll let the chief obviously speak up as well. Two things that you've just mentioned. The first about additional resources, and I think it's an important point. You have been, as a board of directors, as you described, very responsive to this service and continue to add the resources that were required for the continued growth in demand from the needs of the community. And as the chief presented, as a result of aging population, our growth, et cetera. So you fulfilled and continue to fulfill that responsibility. And that's the ask that you'll see. We have never, and we don't believe it's appropriate as public administrators to present to you additional resources to stave off the offload problem. I think you've fulfilled your responsibility today. You've asked the right questions to the people that can solve that, the hospital CEOs, as the chief just indicated, that yes, there's broad community challenges. Yes, there's broad issues. I think they very well and rightly so explain the complexities of the healthcare system, but fundamentally, and I think it was Councillor McKenney that talked about, you're fulfilling your end of the responsibility. So when somebody dials 911, we respond, we stabilize, we bring them to the appropriate hospital, and there the institution has to absorb that patient. So you'll never see a demand from us to ask for additional paramedics to replace those 64 that are being taken away from you. So I want to reassure you from a fiscal perspective, our commitment to you. But I think to your broader question, and I'll let the chief add whatever he wishes as well. As a board of directors, you today, not the first time we've had these discussions before, but in a different forum, they've come here. You've asked the people who can impact the resolution. And there's just one thing about my general comment about what we heard today that disturbs me just a little bit is and perhaps just the reality of healthcare. As they look at their institution in silo, there was talk about risk, and we don't want to do this, and we're not going to take this patient before that patient risk, and that's right, that's appropriate medically, but their perception and their role is within their institution, and the patient's just under their responsibility. And to some of the comments we heard, your responsibility as a board of directors and us as a management team running a paramedic service for you and for this community is the community at large. So if we were going to make a comparison, our hospital is the community, and the next patient, we need to be there for that next patient. So there's risk there that we're assuming every day, and they are using our resources to mitigate their risk, for lack of a better term. So if they've got a staffing issue, they're using 64 of your FTEs to staff their emerge. They're using $7.7 million. I don't think that's true. That's huge money. It seemed trivial, perhaps, in the broader healthcare system. So I think, to your question directly, you did today exactly what needs to be done, and I think we have to continue. Now, in fairness to our colleagues who came, they talked about this pilot. I knew they would have liked to make the announcement officially, but they haven't gotten the funding. I think that's got a lot of potential. And what that is they're finally going to staff the emerge with whoever it is, if they get this funding, to receive every patient and offload them immediately when we arrive, and we can return to the community. We can prove that to the government, and then we can say, now do that at the General, do that at the Montfort, do that at the Queensway. So, this whole talk about, patients, et cetera, it's simple. When we arrive, the patient has to be removed from our stretcher, taken by hospital staff on their stretcher. And I know we talked about the complexities of the beds and the institution and movement of patients, but in simple terms, our paramedics are there sometimes up to 2 hours, but that patient is eventually taken and absorbed in the institution today. So let's just replace tomorrow morning with a stretcher of the hospital and a staff of the hospital member. That's what this pilot is trying to do. And then we can go back and respond to the needs of our community, because we are in crisis. It is problematic, and the chief talked to it. It affects us morally, ethically, as providers of healthcare, and particularly the paramedics. As we talked about morale and other issues. We don't want to be in that position. When somebody calls in their moment of distress, we want to be able to respond, and those units are now on offload in the hospital. I'll let the chief talk if he wants to add anything to that.
Thanks for that. And I actually am absolutely impressed by council in terms of the support for this initiative, committee. And I think that one of the nuances that, and I think Tony DeMonte did mention it, is they're managing risk, but at the same time, the next call that we aren't responding to is our risk. And that's the point sometimes I think is lost, that all this talk about the CTAS and the fact that the next patient who may be a CTAS 1, the highest acuity, will get serviced immediately. The call waiting in the community may be that next CTAS 1, which isn't getting the service. So I don't want to belabor points here. I think it was a good discussion today. In discussion already with the executive with the service, we remain committed and focused on offload delay as a #1 priority. We will continue to do everything in our power to refine and to improve in our processes. But at the end of the day, when we get to the hospital, it remains a responsibility of the hospitals themselves to take our patients. So let's not lose focus on that. So thank you very much for everything today. And maybe just go back to General Manager DeMonte if there's anything that I might have missed. Thank you.
No, Chair, ready to take any more questions if you have.
So briefly, my final comments and suggested direction to committee. 2 things as it relates to the CO's presentation. This issue of long-term care feels like they were in a silo, because if they talked to Donna Gray and Dean Lett years ago, we have seen directly the issue in long-term care. I have 2 in my ward that are city-owned. You walk in, 5-6 years ago, people were playing in the rooms and out and so on. The majority of folks today, forget COVID, are in their beds. It's healthcare. So where are hospitals in planning a system-wide approach? That's where I see major planning failures to where we're at today. The second point, resource allocation. We cannot be dependent on them allocating resources. They have to uphold a responsibility that they have to residents of Ottawa, and we can't be choked to make the request that they need in terms of their beds to the province in terms of health. Those are other political discussions that are beyond us, frankly. But it is clear that we have an issue, that we have a responsibility, and that fixes are needed in the near future. So, Madam Chair, I would ask two things. One, which is, can the clerk and committee agree that this session on YouTube be sent to all MPPs of Ottawa and region so that MPP offices can dive into the extent of the conversations we've had on, one, the City of Ottawa, and two, Ottawa Hospital and CO discussions as an information item. And then two, that we directly have an ask, and that we clarify directly with those COs our responsibility and expectation in writing. Because I think Chief DeMonte related very well, we cannot be a risk level of resources that are allocated by the hospital. We can't become a de facto hospital waiting area. So what the weak point that we have now is COs have put it all out to us, and now we've bombarded them with questions. But I think it's important for this committee to summarize a memo back to them in terms of our expectation. That maybe that's something that Chief DeMonte can take away and work with you on if that's amenable.
Yes, thank you, Councillor Fleury. And as I alluded to as our guests were leaving, my thoughts around this are that they have proposed, for example, the pilot program, which to my understanding, they had hoped to be able to announce today, but have not been able to announce yet. My hope is that over the next 2 weeks, that there'll be some firmer movement, for example, on that pilot, or perhaps other items that were discussed today. So to take these next 2 weeks before we get to council to further those conversations with the CEOs, and based on where that goes, potentially bring that back to council. If it's not going where we want, then I think that there's an opportunity at council to bring forward, potentially it's a motion or information item at that time to further discussion. But I'm hopeful, as I mentioned, that over the next few weeks, we'll be able to solidify more of a plan. Is that's what they were asked to bring to committee, was what is that plan and how are they going to make a dent in these offloads?
So I'm okay with that. Are we okay to also ask the clerk to send to all MPPs today's YouTube link with context?
I have no objection to that, whether it's the clerk or whether it's ourselves individually reaching out to our MPPs we have relationships with. My preference would be that, and that I think that might be more impactful. Not sure your thoughts on that.
Yeah, I mean, I will influence them once the clerk sends it. I think it's more of a generic, like, this committee has asked you to consider the discussions that happened at today's committee as it relates to paramedic and health services in Ottawa. Just something very generic, and then obviously we can follow up with our MPP contacts if you're comfortable with that.
Sure, and I have to admit, procedurally, this is a new concept to me. Can I just clarify, perhaps with yourself, Mark, or the clerk's office, if there's any procedure there that needs to be followed?
No, in the past, the clerk's department has sent out letters on behalf of the committee or links or anything else, so that's no problem.
Terrific. Okay. I'm certainly open to that. So happy to take that direction.
Great. Thank you.
Okay. A few more hands up for questions to staff. So I'll go to Councillor McKenney.
Thank you, Chair. I just have two relatively quick questions of staff. I want to understand, because something was raised today about surge capacity, and there was an implication anyway that it was implied that if paramedics brought patients to hospitals that didn't have that that had capacity, rather than going to the nearest one, I imagine is what they were referring to, that would open up some space. Can I just get a response from staff to how often does that happen? you probably can't tell me exactly, but what would that save us from that 7.7 million? Like, how much of an issue is that?
Chair Suds, thank you for the inquiry. Currently, and for the last number of years, the paramedic service has been engaged in a patient priority system. And we've worked in concert with the hospitals to distribute patients on an equitable format. And so the general and civic receive 2 patients for every 1 patient that's received at the MO4 or the queue. What we're engaged in now is actually trying to refine that again by having a further understanding, not just of this simple distribution, but also applying a patient type to that. And recognizing that if there's a hospital that has a lower volume, that we will redirect that patient to that hospital. So it may, the event could happen where the MO4 has capacity and a patient may be coming from Bayshore, the west end of the city. We will transport them to the MO4 hospital if the capacity is there. I don't want to overplay this as a silver bullet. It's not a panacea. This is all about us refining our processes and doing a better job and working bit by bit with the hospitals on this. I don't have a financial number in terms of cost of this or of the operational impact, but it's of our commitment to work with the hospitals in refining processes. This has been in the works for the last little bit, and we continue to work on looking at the patient subsets that we can safely move from one area of the city to the other where there may be hospital capacity. And once again, just coming back to the bigger issue is that this would be another Band-Aid. This is not a cure. So this helps, but by no means is it a cure. It comes back to the original problem of at the hospital, please take our patient when we arrive.
Okay.
Thank you, Chair.
Thank you for that. That's my only question. I just want to also take a quick second to congratulate Pierre. I just want to note though that Pierre is probably one of our better dressed guys around City Hall. So now he's got to wear that uniform. So I will miss your style, Pierre. Congratulations.
Terrific. Thank you, Councillor McKenney. And next, and I think last for questions to staff is Councillor Luloff.
Thanks again, Madam Chair. I really appreciate it. Welcome, Chief. You have been an incredible partner in your previous role, and I hope you stick around for a really long time because that kind of stability in our service is really sorely needed, that's for sure. I have a lot of friends that work for your service. And as a former CAF veteran, I always worry about the mental health of first responders. What you guys put yourself through every single day can take its toll and often does take its toll. And these invisible wounds, because, well, they're invisible, are very, very, very difficult, even for the people that are suffering from them to recognize at the time. So I'm just wondering, what is your plan to tackle mental health and mental health issues in your ranks?
Chair Suds, thank you for the inquiry. First off, absolutely agree with the opening comment from the councillor with respect to mental health. We did mention it in the presentation as something that is a priority for staff. That is something that, kudos to the city and to the leadership of Anthony DeMonte on this file with respect to providing an initiative that recognizes not just paramedics, but the fire service and the police service, and developing a program that really does focus in on the special needs. And I mean that in a very unique way, that the mental trauma that is experienced by first responders is unique to the work we do. And arguably it's unique to the fire service, unique to the police service, and unique to the paramedic service. And with respect to the paramedic service, sometimes we think of it as acute events, but it's also cumulative events where there's an ongoing exposure on a regular basis to very, very difficult emotional events. And so coming back to the initiatives with the paramedic service, arguably the city has really taken on a leadership role with fire and police in developing a first responder mental health initiative. And over the last number of years, I've been involved with the Canadian Standards Association in developing an actual psychological health and safety standard. And the initiative here in the city actually reviewed that standard and looked at the checklist of items that the city is doing in response to mental health issues. And you know, the city has done really good groundwork, and it'll take time for us to see the benefits of that, because what we're really trying to do is deal with not just the acute events where people feel the trauma. That's almost too late. What we're trying to do is provide an environment where the first responders and paramedics are not insulated, but well able to adapt and be resilient to the effects of this cumulative or acute trauma events. So kudos to the leadership that Anthony Demonte has provided, and to the coordination with the fire service and the police service on this initiative. So it remains front and center when I think of priorities for our staff. And I think of their health and safety, mental health is one of them. So thanks for the inquiry.
Thank you very much. Mr. Demonte, did you want to comment any further on that?
The only thing, Chair, is well, first I thank him. Yes, we've worked with our partners, and we've done several initiatives, and we're doing now some evidence-based. So we're going to peer review some of the work that we're doing with Dr. Hatcher and others. But as the chief assumed command, one of his priorities that he indicated to me was mental health. So it's one of his top 3 priorities. And Councillor, I very much appreciate, because I know you're very supportive of us and all the uniformed services because of your history, and that's very much appreciated. So not only from a leadership managerial perspective, but from a political and representing the community perspective, it's very, very helpful for us to have that support. So thank you.
Well, you're both a credit to the service. You know, as a former paramedic yourself, Mr. Demonte, Pierre as well. Keep up the great work. We've got really high expectations for this team, and I know that you'll deliver.
Okay. Thank you very much, Councillor Luloff. I see Councillor Kavanaugh has her hand raised. Councillor Kavanaugh.
Thank you. I already gave my nicey comments earlier, but I did have a serious question, and that's on the gender lens and equity lens in terms of future high schools be priority.
Chair, maybe I can start, and I'll let the chief, in fairness to him, he's his second day that he's assumed command of the service, so may give him a chance. They talk in their report about some of the initiatives they've done. Actually, of the 3 emergency services, certainly from a gender lens, it is the one that has been the most successful, not only at the front line, but now as the front line, some of the senior individuals there, as you know, opportunities open up in the command staff, are now more and more, we're seeing women assume those command roles. So this is of the 3 services, 3 emergency services, and I know we've chatted with you and other councillors of the challenges we have more in the fire service. So I'm working a lot with the chief out there, but this is one where I like to point as the probably the one where I would hope other services strive to be. When we look at peer services across the country as well too, the Ottawa Paramedic Service with regards to women in leadership roles and that we see a lot of that that work that's been done now, building and the fruit coming to fruition, if you will, and certainly that continues. And we recognize that if we want that, we not only have to give women opportunities to assume these leadership roles, but we have to mentor, coach them, and support them in that. And that's what we're doing. There's a lot of, first, it's a young service, it's a young profession. And so while it's taking time, we're seeing, I could tell you at the different levels, more and more women. And I always joke about this. I remember with the previous chair, Chair Deans, and I know I've said it to our current chair, the paramedic service in particular, you need a college degree to get into, to become a paramedic and get certified to practice in Ontario. And to do that in high school, you have to take, high school biology and chemistry and physics, and you have to have high marks to get in because it's a very difficult program to get into in college. And I used to, when I was chief, go to talk to all the first year students at both La Cité and Algonquin, and I would look across the classroom, and there was more than 50% were women, because I guess the girls are smarter than the guys in high school and they get the marks, so they get into the program, and rightly so. So I think it bodes well for our future because of that. We're going to see, women in leadership roles much quicker, and than in some of the other emergency services that have other types of challenges that we have to work on. So it is something that's extremely important. And I'd be remiss, I know you're looking at that lens, but on the diversity side as well too, we need to work very hard there. And there's a lot of initiatives that the previous chief as well too are working on. So both of those initiatives are front and foremost, and they're both also identified in the annual report. So I don't know, Chief, if you want to add anything to that.
No, thanks for that, Tony. The issue with respect to diversity and inclusion is really kind of an important issue, and you noted that in terms of the presentation. I think the first item with respect to the composition of our staff and women in leadership roles, we've taken a very positive view of that, and we're starting to see the numbers increase with respect to women who are commanders in the service, and who truly are becoming future leaders for the organization. The second piece with respect to the diversity is something that, for us to be reflective of our community. And I think when Tony Lamonte spoke about the first year students at La Cité and Algonquin, we're starting to see that the diversity start to appear there in terms of visible minorities and such. So our commitment is to continue to work on that. The last piece with respect to diversity, our service has been very much engaged in Pride and Pride events. And there is a real sensitivity throughout the organization with respect to that. And, when we talk about inclusion, the benchmarks in terms of how do you measure that is oftentimes a feeling of how staff feel included, how staff feel as part of their community, and that their place of employment also includes that. And so that is something that I'm sensitive to. And I've already spoken to the leadership about this issue. Not in a negative way, but in terms of us continuing to promote and develop that on an ongoing basis. So thank you for that, Chair Sutz.
Thank you very much. Thank you, Chair.
Terrific. Thank you very much. I'm not seeing any more hands raised. So with that, again, my thanks to you, Tony, to Poirier, and your teams, and appreciate all your time and responses today as well. So with that, is the report received?
It is received.
Received? Terrific. Excellent. Thank you very much. So we will move to the second item on the agenda, which is the Community and Social Services Human Needs Task Force and COVID-19 Response Update. I believe maybe Donna, as well as Shelley and Dean, may be joining us and have a PowerPoint.
Yes, that is correct, Councillor. Shelley, our Director of Housing, and Dean Lett, our Director of Long-Term Care, will be here to speak both on the Housing and Resurgence Plan and long-term care as well. Thank you, Councillor Sutz, for the opportunity to present today on our COVID-19 resurgence and cold weather plan to members of the committee. And I'd like to take the opportunity first to welcome Councillor Kitts and express our appreciation to and desire to work together on these important issues as we move forward. And also to thank all members of committee who over the last 7 months have been working directly with us in our COVID response and have been integral players in both linking the needs of your constituents and communities to the work of the department. And we appreciate that and thank you for your support. The community and social services and all of the respective services within this department have been in full crisis management and emergency response for the last 7 months. The department has had over 280 resources deployed from the corporation to support our resources and support long-term care. And all of our staff in our operational areas have been dedicated to emergency response and redeployed to those areas of most critical focus. Today, I can say that as we build the plan moving forward, our resources are extremely strained and challenged to meet the new and emerging demands within our services, at the same time as we deal with a very complex and evolving legislative service delivery model changes that are coming from all levels of governments as they anticipate and adapt to what will be the long-term impacts of COVID. And with the opening of the services and the majority of the deployments going back within the department, we're actively focused on staffing and resourcing the positions to maintain our response. And we're planning now for what we see as a marathon that will see us addressing these crisis and service responses well into the year and through the winter. And also to look at the critical long-lasting impacts that we believe will be faced for those who are facing the most significant barriers in our community, even before the COVID crisis. We are not only dealing with the COVID crisis, we are dealing with a homelessness crisis and an opiate crisis. We are seeing today the strain not only on our existing municipal services, but on the social infrastructure within our community as they strive to deliver the increased needs of the services with the ongoing constraints that COVID has placed on their ability to deliver services through their staff and facilities. In a survey of agencies this month, we started to take a look at, and 53% of our community organizations are serving less clients than they were able to pre-COVID. This service and the constraints within our community means we need to have a very focused and deliberate plan to address those pressures that will face us. It will demand focused efforts, resources, collaboration, and agility and nimbleness. The plan we present today builds on our evaluation of the successes we've had to date in addressing the current constraints and challenges ahead. We will build on those as a model of delivery as we move forward into the future. And to set the context for the plan, I want to give you an overview of the emergency response plan to date, because it really forms the framework that we'll build on for the next plan. And that framework is looking at outreach and social services, financial and food security, and homelessness and sheltering. And these core community priorities and the Human Needs Task Force, which is our emergency response entity, a network of over 50 agencies, will continue to form the basis of our cold weather and resurgence plan. While we will also pivot that infrastructure to start to assume and look at broader systemic coordination and planning functions that we need to address the systemic barriers that are facing the gaps that we've seen in the first 9 months. In this new environment, Human Needs Task Force members have had to forge new ways of working across new sector partnerships with a commitment to eliminate the barriers that have been faced in our community. With these rising cases in our community, the return to a modified stage 2 and the closure of services and the onset of colder weather and snow, there will be increased demand on our shelter systems, day programs, and likelihood for isolation needs in our communities. These factors have all been considered in the development of a resurgence plan. But before I delve in and provide the details of our Human Needs Task Force, I would like to first start and express my deep admiration and appreciation for the commitment, dedication, compassion, and resilience of the community and social services staff team in my department. They've continued to deliver services or been redeployed to emergency services throughout this pandemic with both professionalism and personal sacrifice. They've had to move on a dime to adapt to new policies, procedures, and practices. And this team, which I joined just over a year ago last year, cannot be more impressive and committed and dedicated. I'd also like to acknowledge the service area directors who many of them are joining me today: Dean Lett, Shelley Van Busker, Claire Ferrer, Chris Tuck, Sarah Taylor, Jason Sabaran, and Natalie Johnson. They have worked tirelessly through crisis, change, and uncertainty. And the presentation that I will present today with Shelley and Dean is a culmination of all of their collective efforts working together to make an impact on our community. I'd also like to say a special thank you to my senior leadership colleagues and the city manager who have continued to commit resources, facilities, time, and support in the challenges that we've had ahead. And I'd also like to thank all of the members of the Human Needs Task Force that have been meeting weekly over the last 7 months to meet the needs of our community with agility, creativity, and perseverance. It is an honor and a privilege to be working together with them on this incredible challenge. The Human Needs Task Force, if I just go to the slide, maybe mark the first slide. The Human Needs Task Force addressed the urgent and immediate needs of the residents, first by mobilizing a multitude of resources to really understand what was happening in our community. We did that through the use of Canadian Red Cross, our integrated neighborhood response teams, our neighborhood ambassador programs, and outreach in our OCH, our Ottawa Community Housing buildings, and our priority neighborhoods. And really what these touch points did in our outreach really helped identify what are the unique needs that we were seeing in the early response. This will form the same basis as we move into a second wave of response, as we continue to stay connected with the community to understand those immediate needs. And then we worked collectively with the resources of the Human Needs Task Force and the service providers to reach out to their networks to address these issues. These services, in the time that we were in COVID, we needed to be reconstituted as well, because we were dealing with a social infrastructure that was not yet fully opened and had to adapt to virtual services, different service hours, and different functions as they moved forward. The opening of the McNabb Center is a good example of the discussions and the response that happened as a result of that model. When we look at the McNabb, and Mark, maybe just to the next slide. When we look at the model of the McNabb Respite Center, it really became a model for us to be able to deal with the constraints of service provision, yet meet the needs of those most in need in our community, and allowed us to wrap around and use our collective services to be able to provide services across the city in a geographic location. And we've seen tremendous success in the relationships that have evolved out of that, and see that as a model as we move forward and start to address those who will be experience enhanced barriers with cold weather. And a majority of the priority has been really, mark the next slide, has also been about not just addressing the urgent and immediate needs, but also supporting those community agencies to get back up and running so that they could continue to do the good work that they do in the community. And first and foremost, that meant making sure that those community agencies and organizations understood how they could do that safely and were provided PPE, increased cleaning and staffing resources to be able to ensure that their staff and their services remained safe. The social services relief funding helped us to support those community agencies to do that. As well, it allowed us to address what we were seeing in that first phase of outreach and response as the most urgent needs in those communities, and helped us look at how do we look at the basic needs in the community, how do we apply a gender and equity lens and make sure that no gaps in services were happening in the community in the early stages. You will see when we look at the dollar amounts that were out, there was a significant amount actually put in to respond to those emerging needs in the community, and specifically to address our Indigenous community needs, which individuals in the Indigenous community and those service providers were facing significant gaps to opening up services. As we move forward, we've done a new business case with the province asking for additional support from the Social Service Relief Fund for $17.8 million to be able to continue to support these community agencies and organizations, as well as the response plan you're seeing today, because this is a core piece of our emergency response, is keeping those agencies functioning, keeping them supported with PPE and cleaning and staffing and supports to move forward. Next slide. The next piece, which was really a core function of the Human Needs Task Force in the first phase, and will continue into the second phase, is really looking at the coordination of food security and financial security. And as you know, during that period of time, there were numerous new benefit programs that were rolling out and supporting the community to mitigate some of the financial impacts to those who were financially facing financial instability. What this coordinated provision of food, which we'll continue to do as we move into the next resurgence planning, you'll see this as a core tenet, was to bring together the more systemic issues around food security and how do we look at fostering and developing unique relationships to solve all of the unique needs that move forward. And when you see the extent of the supports that we've had to provide in the community, you'll see that food and wrapping around food to those most in need in our community has been a significant challenge, but also a significant need in the community. But through this work and the work of the Human Needs Task Force, we've seen incredible partnerships emerge. The Parkdale Food Centers and their partnership called Cooking for a Cause brought together restaurants and food businesses who weren't at capacity because of being shut down in COVID. And they were working together with our community agencies, over 22 community agencies, to deliver over 4,000 meals a week in our community. Or Food for Thought, that was delivering a group of restaurant entrepreneurs who were delivering hot meals to those individuals who are living in our shelter and motel system. And a social enterprise, the resurgence of a social enterprise through funding through the Social Service Relief Fund for a group like called Crackers Catering, which many of you may be aware of, that unfortunately that social enterprise had to close in COVID, but was allowed to reopen with the funding that was provided through the city so that they could continue to employ individuals and deliver over 50 to 70 meals a week to individuals in need in our community. So though these have been challenges, the structure and supports and the agility and innovation of our partners has allowed us to respond to that need. Next slide, Mark. As well, what we've done is maintain sufficient capacity for people to isolate. Individuals who are living in congregate living situations who don't have the means or mechanisms to self-isolate. So we've created 84 spaces for isolation over 4 spaces. And we've supported 562 people to isolate, including singles and families over this period of time, with 284 unique individuals being served at the Ruche Isolation Center. Through this first phase of the COVID-19 pandemic, we've had 79 cases, individual cases of people living in congregate living situations and testing positive, although we've had many more needing to self-isolate as they waited for testing or displayed symptoms. And what that means, though, is the support in being able to do this has really, and to have the numbers maintained at the level they are, it comes from the tremendous efforts of our shelter providers in our community and their diligence around infection control and identification of COVID symptoms, our quick response to isolate with the support of Ottawa Inner City Health, and then support to isolate in those spaces. And what those spaces, although those 84 spaces, wrapped around those 84 spaces are things like washrooms, bathrooms, personal care items, transportation, and food. So fairly significant infrastructure that has to be wrapped and supported around those sites. Next slide, Mark. So we'll continue to maintain the isolation capacity in our second phase, and Shelley will speak to that as we move forward. The next phase is really another component of the strategy, was to reduce the capacity in our centers, the overcrowding in our shelters by physical distancing. Our shelters already, we know, have faced significant challenge, and we've had an over 25% increase in the last 4 years in our shelter use, and over a 70% increase in shelter uses of families in this community. So this COVID challenge has further challenged our ability to continue to have emergency shelter situations. And so really the team have been working at all opportunities to shelter people in place, but also to reduce the overcrowding in our shelters to contain COVID. And you can see that we've created 240 spaces for physical distancing for both women, men, and families. In those physical distancing spaces, we've had 558 individuals use those spaces to physical distance over the period of the last couple of months. Next slide, Mark. As well, although we're in emergency response, we can't lose sight that the most important priorities for continuing to support residents to secure and maintain permanent housing. And under the leadership and support of the Alliance to End Homelessness, we've done a housing blitz to look at private market landlords. We prioritized women to flee situations of abuse by using the Canada-Ontario housing benefit. And we have also continued to mobilize and use our Housing First workers to be able to do look at housing and support for housing. And our housing loss prevention is supporting people with rental arrears, and our housing benefit fund. We know, though, in the current market, in the current situation, housing is limited, and this continues to be an ongoing challenge for us as we move forward. I'd like to take a moment before I pass it off to Shelley to say, so just in summary, you'll see that as the strategy, and Shelley will speak to the next component, each of these components and the funding and support we've had from other levels of government have been critical to bring us to where we are today. We know that we need to scale up and enhance our response, and we'll talk about that when moving forward. We can't do that without the continued support of other levels of government and the continued support of our staff moving forward. But before I pass the microphone to Shelley Van Buskert, our Director of Housing Services, for an update on the plan and the details of how we plan to scale, I wanted to take a moment to thank her and her housing team for their continuous dedication over the last 7 months. I know this city has faced many crises through this, and that team has been on the ground dealing day after day, not only with housing those that are most vulnerable, but supporting and wrapping around services and crisis managing all of the individual issues that have come upon them in the last few days. And I want to highlight the work that they've done over the last 7 months and appreciate the commitments that they've made as a staff team to do that. So thank you, Shelley, over to you.
Great. Thank you, Donna. If you can move to the next slide. So as we plan for the resurgence of COVID, and I think we're already there in the colder months that are coming, we're really moving from that immediate response to looking at more medium-term and longer-term sustainable solutions. We're also looking for solutions that are cost-effective. We want to make sure that we, remain fiscally responsible during this period and use the money that we're receiving from the other levels of government wisely. So we're very much looking for solutions that we would say are feasible and scalable. So we're really only paying for what we're using. So we're really also focusing our efforts on prioritizing resources and supports and responses for those who we feel are most at risk in the community based on the information that we have right now. And one of the biggest gaps moving forward into the colder weathers is the one that's impacting the community and family shelter system and the gaps that will create in our shelter capacity. Pre-pandemic, there were 598 beds for single men in the system, and that includes overflow beds, and 167 beds for women. And in following, Ottawa Public Health guidelines, we really want to try and reduce that overall capacity in the emergency shelter system by about 45%. So as per the slide, again, we are going to take that phased approach, leverage funding, prioritize the facilities that we currently have in play, and redeploy staff where possible. And really our actions are going to focus around maintaining and scaling food security, enhancing our daytime respite response, the plan for additional isolation spaces so we're ready to respond, increase the number of physical distancing spaces, maintain and increase our street outreach and supports. And again, continuing to advance the housing and homelessness plan that we brought to CPSC in June. There are quite a number of strategic initiatives that are involved with that plan, and we're coming back to CPSC in Q1 of 2021 with a work plan to prioritize all of those short and medium term actions over the balance of the term of council. Next slide, please. So we have the Red Cross on standby to resume wellness visits, and we're working with food providers to coordinate food access and hot meals to those in need. So for instance, we've been working with St. Luke's Table to deliver more than 150 meals at the McNabb Respite Center. And we're working with St. Luke's to try and identify an alternate site for the delivery of those hot meals. We have a space that's available January 1st, but in the interim, St. Luke's has a temporary space at a church in their local catchment area, but very much working collaboratively to make sure that there's that indoor space when the weather gets colder, so that people can come inside and have a hot meal. We've also been working very closely with the Human Needs Task Force to coordinate the delivery of food for individuals and families, most specifically families who may need to isolate at one of our family isolation centers during this period of time. And we're looking to identify a staff resource to really coordinate the whole entire food response. We're expanding the neighborhood ambassador program to neighborhoods identified with at-risk youth. And we have hired 6 new ambassadors, so that's great news. Today, the program will launch teams in the following micro communities. So Britannia Woods, Michelle Heights, Bayshore, Foster Farm, Winthrop Court, Pinecrest Terrace, and Morrison Gardens. Great, next slide, please. So one of the actions we took early on due to the when COVID first hit our community, and we saw many programs have to either shutter completely as people figured out how can we safely deliver services in this period of time. And so we worked very closely, our partner and stakeholder initiatives team and RCFS staff to open the McNabb Respite Center, which has been very busy providing services to at-risk individuals in that catchment area over the past 6 months. So one of the first phases of the cold weather response plan is services at McNabb have ceased as of last week, but we will be opening the first phase, the Tom Brown Arena, as an additional respite site, and that's in Councillor Leaper's ward. So we'll be using the top floor of that building as a respite site to replace McNabb in that area. It will open early November, and it will deliver the same suite of services that were being provided to McNabb. Access to washrooms and showers, basic essentials such as towels, toiletries, clothing, referrals to social supports and crisis intervention. We'll also, during this period of time where there's a lapse between McNabb closing and Tom Brown opening, we've provided increased funding to a number of day programs to extend their hours and days of service to meet that gap in the interim and to also to meet that gap ongoing. We are also looking for other respite sites in the Vanier Overbrook area and also in the Bywood Market area, so that we would have 3 respite sites opening this fall and carrying us over the winter into the spring to be able to respond to the needs of people in the community. And I think we'll be in a position to be able to announce those sites, probably in the next couple of weeks. So next slide, please. So in terms of isolation centers, you can see here, we currently have, well, as of today, it's actually 8 individuals that are using the Routier Isolation Center down in the market, and it has a capacity for 40 individuals, and services will be continuing in that particular site. We are holding a second site that has 30 additional rooms in case, we get into a situation where we need to respond past the capacity at Route GA. And again, we'll be able to provide further details on that particular site in the coming weeks. So we're actually running 2 family isolation centers. So I think folks are familiar with the isolation center that we're utilizing a building at Ottawa U. We continue to have that site available to us. So right now it has capacity for 12 large rooms, accommodate large families. We also are using fully leasing a hotel to provide a second phase of isolation space for families. And we currently have 7 families that are in isolation. We do believe we have sufficient capacity between the 2 sites, but are also working. Are working with I guess a real estate brokerage firm to look at additional options that may be available to us, whether in a hotel or motel space or kind of other commercial or residential space, to be able to flex our capacity as needed around that. So the Youth Isolation Center is currently part of the Kids Come First, and it's a partnership between YSB and the Children's Hospital of Eastern Ontario. And that site, it was originally at a building at the Royal Ottawa campus, and it's being relocated to one of YSB's transitional housing facilities. They'll have capacity for up to 4 youth who may need to self-isolate. And we're working with YSB to identify, opportunities for additional flex capacity should the need arise there. Next slide, please. So when it comes to increasing the number of physical distancing spaces. So we were originally at Jim Durrell, and we've moved to the Dempsey Community Center in Councillor Cloutier's ward. And thank you, Councillor Cloutier. I mean, your constituents in Councillor Cloutier's ward have been nothing short of amazing in welcoming us to both of those facilities. And their generosity through donations has been very, very much appreciated. So we currently have a capacity for 58 individuals at that site. Currently only 34 individuals are there. Right now, we're exploring other city-owned, provincial, and federal and private sites to increase the capacity for up to 140 beds. So if we're looking at reducing capacity in the men's shelter system, we're really looking at getting up to, in and around approximately up to 270 men out of the shelter system. And we've been having ongoing conversations with our community shelter providers about the winter response and what it would look like and how we're going to refer individuals to these facilities. So again, we'll be in a position to announce the second physical distancing site for men, probably within the next week. We've been using a hotel for physical distancing capacity for single women. We have 15 individuals there right now. I think there's 2 couples that are actually physically distancing there also. And we have secured a new site. We'll be signing a lease for that new site in the next week or so. And we will be transitioning to the new site probably now in early November, just with how our planning is going. And that new site is going to have a capacity of up to 390 individuals. So what we're going to do there is working with the women's community shelter sector. So with Cornerstone and with Shepherds of Good Hope, we're going to consolidate women's services in this new facility, and also move any single women we may have in our hotel or motel system to this new facility. So we're going to have a very, very robust response for women starting this November and into the spring and summer of next year. Next slide, please. So we've invested, so we have about 12 different organizations that do street outreach in the city of Ottawa, and the city doesn't fund, Housing Services doesn't fund all of them. Some of the organizations receive different other core funding through the city's community funding branch. But we have invested through funding we've received from the federal and provincial governments about $500,000 to increase street outreach services during this pandemic period. So we've increased operations. We've gone from one outreach van to 3 outreach vans. We've put more boots on the ground with the Salvation Army and with Ottawa Inner City Health. And so, you know, the whole point of our street outreach program, we know that the number of people sleeping rough in our city has increased greatly. Since the start of the pandemic, we went from about 90 individuals that were sleeping unsheltered to about 250 individuals. And that's for a variety of different reasons. You know, many individuals indicated they had a fear of contracting COVID in the shelter system. We know in congregate environments where there's little room to space out, that's a real fear. We always do see an increase in the summer as warmer weather approaches. Many people prefer to sleep outside. And we also know that some folks were actually able to access the CERB benefit and chose to use that and live outside of the shelter system. So the outreach teams that we have right now are working, collectively together in a very coordinated fashion to engage with individuals that are sleeping unsheltered. And really the whole point of street outreach is to do that assessment, engage with the individual, do that assessment, determine their acuity and the supports they need. And anybody that's on the street sleeping unsheltered is a top priority and the first priority for the city's Housing First program. So really it's about engaging, connecting to resources and services, providing COVID kits, so, sanitation supplies, and providing basic needs and harm reduction supplies. And also, our outreach teams very much proactively, respond to concerns from residents and businesses as those are escalated. We're also working and have created this summer an unsheltered task force that includes representatives from other city departments. So we have legal services, public works and environmental services. We have RCFS staff, housing services. It also includes the NCC is on that. It includes community outreach providers. I'm sure I've missed another city department that's there, but we're working together in a very coordinated fashion to address the issues of individuals sleeping rough. So, identifying where we may find encampments, where people are congregating in different areas, and really going in with a very, very supportive approach to encourage individuals to come inside, to receive services, to be assessed. So we really have an enhanced level of monitoring around encampments that we've probably never had before in the city. And as part of that, we know, from community residents and even shelter providers themselves and businesses in the Bywood Market and Lower Town area, we've implemented a Bywood Market cleanliness strategy. So working hand in hand with Public Works to identify the hot spots in terms of, cleanliness in the market and really doing a, proactive cleaning and making sure that, the physical presence of the market is taken care of. It is, it is a tourist area. So, and they've been wonderful. Public Works has been wonderful in working with housing services and in responding when we escalate any concerns or that the community is raising to us to them. So very much appreciate their support. Next slide, please. So we continue to advance the housing and homelessness plan. So we have created an interdepartmental task team to be able to respond to the Rapid Housing Initiative. So this is the federal funding that was announced, $1 billion across the country to rapidly create up to 3,000 housing units. We've received no further information about the initiative since it was announced. I believe it was in September now, late September. I have heard that we should hear something by the end of the month. So very much looking at how we can rapidly scale up construction using a modular approach, but also looking at acquisition opportunities and working very collectively and collaboratively across the city. Housing Services is working with planning around the background studies that are required to actually, implement and create recommendations and then around an inclusionary zoning bylaw, and that will be completed in Q2 of 2021. We're advancing the construction of units on the short-term transit-oriented development report. So that would be sites like 159 Forward Avenue, 1010 Somerset, and also the library lands on Albert Street. And we currently have 644 units and 11 projects that are underway right now, with 190 units scheduled to be available in late this year, but probably more into 2021. So as we're responding to the emergency, as we're taking care of day-to-day needs, responding to the emergency. We're still very much working to respond to new initiatives that are coming our way, but also to move forward and drive forward the strategic initiatives that are there in the 10-year plan. And as I've stated previously, we'll be at CPSC in Q1 of 2021 to talk about that work plan further. Next slide. I think now I turn it over to Dean. So thank you, Dean.
Yeah, and maybe just before Dean starts and you bring up the presentation on long-term care, I'd like to take a moment as well to thank Dean and his management team in our long-term care, who have been in amongst the full response, pandemic response for the last 7 months. As part of our response, we did set up a separate incident command structure for Dean in terms of supporting the work that he needed to do across all of his sites, making those stronger links and connections with Ottawa Public Health, who's been a strong player in supporting the efforts of long-term care, as well as the Ontario Health teams and the work that we, in implementing new programs and new legislative directives that have come from the provincial government as well. And I'd like to acknowledge Dean's leadership through this difficult time and appreciate the sacrifices and commitments he's made over the last 7 months to ensure that the residents in our long-term care home continue to be safe from the COVID virus, and that he ensures that his staff continue to be safe so that they can continue to deliver this critical service. So I'll pass it over to Dean to talk about the status of where we are to date and the plans moving forward, anticipating and seeing increased transmission and what that might mean on the services in long-term care.
Thank you for your kind words and your leadership through the pandemic and all the support you've been providing. I'd like to thank Chair Suggs and the committee members for the opportunity today to give you an update from long-term care and some of the lessons that we've learned from the first wave. Since our last update in June, we've been preparing and modifying our safety protocols in order to ensure all necessary processes are in place to protect the health and safety of our residents, our staff, and our families. We conducted an in-depth session with our management teams in each of the homes in early June to look at opportunities to implement quality improvement in preparation for the resurgence of the pandemic. We also, between the last presentation and now, we did a survey with our residents, our families, and our staff to understand what worked well through the first phase of the pandemic, and also what we could do better as a learning opportunity for the resurgence. The survey, also from that, we had 130 residents that responded to the survey. We had 227 families, and we had 255 staff members that provided feedback that we used then to incorporate into enhancements to our infection control practices. 70% of our residents, 84% of our staff, and 87% of our families felt that they received the information they needed about the pandemic. And 91% of our staff indicated that they had the tools they needed to be able to support the residents and each other in the homes during the outbreaks. The resident survey confirmed the impacts on our residents living in long-term care. I think we all can appreciate that it's a very difficult environment when you're being asked to isolate in your rooms. We're putting social distancing in place around meal times. We've had to limit the activities in the homes to one-on-one with residents, and also the isolation from families and residents. That social connection was significantly impacted as we were going through the first phase of the pandemic, and definitely a learning opportunity for us. The residents expressed that the level of care, the staffing levels, and safety protocols were working well, and provided recommendations to improve communications and social connections. And we've been working very closely with the province and with the public health on making those social connections for our residents and their families. And I'll speak a little more to that further on in the presentation. Our staff indicated teamwork and safety protocols were working well, and provided recommendations to improve communications and suggestions for additional supports. As a result, we've been able to implement network accounts for all of our staff in long-term care, which will help us to be able to get mass messaging out and to share updates with our staff in a timely manner. Families indicated that the level of care and staffing and visiting processes were clear and transparent communications were working well. They provided some recommendations for additional communications and changes to visits. And many of the family requests around visiting have been addressed through the recent updates from the provincial direction. We also, over the summer, conducted town hall Zoom meetings with all of our families, and it was very successful. This will now become part of our communication strategy on a go-forward basis to keep our families informed of what's happening in the homes. And finally, on this slide, we did a COVID-19 long-term care preparedness assessment, which was required by the Ministry of Long-Term Care and Ontario Health. And really it focused around strategies for human resources to ensure that we had the adequate staffing levels. Also the infection prevention and control program that was in place, and then our partnerships and how we would sustain operations on a go-forward basis through the pandemic. Next slide, please. So today in our homes, we have outbreaks in 3 of the 4 homes. At Champlain, we currently have 4 active staff and 7 staff that are resolved. And that outbreak started on September 11th. And I just want to prerequisite by saying that every time we get a positive staff, the clock changes on when we will be able to resolve that case or resolve the outbreak. So it keeps moving every time we have a new positive in the homes. At Carlton Lodge, we have no active positive staff, and that home is not an outbreak at this time. Gary J. Armstrong has 4 active positive staff. 3 resolved from this current outbreak, and 1 resolved resident. And at the Peter D. Clark Center, we currently have 2 active staff. I guess something positive out of all of this is we have no positive residents in our homes at this time. And I think that just validates that our staff are doing a lot of the right things to be protecting our residents from contacting the virus. The other thing I'd like to highlight here is that our contact tracing has demonstrated that the virus is being introduced to our staff in the community. So the virus is not being spread in the homes today from staff to staff. So again, the infection protocols that we have in place are validating that we are doing everything we can to protect our residents and our staff, and also our designated caregivers. Next slide, please. I want to give a little bit of information around our infection prevention and control measures that we've implemented following the first wave. The homes are completing surveillance testing for all staff twice a month. And this is where we're picking up many of the cases of the positive in the staff. And the challenging part here is that these are individuals that are asymptomatic. So that's what's difficult for us to be able to identify that, but their surveillance testing is allowing us to identify those positives and then have those people isolated to prevent the spread of the virus in the homes. We've revised our IPAC education modules, and we're providing hands-on training and coaching to our staff, including donning and doffing of PPEs and hand hygiene. The homes have also implemented a structured audit around the donning and doffing of PPEs, and also around hand hygiene audits. We have a designated support in the homes to ensure weekly PPE counts and ordering are taking place, and there's standardized processes in place to ensure we have receiving regular supplies of PPE. And I just would like to acknowledge here as well, the EOC Logistics Group has been incredible in helping us to maintain a stable supply of PPEs in our homes through the outbreaks. We're currently in the process of hiring a dedicated IPAC resource in each home to provide additional support in the management of outbreaks and to oversee IPAC practices and procedures, including training, coaching, and auditing. The homes are following all of the guidelines and directives from the Ministry of Health, the Ministry of Long-Term Care, Ottawa Public Health, the pandemic plan that we had developed, our infection prevention and control program. We're doing the screening and testing of our staff and residents twice a day, as well as any designated caregivers are going through screening, entering and exiting the building. We're providing enhanced disinfection with more environmental staff to ensure that we're doing a very thorough job of cleaning the areas and disinfecting. And we're leveraging our partnerships. And Donna highlighted earlier, we've had an excellent relationship with public health, and they have a dedicated resource on our incident command that is extremely responsive. And so we're getting incredible support from Ottawa Public Health. Next slide, please. So the homes have continued to increase our staffing levels as required. This is allowing us to ensure that we have the appropriate staffing levels to meet the additional tasks that are required in the homes. Example, the feeding of residents in the rooms. When a home is on isolation, residents are eating in their rooms, which requires more resources to be able to support the nutrition and hydration of residents. Also, additional staff to support the screening for staff, residents, and visitors twice a day. And also the surveillance testing that we're doing in the homes for our staff twice a month. The redeployed staff from primarily recreation culture facilities have returned to their substantive positions. In order to replace these resources, we've hired 30 what we call long-term care helpers. And these individuals are helping with one-on-one activities for residents, connecting residents with their families, and support with meal times and also environmental cleaning. In order to ensure that we have the resources required, we have an open competition for all of our frontline positions right now that are posted on the city website. Since our last update, we've hired 117 staff across all disciplines in the front line in the homes. And we've also, with our student placements over the past few months, we've hired a number of those students. And the real benefit of hiring the students is that they come day one ready to work and they've been fully orientated and trained. So we're very fortunate to have the relationship with the colleges to be able to have those students and the ability to recruit directly from that pool. Next slide, please. So there's been a lot of changes in visitors and long-term care. I'm going to give you a bit of an overview of how the changes have come forward and some of the most recent changes to visiting and long-term care. So one of the most difficult things we've had to do, is isolating residents in their rooms, but also isolating them from their families. And so when we were able to start permitting visits into the home, we were very pleased that the government had given us that direction to move forward. In the summer, we started gradual return to indoor visiting. We introduced garden visits in June and short scheduled indoor visits starting in July. And once these were established, the homes moved to enhanced indoor visits in August, which allowed longer, more frequent indoor visits. On September 9th, the Ministry of Long-Term Care implemented an updated visiting policy that permits designated caregivers to access the homes for no time limit or required scheduling, regardless of whether or not the home is on outbreak. So again, very positive that we can continue to have those individuals in the home to be supporting their loved one. The ministry recently announced additional restrictions on visiting on October 7th. So social visits are currently suspended in the homes until further notice. The resident can have 2 designated caregivers connected with them, but only 1 designated caregiver can come in the home at a time. There's no restriction on the number of days or the length of time that they can come in and visit in the home. And today we have approximately 400 designated caregivers that are regularly coming into the home to support the residents. As I said earlier, the process around visits is changing constantly. We received notification yesterday. The direction from the ministry is that residents living in areas with high community spread, which would be Ottawa, are not permitted to leave the homes for short stay absences or temporary leaves, except for medical or compassionate reasons. So again, we also are allowing essential visitors. This would be individuals that would be repairing the building, deliveries, essential medical support. These individuals are being permitted to come into the homes, but they are in full PPE when they come into the home. Next slide, please. So again, I would like to thank the Community and Social Services Protective Services Committee for allowing the update today. I would also like, in closing, to take a moment to publicly thank and acknowledge all our staff working in the long-term care homes, our frontline workers and our management teams. Like all staff working in long-term care today, they've been working tirelessly for the past 7 months, making personal sacrifices in order to provide the best possible care and protect the health and safety of residents, families, and co-workers in this most difficult time. They are wearing full PPEs during outbreaks, which is exhausting both physically and mentally. We're so blessed and fortunate to have such incredibly dedicated, courageous, and caring team supporting the homes. They are truly heroes in the throes of this battle against the COVID-19 pandemic. Thank you. I'm going to turn the mic back over to Donna.
Thank you, Dean. And so you can see for us in the long-term care and Dean's response to long-term care that increased transmission continues to pose a threat and a challenge to the delivery of service in long-term care. It's through the efforts of Dean and his team and his amazing frontline staff that although the staff will get sick or potentially through community transmission, it's the practices that they put in place that continue to protect our residents in these long-term care facilities. So just in closing, I would like again to thank and recognize and appreciate all of the staff within the Community and Social Services Department who are and have been on the front line every day delivering services. And it is a true testament to public service that the commitment and work that they have done in maintaining their own health and the health of their families so that they can continue to deliver service. So with that, I'll open it up now to questions.
Thank you very much, Donna, and I echo your thanks. It is truly remarkable the work that you and your team, and extend my thanks to both Shelley and to Dean and your teams. You have done, unbelievable work on behalf of the city and our residents. My sincere thanks as well to add to that. And I think the presentation you just gave us this afternoon, really is a testament to just not only the quality, but just the sheer amount of work that you've done. And I know have done it with your hearts in the best interests of our city and our residents. So my thanks as well. And I see hands up. I'm going to pass it to Vice Chair Egley, and also ask that he take the chair seat for a moment as well for me.
Thank you. Happy to fill in as chair, and I guess I get to ask as many questions as I want now. Actually don't have a lot of questions. There was one thing that kind of twigged me though that I would like some more context around. So I think it was Shelley that spoke to sort of the connection between CERB and whether or not people were using the shelters. So I'm not exactly connecting the dots here. I know some dollars would be coming in. I'm assuming that the fact that someone's on CERB doesn't preclude them from accessing a shelter.
No.
You're nodding. So,
yeah.
So what do we have a sense? Because if people are getting CERB and then staying on the street, we don't want that to happen. If they're getting CERB and somehow utilizing that to find some place to have shelter outside of the shelter system, that's okay. But so these people that are that you've referenced that are getting CERB or are not using the shelter system, are they still on the street, or are they finding other accommodations as a result of getting those funds in? What's that connection?
So thank you, Councillor. So the reports of people getting CERB have come from the community shelters that a number of individuals managed to access the benefit. So I think it's probably a yes to both of your questions. I think maybe some might have used it to find a place, but it wouldn't be a place that they would be able to maintain long term, right? Especially now as service transitioning to a different benefit. Some probably used it to pay people to couch surf, but others, I think, chose to sleep outside and used it to augment their lifestyle over the summer months. So I think it is a real mixed bag, but the information around people experiencing homelessness accessing CERB has come from, anecdotally from the community shelter providers.
And if the people that are currently accessing CERB and doing one of those alternatives that you laid out, if as the weather gets colder and we get into winter, if those same people decided that they, CERB or not, they want to be in or they need to access the shelter system, do we have capacity to take those additional folks in?
Yes, we do. The shelters have actually been operating under capacity since COVID hit, just because so many people opted to not stay inside. I think, again, for the fear of contracting COVID. So as the weather changes and people CERB, no CERB, want to come back inside out of the cold, absolutely. We will have the capacity to be able to receive them within either the emergency shelter system or whether an alternate physical distancing centers that we are opening.
Okay, thank
So
you.
We don't turn people away.
Yeah, no, thank you for that. That clears that up, and thank you all for the work that you've been doing. I now have a bit of a quandary. The chair left me with a note saying you have questions, and next is Catherine. So we've got two Catherines. I'm not sure which Catherine she is referring to. I know Catherine McKenney always has questions, but I thought perhaps it might be Catherine Kitts as well. And okay,
Councillor McKenney, Keith.
Okay, all right. So over to you, Councillor McKenney.
Thank you, Vice Chair. Thanks, staff, for bringing this in front of us today. I also want to do a real shout out to staff staff McNabb Community Respite Center, the people that they served, mostly in the ward I represent, actually referred to McNabb as the McNabb Respect Center. I think it was for them the first time that they really felt that they had been treated throughout the day with respect, made friends. And I know the staff, everybody I spoke to, both staff and residents who were using the respite center really formed a close bond. So big shout out to Kim Stephen and all of the staff that were in there as well. And I look forward to, I would have loved to have kept McNabb open. I know that it's an arena pad, so it's not heated, but I look forward to Tom Brown, which is literally in my backyard, and others. I just want to go back to the housing blitz, and we've had this conversation, and I know the answer, but I just want to get it on public record because I want to think about a direction where we can resolve some of the issues. So my understanding is that there was the housing blitz with city staff and the Alliance, in phoning landlords, some, between 50 and 60 units were identified. Everything is not equal when you identify a unit, but could you tell me what, and I know that only about 4 or 5 of those units have been filled. So identified 50 to 60, but only 5. What were the major barriers to moving somebody into a unit that is available, but we're unable to get them there?
Thank you, Councillor. So I think there were a number of elements that contributed to not seeing the success that we would have hoped. I think everybody was, very much behind this initiative, under the leadership of the Alliance, the city being a great partner, Eastern Ontario Landlords Organization also. So a number of different factors were many of the units that we received were not affordable. So they were not affordable even with somebody who might be eligible or who would be eligible for a housing subsidy program that the city was offering. Others were very, very specific about the type of person that they wanted. Some like, I only want somebody with a particular religious affiliation. I only want a professional, a young professional. So maybe people not understanding some of the nuances of the initiative. The landlords that were offering units also weren't holding them specifically for the blitz. So it's like, here's a unit, putting it on the market, but person exiting homelessness is competing with person A, B, and C walking off the street to try and access that same unit. There was also a reticence because one of the programs we were using is, especially for single women, is the Canada Ontario Housing Benefit. And one of the requirements, and we know that this is a program under the National Housing Strategy, and the National Housing Strategy is a 10-year strategy. I think we're in year 8 now. So, and even under our Home for Good program where we have housing subsidies, there's can be a real reticence for individuals to agree to take that benefit because they worry that benefit may not always be there. They're like, oh my goodness, what happens in 10 years? And I think it doesn't really matter how many assurances we provide that, in 10 years, nobody's going to take your benefit away from you and make you homeless. I mean, that's not how the city operates. So reticence to take the benefit for that reason. And certainly under the new program, the Canada Ontario Housing Benefit, there is the requirement that people come off the wait list. And for some, that's not an issue, but for others, it very much is an issue. And many families, especially, will prefer to wait in shelter to access the deep affordability of a rent geared to income unit versus taking a housing subsidy benefit.
Thank you for that. I appreciate that. And we've had this discussion,
yes.
So I knew the answer, obviously, going into it. But I guess what I'm getting at is, you know, one thing, even in January, when we declared a housing emergency, we weren't in what we're in today. We thought it was as bad as it could get, but you know, things can always get worse. So if the province were to allow us to do two things, one, to even temporarily suspend the removal of people from the subsidized waiting list who choose to access a housing benefit, that would be helpful, right? Because then we could say to families and individuals, look, and I get why somebody would be reticent, especially if you're a single parent or a parent, and you're like, what if I lose that benefit? So if they could stay on the wait list and still access the housing benefit, there's no real loss. I mean, I never could understand the province's rules around this. There's no real loss, because if they get offered a unit and they say, no, you know what, I'm happy here, then there's no loss. The offer just goes to the next person. So if the province allowed that, even just temporarily, and they also allowed the housing benefits to be applied on units that are above average market rent, because my understanding is can only be average market rent and below. Surely that would help us get some people out of shelter and into permanent housing, because we know that, you know, the 60 I get probably wasn't a real number, but there might be 30 or 40 units out there that we could access if, in fact, the province were to allow us on these two matters. Is that correct?
So I'll take the first one. Yes. So if if they were to suspend the requirement that people had to come off the wait list, yes, you may get more people that are willing to accept the housing allowance or housing subsidy program. It's not seeming, I mean, the province of Ontario and MMAH has taken really some ambitious steps to reduce the wait list right now. So, one of the things we saw was the requirement that people take their first offer of housing, right? No more 3 offers. If you're offered, you need to take your first offer of housing as a way to reduce waitlist numbers and trying to assess what's the real need in a community. And also the work that MMAH is doing around asking and saying that you can create a separate list, because our centralized waitlist numbers are always inflated, right? If you say 12,577 households, we know that almost 3,000 of those households already live in rent geared to income housing, but are actually counted in the wait list because they're on an internal transfer list for a variety of reasons. So the answer to your first question is yes, that might create more momentum for people to take the housing allowance if the MMAH was amenable to that. In regards to the second, people are able to take a unit with a housing subsidy that's over AMR as per the program guidelines. They just have to pay the difference. So there was no requirement to say if you found a unit that was $100 over, 80% of AMR and what the benefit is, you could still take that unit, but you were then just having to make up that amount out of, in many cases, not all cases, a social assistance payment. And that's a real deterrent even there for some people, right? You're cutting into people's food money and, basic needs money.
Okay, so I guess, Vice Chair, it's still up to you. I would like to give a direction, because I think this is really important for staff to be able to continue to do their job. And I think that we need to make a formal request to the province to temporarily suspend the removal of people from the subsidized wait list who are accessing any housing benefit. Let them stay on the wait list while they access that housing benefit. It is a deterrent, and it is one that is based in reality and fear. And I think that it's keeping people from moving out of sheltered families for sure. So I see the chairs back. I wonder if we could just accept that direction, that we that staff make that formal request and then follow up with us on what that.
I'll turn it back to the chair.
Thank you very much, Vice Chair Aglai. And I see Donna nodding her head that this is agreeable to move forward. So yes, we'll take that direction for sure.
Thank you. I really appreciate that. I just want to talk quickly. I just want to ask quickly about, you talked about some of the temporary hotels that are being leased and temporary accommodations for people for overflow and for safe distancing. How many of those spaces do you think we're going to be able to retain going forward? So after COVID, so that we don't put people all back in, crowded motels, and we know we've had problems with, we get so overcharged for hotels and motels. And is there any plan? Do we know what we can do going forward to keep people? We put them into better circumstances. How can we keep them there?
Thank you, Madam Chair. So, Councillor, I think for some of the, for the families, we've created new relationships with new hotels that wouldn't have traditionally worked with us. So that's a positive. Not that we want to keep housing families in hotels or motels. We want to move families to permanent housing. But we need significant additional provincial investment in housing subsidy programs to be able to do that at all. If we look at our current families, and you say we want to address every family that's in the hotel system, you're looking at about 4 million plus annually at a $700 a month housing subsidy for those families. So that's the families.
I guess I was wondering. I guess I was wondering not so much keeping the hotel as a shelter system, but is that conversation going on around? Is there some way that we can either purchase or lease the entire hotel? Then we have it, and it becomes housing, and it becomes acquisition, because the rapid housing initiative is for both, right? Modular and acquisition. So is that part of the rapid housing initiative, I guess is my.
Yes, I apologize. I started with the families. I was going to move to the singles. So some of the options we have for singles right now, we will have to return to a community use at some point in time in the future, or they may be facilities, for instance, if we're working with a post-secondary institution, that they may need to turn back over to student housing, depending on what the needs are moving forward. So certainly under the rapid housing initiative, those are the things that we're looking at. What are the projects that we know of that we can quickly, grab available, whether it's partner land, private land, city land, to construct modular housing? And then what are the priority populations for that housing? And I think, ultimately we have quite a number of individuals in the emergency shelter system that we would want to be a priority for housing. And also looking at acquisition opportunities. And I'm having ongoing conversations with individual organizations about other additional, acquisition opportunities that may be out there that they're aware of. But also, I think we still are very interested in a hotel or motel if they were to come to the table. And again, thinking of the RFO we did, something that we could acquire that did represent good value for money for the city, in terms of acquiring that asset and renovating it for a housing purpose. So I think we're looking at everything, looking at all the available funding that we're able to access to advance our objectives in that regard.
Okay, I appreciate that.
Yeah. So Councillor, too, just on that, so the work that we're doing with a corporate real estate group with Steve Willis, so that real estate firm that's looking first priority is, our emergency response. The intent with both our real estate and that group is to look at acquisition of all properties. And when we did the RFO, the first RFO for motels and hotels, some of the feedback that we're getting was the impact in the market had not yet hit the Ottawa market as compared to other municipalities, and that we may see a change in that circumstance earlier in the new year. So we will continue to use that as a strategy to look at hotels, motels, purchasing, et cetera, as longer term solutions, and then be able to use some of the rapid funding program and funding that we have available to us to actually do those acquisitions, as well as some of the business case around the Social Service Relief Fund, that $17.8 million. We do have some capacity in there to also put that towards acquisitions and builds, and also the modular as well.
Okay. Thank you. And thanks, Donna and Shelley, for that. Chair, if I may, I just, one last thing that I want to raise, and it's not a question to staff, is and I have a motion that I'd like to put on the table around evictions and the lifting of the freeze on evictions and what that means. So I don't know if you want me to do that now, if you want to wait till the end of this item.
Feel free to put it out now for sure.
Okay. I don't know, Mark, if you have it that you can share it. Essentially, we had a freeze on evictions that ended. That moratorium on most eviction proceedings ended July 31st. We know from the Eastern Ontario Landlords Association that 2.5% of our rental households, and that comes up to approximately 3,200 households, have not been able to pay any rent over the last 6 months as a result of the economic shutdown. We have others, I think it's up to 4%, who have been able to pay some, but 2.5 have not been able to pay any. So just consider what could happen if 3,200 households were to lose their housing as a result of eviction. And it will take some time, but it could very easily happen. So this motion is just asking for, for the committee to recommend that council direct the mayor to write to the premier, the Minister of Municipal Affairs and Housing, to request that they immediately restrict all residential rental evictions, except in the case of threats to public safety, and to maintain this moratorium on evictions until the COVID-19 pandemic is contained and we get back to some form of normalcy where people can get back to work. We just cannot risk. We also, on top of that, we also have 36,000 renter households who spend more than 30% of their income on rent in the city. That's growing. 19,000 spend more than 50, 60, 70%. So there's always, people are always at risk of falling into homelessness, and we just cannot let this get worse before it gets better. So that's the motion in a nutshell. I'm happy to answer any questions before we go to vote on that.
Okay, we do still have questions to staff as well. So I think we'll just wrap that up, Councillor McKenney, and then if there's questions on the motion, we'll deal with that, and then the report itself. All right. And thank you very much, Councillor McKenney, for that as well. I believe that, sorry, I'm just checking my notes. Councillor Fleury was next, and then Councillor Meehan.
Yes, Madam Chair, I'll be supportive of that motion, and thank you, Councillor McKinney, for mentioning the specific element of criminality, because I do think that is one window of issues that we're seeing. We've seen it, for example, at OCH, where we have tenancies that are creating bigger problems in buildings, and we do need those evictions to proceed. But generally, I understand the intent and support the intent of the motion. My questions relate on three fronts, and Madam Chair, if you indulge me, I can save us a lot of time because we have the same team members to actually ask my questions on the inquiry, which the two inquiry requests, which were sort of presented on, because I think Donna or Shelley that spoke about the outreach services. So if you're okay, I'll use this window to raise.
I think, as you've said, it's covered in the presentation anyway, so go ahead.
So so the first one, my first question is around shelter capacity. And Shelley, you spoke to shelters not being at capacity. I understand from historic numbers that to be the case, but in conversations that I've had specifically with the Ottawa Mission and Shepherds of Good Hope, they see it differently. They see it that they have sort of a new capacity now based on the period. So I wonder if your interpretation of capacity has included that, just from an understanding point of view.
Thank you, Madam Chair. So our community emergency shelters have always been over capacity. So if we look historically, they have absolutely been over capacity and resorting to putting, mats down on the chapel floors to be able to deal with overflow. And actually, we funded Shepherds of Good Hope last winter to run some overflow beds actually in the space that they use for their kitchen. However, since I would say April, more likely May, the emergency shelters have seen a corresponding decrease in the number of people who have been utilizing beds. So they have been down beds. People are not coming inside to be in those beds. And we know that because obviously we see the shelter's monthly billings, right? They're only billing us for when a bed is occupied, and their billings are quite down. All of the shelters and our ongoing conversations about our winter response have indicated, we absolutely need a winter response, because our new capacity, to your point, Councillor, will be different because we do have to create that space for people to be able to physically distance. So that's why we're creating more spaces. We're going to keep the 58 we have at Dempsey plus add, the other 140 to take men out of the shelter system. That will coordinate the women's services. That will free up some money, some room for Shepherds of Good Hope. So it's all a phase staged plan. So yes, their new capacity is different.
No, I appreciate you clarifying that, because I wanted to understand and make sure there wasn't a disconnect between pre-capacity and current capacity levels, and that's clear. Want to then move on to acquisition. So we went out early with an RFO with interest of acquisition. I was skeptic because, in a bizarre term, you sort of have to leave the pressure of some of the landlords and hotels particularly at B and sort of pick it up at the last bit. And it's unfortunate to speak like that, but when you're talking about acquisition, you sort of have to pick up a property that's not at market. We have to say it that way, and it's bizarre to say, but it's a reality. Want to understand the flexibility and intent of acquisition. And what I mean by that is there is certainly an appetite for your teams to go out and solidify what I'll call short-term agreements, probably like a year lease or so, in whatever properties and locations you want, just to respond to COVID. But to me, there are heightened risk if we are to embark in a relationship with new property owners. If we were to take, for example, the lease or the acquisition of a full property without proper consultation and engagement with what the financial impacts would be and how tactical that approach would be. So that sort of prefaces my question. Want to understand, in the acquisition strategy, what value do we bring or think around purchasing? What would be a good fit to purchase, and what would be a good fit to partner / rent for a period? I'm unclear about where we see the value and what we're entertaining in terms of those interests.
Thank you, Madam Chair. So, so in the interest of the short term, let's say the short to medium term, we need a response to meet the needs in the service system. Certainly, probably past the spring of next year and into the fall. So if any of those relationships that we're entering into for a medium term response, we were to ever consider them as any sort of longer term response, we would absolutely have to do a complete due diligence around that, you know, consultation, engagement, financial, you know, all of those different pieces around anything that we're using temporarily. You know, when we look at acquisition, you know, I think there's a number, you know, there's a number of different things. Are there properties out there that we should be buying to maintain affordability for low-income people that currently live there? Is there a hotel or motel that has suites that would be an easy conversion into family housing, for instance? Is there, you know, new buildings coming on the market that aren't rented up yet? So I've been approached over the last 4 or 5 months with all of those scenarios. You know, this morning while I was listening to the early part of the meeting, I received a call for somebody about leasing a hotel and about 2 other hotel properties. So I think people are aware that we're looking to, you know, both the medium and the longer term for our acquisition opportunities. So short, medium term leases, longer term acquisition opportunities, looking at what's available to us and where we can find the money to be able to acquire those assets.
If I'm a property owner today, hotel, motel, a new build, whatever, and I come to you and say, hey, I want to be part of the solution in response, would you sign, if I said, hey, I want to keep my property because it gains value, but I want to rent to you for a year, would that be part with whatever, let's say it meets all the financial conditions, would the city entertain a 1-year lease of an entire property to meet the family housing needs?
I think we'd have to look at each one on a case-by-case basis. I'd also have to talk, you know, with procurement, like, are we following the right, you know, process within the city to be able to secure that particular asset? You know, I think we're always open to all opportunities that are available to us.
And just to comment on that through the chair, you know, our first and foremost, our priority, and I think you've seen that, is, you know, we are using city facilities and want to not invest money in temporary lodging or emergency lodging as much as possible. Like, what we are really trying to do is take the money that we actually have and look at how do we advance our housing and homelessness plan, and how do we look at longer term homes. And that's why modular is, you know, so interesting to us right now, because it is a way that we can get to housing at a more expeditious way and use our existing lands or lands that we have to do that, and do that expeditiously. We do not want to be in a situation where we are acquiring assets or leasing assets in longer term in an emergency response situation that at this point in time, right now to date, we're predicting volumes, we're anticipating need, we're scaling up for that, but we're not putting ourselves into financial commitments that at the end of the day, we're going to have to maintain in the longer term.
Okay. Yeah, I mean, we have to have a short-term acquisition or negotiation tactic, yet have a long-term vision on acquisition. And that has to include some of the federal offices. It has to include those vacant properties that the feds keep in most communities in our city. My final point on the acquisition piece is, Shelley, I'm glad to have facilitated conversations with you, Ottawa. I think they will be fruitful in a response. I call on all other institutions, Algonquin, Carleton, and Leslie, to be open-minded. Their student residences are not full because of the period, and they need to be part of the solution. So I'm not asking for a response from you. It's a call, it's a public call out that I'm seeing firsthand. You, Ottawa, step up. We need the other institutions to do the same. And my final, well, I guess this is my inquiry components of it. So I want to understand, I think your interest is in the right place as it relates to outreach services, but I am unclear how we sustain the effort, and I am unclear how we've equipped these outreach teams to be successful. I will describe a number of quick situations that maybe guide you to where the issues I've seen. So we've given resources so that teams are able to go out when there are challenges in communities. But when faced with that outreach interactions with vulnerable residents suffering from addictions, mental health, and housing crisis, we're not equipping those teams for quick response. They're sort of stuck in the same model of, okay, well, we can bring you to the shelter, or we can bring you, while people have made decisions not to go into the shelter, and those impacts have, those situations have community impact. So I want to understand from your perspective, how do we sustain the effort on outreach, which I think in its concept has value, but then I also want to understand what measures we're putting in place and learning from. And that's maybe what I didn't see in the response, and maybe it's the way I posed the question, but I'm not clear on the gaps. I'm not clear that I'm seeing gaps, and I'm not sure that your team agrees with those gaps. And I want to make sure that that's clear, because I interact daily with your team. They do great work in acknowledging and reaching out to members in our community that are vulnerable, but I'm not seeing a resolution. I'm seeing interaction at this point.
So maybe I'll take a few points, Councillor, and then I'll have Shelley respond as well. I think the piece that we've actually been struggling with through COVID was what I talked about at the very beginning, the fact that we have had a social infrastructure that has had to adapt to new ways of delivering services. So there absolutely have been service gaps that we have been continually trying to bridge. And I think when you look at the respite at McNabb that Councillor McKenney spoke to, and the success that we've had at that is what we're using to kind of replicate in our respite centers, but also look at best practices around where are the gaps and the needs that we're actually seeing. And one of those areas that we are seeing gaps is mental health, addiction, and harm reduction support. And that has been a critical piece in these respite centers at the very early on. It's been the key to the success, the community health and resource centers and the role that they've played in working with our staff to provide those critical and vital services. But our ability to scale those up and be able to wrap those services around these outreach services and support services are absolutely critical. And we've been in conversations with the community health and resource centers about how can we support that, and how do we look at other areas of funding? And there are a number of different programs and areas of funding that they believe this model could start to replicate with other levels of government. So that discussion, which we are definitely seeing right now, is the mental health and addiction, and trying to bridge that gap with our community partners, both to wrap around on the street with the outreach workers and to wrap around these critical respite centers that just really also then augment our community health and resource centers that are playing such a critical role in this response and being that front door in crisis intervention and supports as well.
I can also add to Donna's response, and certainly, your point is well taken, Donna, about the mental health and addictions. And certainly we've seen people's mental health and wellness deteriorate, people sleeping rough or unsheltered on the street over COVID, as many services that individuals relied on for those supports, whether it was the day programs, whether it was your housing first worker doing your home visit, or the outreach teams engaging on the street, or the mental health and addiction workers being able to come out and meet people where they were at, just because everybody was trying to do things remotely and a physical distance. So I can say that outreach, and certainly when you see many of the people that are unsheltered are very, very unwell individuals. They're struggling with a lot of co-occurring issues, and it really is it's a progressive engagement approach, right? It's trying to build that relationship and that rapport to get people to accept help and want to move on to something different. I can say though that the outreach teams, it may look like they're just chatting and they're handing out supplies, but they're building a relationship. They're doing that assessment. They're administering what we call the VI SPDAT, which is an assessment tool. And you don't even have to administer it. You can just ask the questions and very quickly see what somebody's kind of acuity rating is. All of those individuals on the street that we know by name go on our by name list. So they are prioritized for housing first programs and services. I think the issue there is, you know, many of the individuals in our Housing First program are moving into private market housing. So we need available units, we need continued housing subsidies, and we need willing landlords to be able to work. Many of our clients that we work with, exiting homelessness, come with a lot of stigma and discrimination attached to them, you know, and if you're racialized or Indigenous, like times that by 10 right now. So, you know, it's there, we do have a coordinated outreach response, and they are absolutely being prioritized for service first.
Okay, is it possible, because I've recognized gaps, and I want to know, you've touched on a couple of high levels, but granularly, is it possible to get a summary of what the team has seen? Because we get the number of, for example, encampments or so on, we get that list from Mr. Levine, but we don't get the specifics of, okay, what's the game plan with that individual, or what's the particular issue of why that element is not resolved. We don't particularly appreciate where the roadblocks are, and that would be, I think, valuable information, because I from what I'm hearing from staff that do outreach, there are existing barriers that we're just not rethinking. We're continuing to kind of struggle with the same outreach, not levels, but same outreach barriers.
I think we have to be cognizant of the level of, obviously, personal information that we provide. You know, the reasons are varied and diverse why people are choosing to sleep unsheltered. The opioid crisis, addictions, mental health. We have people, home takeovers. We have people that are sleeping unsheltered, but, you know, are actually declaring an address somewhere else, right? So there's a whole gamut. I mean, you know, theoretically, we could roll them up for you in a very, very high level aggregate. I don't know if that would meet your need, but we could start there.
I'm interested in, just to be clear on what I'm interested in.
Yeah.
I want to know what so right now the city contracts out outreach services.
Correct.
And I am not seeing a report from those outreach contract services in terms of identified gaps that have been relayed into the city and visible to us. There's no visibility of that. But when I go around this system and I reach out to folks who are on the streets, I recognize these barriers, and I want to make sure that is making its way to your desk, let's say, because there's a lot of components. The person that does outreach, are they tracking appropriately? Are they providing the resources that are available? Is your team understanding where those barriers are for those who are doing outreach? So I'm not looking at it from a granular standpoint. Okay. I'm looking at it from a systems outreach standpoint. What are the identified gaps? And have those emerged differently over the summer, which I believe they have, than where we were at a year ago, let's say?
So we can reach out to our outreach providers and have a conversation about gaps that they feel. I mean, we have a very coordinated approach. We have a staff that's working with all the outreach agencies. So we can reach in and provide something back that talks about the gaps that exist in the system from their perspective, and also all of the initiatives that are underway to be able to respond to those gaps. But if it's deeper than that, then it's something we would need to put on our work plan. Because
no, I'm glad with what you just described. That would be a really interesting piece. My final one, it relates more to the second inquiry piece. So you refer to 9 day programs, and I can appreciate that. They've all worked, they were all closed, and your team worked diligently, specifically yourself, to reopen them, and I appreciate that. But they have limited capacity now due to COVID. So that's what I'm conflicted with, is the respite centers are a piece of solution, but we don't have a lot of low barrier. And when I mean low barrier, I mean obviously consumption, I mean mental health, I mean a lot of the stigma that's out there around how do we facilitate a space that is low barrier and that is more open than simply Monday to Friday in the window. It needs to be evenings and weekends. We need that. And I think your point refers to some of the programs that are open, but I think we need to open up our minds. And maybe the question to you is, do you believe that the respite centers we're creating for the winter can be that entry into low barrier efforts and program? If not, what what are you working on?
Thank you, Madam Chair. So I think the standing up additional respite centers is really a response to the situation that we're in. I mean, pre-COVID, we were managing within our regular day program operations. There are a group of individuals that tend to congregate more in the market area that might not traditionally access some of the day programs. I mean, day programs, many of them, the majority of their population is actually individuals who are precariously housed that are coming to that day program for services and supports. So, I think it's, housing can only do something that has a housing component attached to it, right? Like the funding and any dollars I have to advance programming or to build new respite spaces or day programs has to come with a housing component. Right now in the city, and Donna may speak to this, we don't really have an identified pocket of funding for just increasing our social infrastructure, which is important. I think we would need to look holistically, do the day programs we have meet the needs. The respite centers are temporary at this point in time, and where there are opportunities to provide more of that programming, and in what parts of the city should it be to be most effective.
Yeah, and just to add, so I think what we're seeing as a gap that's been identified or exacerbated by COVID is the day program area, and recognizing that the needs and the increasing needs are getting more complex and more difficult for individuals who are experiencing homeless or have addiction and mental health issues. We know that we need to think about that in the longer term. We do have that as part of our plan, particularly as we're looking at housing options, in which Shelley talked about in the rapid housing and the modular. We are also looking at that as being a supportive housing approach. And in that gives us opportunities to also look at day respite programs or facilities or access into those structures. So we do see it, we do recognize it as a need. We're working with the existing programs that we have to build that capacity where there's opportunities, and we think that there may be some in the next year to move that forward and advance that.
Okay, well, that's a start to that, and I'll take the rest offline. Simply want to leave committee and specifically a specific mention to Dean, who was on the call earlier. I don't know if he's still there from long-term care. That it was an interesting conversation today with our CO hospitals, with our hospital COs, and I would love for them to consult with you specifically on what you've seen changed over the last number of years in long-term care that requires more hospital-like environments. I think they're now awakened to the moment due to COVID. I'm not asking for your comment unless you have any, but to me, you are a resource that they need to tap into as they face growing numbers.
So, Madam Chair, I will just add one comment. I believe there's an excellent opportunity through the health teams that are being developed for long-term care to be at those tables and to be involved in sustainable solutions to our healthcare system. I think it's really important that we don't work in silos and that we're working together if we're actually going to be successful in moving forward with sustainable changes to healthcare.
Thank you.
Excellent. Thank you very much, Councillor Fleury. And next I see Councillor Meehan.
Thank you, Chair. I'll try to make this really brief. I just one question, first of all, to Dean Letts. Dean, thank you for all your work in this area. You said in your presentation that there was no staffing issues in the 4 long-term care homes we have in Ottawa. I understand that we're going to be opening a new, I guess at the Greystone, 100 and some beds. Is there going to be? Are we anticipating a staffing shortage? For those the helpers in the home?
So, Madam Chair, there is a commitment from the province around a human resource strategy for the healthcare system in general. We're going to be bringing on more long-term care beds when there's already a struggle in certain parts of the province being able to recruit staff that are skilled healthcare workers. So I think we're going to have to get creative in how we support individuals, whether it's through tuition reimbursement, paid placements, to be looking at opportunities to attract people into long-term care and into healthcare in general. So I think that provincially and locally, we need to do our part to make sure that we're supporting individuals to be able to meet the current demand and the future demand as more beds come onto the system.
Yeah, I agree. Yeah, we've got to help. We've got to help them because this is going to be critical moving forward. If we're going to try to increase all those long-term care spaces, we're going to be needing. The term we had them when my mother was in a home. Like, what is the term? The long-term care worker? Anyway. You know what I'm saying?
Yes.
Yeah, so that's just one thing. So thank you. And if you need us to help you do that, to impress upon levels of government that we need to do that. And we'd like to have make a greater emphasis on the value of these workers so that they don't have to jump around to 2 and 3 jobs in different homes. So, a job that's got better pay, maybe a few more benefits so that they can build relationships with their patients. I think that's essential at this point. So if we can help you, please let us know. Just one quick question about, it jumps off the modular comments that you were making, Donna and Cindy. Have you been approached by anyone who is retrofitting shipping containers? I've been doing a lot of research about alternate forms of housing around the world, and a lot of communities now are using shipping containers. They're retrofitting them, putting in services, and they're mobile to a certain point, and they are answering some housing needs in various communities. And I know that there's a couple entrepreneurs in this area who are doing this. Has anyone approached the city to say, use me? I mean, shipping containers, you buy them, they're not all that expensive. We insulate them, we put in a little kitchen. It has to be a lot more affordable than what we're looking at right now. Anyone doing that?
Thank you, Madam Chair. Councillor, so we've been approached, I think over the years by different individuals who are bringing the shipping container idea to us. Not necessarily individuals who have a lot of experience with the concept. I mean, I think with shipping containers, it's always about, the people who approach us to say, well, here's your shipping container, and then really the city has to find the land, run the servicing, find somebody who wants to own and operate them as housing. So it hasn't been a route that we've given significant consideration to, though we have had conversations about potentially doing a small pilot at some point in time in the future to see, whether it would be a model that we would, want to do more of, but we would really have to trial and test them.
Okay. That's interesting. But so do we have land? I mean, could we put these someplace if somebody came up with, I would love to see them. They're self-contained, they're safe. Would be lovely to have a couple. I'd love to see a couple out here. I've got women in shelters. I've got nowhere in the community for these women to go, but we need spots. They could provide very possible housing very quickly. And if we could get people to actually do the retrofitting and we could rent them. It could be but if someone came to you and said, I've got 10 of these, do we have spots? Where would we put them?
Most of the land that the city has right now is land that you would want higher density development on. If you think a lot of the land we're holding, obviously along the transitway, higher density land. So we have had conversations with our corporate real estate office around available pockets of land. I would say we don't have anything, right at this moment that would support just kind of that lower density, just a few of them pilot. But like I suggested, it is conversations we've had, and we've certainly had them over the last 6 months. Okay. We feel that going with modular right now is probably, the best option. You cut development time, almost in half. So we feel like with the Rapid Housing Initiative, we can scale up some solutions very quickly before the end of next year. And organizations are reaching out to me, Interval House, for instance. There's lots of little opportunities right there that we can potentially work with some modular and do some women's projects.
Okay, but if I could find somebody who would like to participate in a pilot project, that's a possibility. Maybe.
Are you asking for the developer?
No,
or are you asking for somebody to own and operate?
No, I just know that somebody who's doing these shipping containers and they're retrofitting them. And I would like to act as a conduit between them and maybe the department and see what's possible. That's all.
What I would say, if we were going to proceed with a shipping container pilot, we would do probably a little request for offer specific to that. We did have a few modular shipping container providers come in through the RFO we did for hotels or motels, and it's very hard to rate what they're proposing versus an acquisition of a hotel or motel. So if we were going to do a pilot, we'd do a small request for offer because there's different people out there. We'd want to be, kind of transparent about any opportunity we would provide.
I just think now's the time to be looking at all options and see what we can get the least expensive and the fastest. Okay. So thank you.
Definitely.
Okay.
Thank you.
Terrific. Thank you very much, Councillor Meehan. And I'm not seeing any further hands. So again, my sincere thanks, Donna, to you, your team, to Shelley and Dean for joining us today in the presentation. Again, just really outstanding work that I know is heartfelt and is difficult, particularly right now in the midst of the pandemic. So again, my thanks. So I think now we will deal first with the motion we have in front of us, and perhaps if we can get that put back up on the screen. A motion tabled by Councillor McKenney. Does anyone have any questions with respect to the motion? I'm not seeing any. Is this carried? Carried? Excellent.
Carried.
Thank you very much. And thank you, Councillor McKenney, for bringing it forward.
Thank you, Chair. Thank you, staff and committee members. Appreciate it.
And so with that, is the presentation, we have to receive it. So presentation received?
Received.
Received? Excellent. Thank you very much. And so now the final report on the agenda today, number 3, the Community Safety and Wellbeing Plan. This is an interim report. And I believe both Valerie Bretlow and Lisa Pitch will be walking us through a presentation.
That's correct, Chair. Excuse me, that's correct, Chair. I have a few opening remarks, if I may. Merci, Madame la Présidente. I'm very pleased to be introducing this interim report for the Community Safety Wellbeing Plan. This report marks the first milestone in developing the plan and is the fruition of many months of community and public engagement, research, and data gathering. The interim report that Lisa Petch and the team is presenting today recommends 5 priority areas for community safety and well-being. While it is unquestionable that there are numerous important issues that form part of the discussion around community safety well-being, the plan won't be able to address all of them. It is important that Ottawa's first plan be focused and scoped so it not only truly speaks to the most important local priorities, but that it aims to be achievable and measurable. As a result, the 5 priorities recommended today will address the most urgent root causes of safety and well-being. These key areas of focus were identified as the most pressing and the most meaningful both to the community and through data sources. Lisa Petch, the project lead for our Community Safety Wellbeing Plan, will be providing you with a background on the work that has led us to these recommendation priorities, as well as the next step in our planning process. Before I turn it over to her, I would like to take a moment to thank the many people involved in the Community Safety Wellbeing Plan development. Thank you to Lisa and the entire team, Leslie, Justin, and Paula, for their tireless efforts, professionalism, and dedication to this important work. And I'd also like to thank our advisory committee, which is the Board of Community Crime Prevention Ottawa, rather. Their valuable advice and guidance as we move through the development process has been extremely important. And I think we came back to them 6 times over the last year for input. So thank you also to the participants who engaged in the activities for taking time to share their thoughts and opinions. And even under these challenging times, people came out to give us their input into this important work. Also thank you to the many organizations and agencies who've been working with us and supporting us in this development. I'd like now to turn it over to Lisa Petch to continue the presentation on the interim report. Thank you, Chair.
And thank you, Tony. I'll just wait for the presentation to come up. And next slide, please. Next slide, please. So maybe while we're waiting for that to change today, we will provide you with a project overview and update, provide a high-level summary of what we heard from our public engagement activities, seek approval of the recommended priorities, and outline the next steps for the development of the plan. This report marks the end of the first phase of the project. Upon approval of the 5 recommended priorities, we will move into the next phase of development of the plan, which is another engagement period to focus on objectives and actions for each priority. We expect to present the full plan to committee and council in late 2021, once the development is complete. I would like to now give you an overview of our approach to development. Under the provincial legislation, municipal councils must develop and adopt a community safety and well-being plan. And a community safety well-being plan is a long-term community impact tool that is used to address key social priorities and reduce risks and root causes of crime, social disorder, and ill health. The plan will be evidence-informed and will not duplicate, but rather complement existing initiatives for community safety and well-being, and will identify and address gaps in the system. The approach outlined in this slide allows us to have a systematic way to develop the plan that can be defended later and does not just address one organization's particular concerns. This ensures we adhere to the principles recommended by the advisory committee and approved by council. To date, we have completed the data analysis and environmental scan represented by the first shaded bubble on this slide, including perception polling and program mapping, and are now presenting the community safety wellbeing plan priorities for your approval, the second bubble on this particular slide. To develop the priorities, we conducted engagement activities to understand the needs of the community. Over 630 residents and stakeholders participated in our engagement activities from mid-March to the end of June, representing diverse people across Ottawa. The equity inclusion lens was applied and special efforts were made to reach out to as many diverse audiences as possible. The What We Heard report includes the demographic information and the issues discussed within each of the categories. As with the rest of the world, COVID-19 required revising our timelines and our approach to public engagement, but not our overall development approach. The original deadline for completion of the final community safety wellbeing plan was January 1st, 2021. But due to COVID, the province has extended that deadline and we are still awaiting a confirmation of a new date from the Solicitor General. Public engagement is a fundamental element throughout the development of the plan. And as you can see from this graphic, there remains opportunities to participate in the process as we move into our next phase of development, which focus on strategic objectives, strategies, and actions. Further, we will develop an evaluation plan and performance measures, look at an ongoing governance structure, look at the implementation plans, including the financial framework to form the overall community safety wellbeing plan. Although council approves the plan, any future actions and initiatives identified under it will be undertaken by the most appropriate department, service, partner, or agency. This means the City of Ottawa may have some actions, but will not assume full responsibility for the implementation of the plan. Next slide, please. This is a high-level overview of what we heard from the public consultations. The detailed What We Heard report was attached as document 2 to the committee report. This slide demonstrates how the public and stakeholders ranked the various topics when asked to prioritize them. Participants were also able to identify topics that were not covered in our list, and these are summarized in the other category. The consultation revealed and acknowledged the interconnection between all of these topics. However, participants also recognized the need to address root cause issues. The top 5 priorities that the public and stakeholders have identified are 1, housing, 2, discrimination, marginalization, and racism, 3, mental health, 4, systems change or security, and 5, financial security. Next slide, please. I would like to take a moment to present the 5 proposed priorities in no particular order. They are discrimination, marginalization, and racism. And just next slide, please. Oh, back one, please. There we go. Discrimination, marginalization, and racism. We were told stories of discrimination and racism from participants in our consultations and calls to address systemic racism, sexism, and other forms of discrimination. The research, such as Ottawa Public Health's recent study on the African, Caribbean, and Black community and mental health, demonstrate the inequity of the systems and effect on marginalized communities. The anti-racist, gender, Indigenous, and equity lenses must be considered in all our work as we develop the Community Safety Wellbeing Plan, but also require specific action to move forward. We will continue to work with the Anti-Racism Secretariat, the Women and Gender Equity Strategy, the Indigenous community, and many others to move forward on this particular priority. The next priority I'll discuss is the financial security and poverty reduction. Poverty was identified as a critical barrier to well-being and safety in our consultations. This priority in our consultations was also connected and linked with other issues, such as housing, mental well-being, discrimination, employment, and basic income. The 10-year housing and homelessness plan needs assessment also identified the link between housing and poverty. So next, most appropriately, housing. Housing was identified as a top priority for consultation participants across demographics. The plan will encompass and recognize the important work underway in this area and look for opportunities to support and enhance this work. And now I'll talk about mental well-being. This priority encompasses mental health, substance use issues, and social isolation, with the focus on the outcome of mental well-being. In discussion with Ottawa Public Health staff, including substance use with mental health was critical because of the comorbidity between the two. Also, in our consultations, participants often mentioned mental health and substance use together. Furthermore, social isolation will be considered as part of mental well-being, as consultation participants identified a direct connection between social isolation and mental health. Social isolation was raised as an issue both pre and during COVID. And finally, I'll talk about the integrated and simpler systems. This one is more of a process priority and is seen as both a priority in and of itself, but also as an enabler of the other priorities, which is why it is centrally placed in this graphic. This priority is about working together collaboratively to create a more streamlined system. This would include communications, processes, policy, finances, data, as well as service coordination and delivery. There was a call to action to change our culture as organizations and to focus on shared goals and how we can make it happen rather than focus on our individual mandates. And often the Human Needs Task Force was cited as an example that we could learn from for this particular category. Next slide, please. As mentioned previously, this is the beginning of our journey to develop the plan and marks a first key milestone. The slide before you represents the next steps for the development of the plan and the associated timelines. I would note that the timelines on this slide is tentative due to COVID and the deadline from the province. There will be a variety of engagement activities throughout the process. The next upcoming public engagement activities will inform the development of objectives, strategies, and actions for each priority and will begin in Q1 2021. We will also develop an evaluation plan and performance measures, an implementation plan for each priority, and determine leads and the resources required for the actions. We expect to come back to committee and council in late 2021 with a full plan. Thank you.
Thank you very much, Lisa. I appreciate the presentation, and I know the tremendous amount of work that has gone into getting to this point. It's great to be here, and I look forward to over the coming year when the plan itself actually does come back. With that, I do see questions, and I believe Councillor El-Shantiri was first. Over to you.
Thank you, Madam Chair, and thank you, Lisa and Leslie, for your presentation. I did meet with Lisa and her team more than once, talk about this. Madam Chair, just a little bit of history and contact. When we talk about the community safety plan, we had that from the previous government. We recommended for all police boards and whether they're served by the OPP or by municipal police, to have their own community safety plan in place. And at that time, the previous government was recommending some funding. And I think the last time I asked Lisa, and I let her answer that, there was no funding came from the province. Is there any expectation, unless Councillor Dean knows something, because she's the chair of Crime Prevention Ottawa as well, does she know if there's any money coming to us to implement some of those recommendations you have in place, Lisa? Chair,
If I may, I'll take that question and give Lisa the opportunity to skate the budget questions. No, Councillor El-Shantiri is right. There was initially some discussion as this file advanced. The government has not provided any funding, has given us very strict parameters and responsibilities as municipalities of what the plan has to be composed of, etc. But there is no funding. That's why one of the important components that we've done today, you heard Donna and her team, some tremendous work they're doing in housing. So we want to leverage that, and we're really focusing on the initiatives you've already focused on as a council and invested in our top 5 priorities, so to be effective. So unfortunately, there is no funding, and as a matter of fact, even for the team that's doing this work, we've had to find out within the departmental budgets to continue to do it. And we have the opportunity that our advisory committee through Crime Prevention Ottawa exists, so we're using them, we're leveraging their expertise and the team that's there as well too. So Councillor El-Shantiri, you're absolutely right. There's no money to help us do this.
And Demonte, without the province investing in, if they really think this is an investment, without the province's investment and without the funding allocated, those 5 recommendations or 4 recommendations our staff identified with the help of the Crime Prevention Board is going to stay put, because you need some funding, you need a budget to be able, and it's not, we said it all along through the years, community safety is not police, it's not foot on the ground. Community safety is every one of us, the police, the paramedic, the bylaws, all the emergencies, plus the community. And we need to, we need to take advantage of, we heard in the past Crime Prevention Canada has fund available, but we didn't reach some of them because we didn't have plan in place. Well, now we have a plan in place. Are you going after funding from Crime Prevention Canada and Crime Prevention Ontario to be able to support our own plan?
If I may, Chair, the council raises a good point. I think I'm going to be the optimist for now. This is just the first phase. So when we went out and consulted, across the board, and we've now identified 5 priorities, which we're presenting to you today for approval. Then we're going to go back with the next phase where we're going to look at each of those priorities and start identifying work that needs to be done. And I think then we'll know exactly what type of money. And I think you're right. It's particularly not even emergency service. What this is social services. It's all the other things we've all been talking about, you know, mental health and all the other challenges we have as a society. That's what a community safety well-being plan is. That's where investment needs to go. This will give us a good roadmap as to identify the projects and priorities that need to be invested in. I think this conversation will be important when we come to you with our second phase done, where if you approve these 5 priorities, then we're going to go and consult and identify projects with clear benchmarks and targets that we need to obtain. And then how are we going to do that other than things that we're already doing? How are we going to do that, and what type of money we're going to need? And then, yes, then the debate will be on where do we get this money and what opportunities, as you say, Crime Prevention Canada or others, what other opportunities for funding that we may need, we may do as a municipality, or we may ask senior levels of government to support us. So I think we're just one phase before that question. So I'm going to be the optimist that once we know what we need, then we'll be able to identify what kind of budget support we need to go achieve those objectives.
Okay, well, thank you very much, Chief DeMonte. I mean, this is a good dialogue to have, and I think we need to continue that dialogue. With the counselors to talk about their community and what the challenge they have in their own community, and reach out. But I mean, again, it's not just about police. And I know this recommendation came from Justice Tulloch to the government, previous government, but it was supposed to be funded to be able to, because right now the city, you just said you found the funding within budget. What about other small municipalities? So, and without having the overarch community safety plan, so that means it's going to be pieces here and there, and unfortunately, it is a great work our staff is doing, identifying the need, but yet without the funding, it's going to stay still. And I hope you'll keep us up to date. I'm not sure how often you're going to come to this committee with up to date, and if there's something we can help you to achieve, well, by all means. But I mean, this is a great work that our staff be able to do during the pandemic, and have that dialogue with. I'm not sure how many counselors, Lisa, have you met with about this? Have you reached all counselors?
We had individual meetings with 14 counselors, but we have shared information with all of council.
Okay, all right. Thank you very much, Lisa. Again, to you and your team. Thank you, Madam Chair.
Thank you very much, Councillor El-Shantiri. The committee coordinator has reminded me that we do have one delegation on this item as well. So I'm going to go to the delegation, and then I'll come back to the list with their hands up. My apologies. So with that, I believe we have Dylan Black, who has joined us. There we are. Hi, Dylan. Nice to see you. Thanks for joining us.
Yeah, thank you.
Pleasure. You have 5 minutes.
Perfect. Good afternoon, councillors. My name is Dylan Black, and I am the Senior Advisor of Sexual and Gender-Based Violence at the Ottawa Coalition to End Violence Against Women, also known as OCTIVA. OCTIVA is a coalition of over 40 organizations here in Ottawa that works together to bring a gender-based violence and violence against women lens to aspects of everyday life where we can help prevent and address violence. I'm here to speak to you about the proposed priorities as captured in the interim report for the Community Safety and Wellbeing Plan presented to you today for approval. While we support the 5 priorities presented in the report, we are deeply concerned that the safety and well-being of women and 2S LGBTQIA+ people is not included in this list of priorities. This is especially concerning considering the rising rates of gender-based violence and violence against women in our city and beyond, particularly in the context of the COVID-19 pandemic. Council has demonstrated its commitment to helping address, prevent, and end violence in numerous ways, and to prioritize the needs of women and gender diverse people in our community. Notably, Council has put significant resources into creating the Women and Gender Equity Strategy Framework, and only recently OCTIVA presented to support Council to have a robust process to help prevent sexual harassment and violence when hiring counselors' assistants. You have been clear that violence against women and gender-based violence has no place in our city. The communities we work with have been directly impacted by gender-based violence and a lack of safety in our city. Our member organizations have been directly impacted by these issues as well. And when we look at who is disproportionately impacted, it is important to highlight both the racial and gender dimensions of this social problem, particularly because narratives of women's safety are often used in problematic ways to police, incarcerate, and surveil marginalized communities. We also strongly support a fulsome gender equity and inclusion lens be applied to all activities related to the community safety and well-being plan going forward. We urge the city not to leave survivors of gender-based violence, women, and 2S LGBTQIA+ people out of the discussion of safety and well-being, and to substantially increase investment in community solutions to gender-based violence and violence against women. Unfortunately, we believe that the gender equity and inclusion lens, a requirement for all work undertaken by the city to be used, was not applied in the design stage of the community safety and well-being planning process. As such, a survey was circulated widely around the city with no mention of gender-based violence or violence against women. How can survivors feel seen and cared for, their need for justice addressed when no one was asked about being subjected or feared being subjected to violence? Anyone applying the gender equity and inclusion lens to safety and well-being would automatically understand that in this context, it would mean engaging stakeholders on violence against women and gender-based violence. Committee members, you have the opportunity right now to make sure that this is not lost. The Women, Gender, and Equity Strategy Public Engagement Finding Reports identify safety as a core priority for women and gender diverse people in our community. The priorities were developed using a robust and community-focused approach to understanding the needs of women and gender diverse people. Furthermore, the 2S LGBTQ+ service needs gaps and recommendations report also identifies safety for this community as a significant problem. The report before you today notes that other relevant work is taking place at the city, including the Women and Gender Equity Strategy Framework, and that this work complements it. It is your role to ensure that this work is aligned and that the community safety and well-being plan includes gender-based violence and violence against women as a priority. Each priority can certainly connect to these issues, but that's not enough. We cannot afford to lose gender-based violence and violence against women under other priorities. The city and all of its residents need to take action at every opportunity to prevent and address and ultimately end gender-based violence. COVID-19 has shone the light into the dark corners that many of us know are here in the city, who is most targeted for violence and who is the least supported. We cannot fail survivors. Please, we urge you to make this an additional priority now. Let's put every possible resource towards this vast and systemic issue that requires everyone's expertise and effort. It can't rest on survivors and those of us on the front lines alone. We need your help. We look forward to being able to advance a more robust and substantive approach to this issue and know that as councillors, you will continue to do what you can to help prevent violence, increase safety, and ensure that survivors are supported. Thank you so much for your time and for your consideration.
Thank you very much, Dylan. And I believe there's a few hands up, which I'm taking to mean questions for yourself. And the first was Councillor McKenney.
Thanks, Chair. Appreciate it. I actually had a motion on this, so not so much a question to the delegate, but I wanted to maybe put the motion out there just so we know that it's up for discussion and vote a little later. So essentially, and again, I just want to preface it by saying that I'm not challenging or questioning necessarily the methodology here. I know that doing broad-based consultation is especially difficult during a pandemic when we can't be in person. The way we communicate with each other has changed, and I do feel that this issue was likely missed as a result of that. I don't think that we had the people out that we normally would have that would have brought this issue to our attention. And when I think about even police, and you know, the chair of the Police Services Board is here today too on our committee. You know, violence against women, gender-based violence is a key priority there. You know, we have our own women and gender liaison. We've recognized that it's that this is a priority in the city, and this simply adds it as a sixth priority to the community safety and well-being plan. I just feel that it would be almost it would be very difficult to move forward with a community safety and well-being plan without recognizing gender-based violence and violence against women in our community as a key priority. So I'll just leave that there. I have no questions for the delegate, but I'm happy to again to answer any questions on the motion if necessary.
Terrific. Thank you very much, Councillor McKenney. We'll come back to questions on the motion as we table it a bit later. But just continuing on with questions for the delegation, I see Councillor El-Shantiri has his hand up.
Yes, thank you, Madam Chair, and thank you for your presentation, Dylan. You heard I'm sure you were on the call, you heard my exchange with the general manager and how the provincial government, who, when they asked municipality to do the community safety plan, was supposed to be funding coming from the province to support this, and none of that happened, and there was no funding received. And I can assure you, out of the 444 municipality, a lot of them won't be able to do their own community safety because the lack of funding is going to be a barrier, especially with the COVID and what's happening. So you heard the exchange with the general manager. My question to you is, do you agree our staff has done a good job identifying those priority, and now is, we don't want to download this on us without waiting for the province really to fulfill their promise, which is in the past to fund the community safety plan. What's your thought, Dylan, on this?
Thank you so much. Definitely feel like your staff has done a good job on this particular strategy and framework. Like Councillor McKenney said, there is obviously a lot of barriers, particularly with regards to the COVID-19 pandemic. In terms of the funding and resources, yes, like it is absolutely appalling that the province isn't extending any further additional resources around this, but the symbolic nature of adding this as a priority will signal to the community that this issue is of critical importance. And also there is funding to be found around these issues, and the violence against women sector is one of the most under-resourced sectors in our community. And also by investing in this issue in the long term, we will be saving our city funds, because we know that the cost of gender-based violence is very critical to the community, not only from a safety lens, but also from a financial lens or investment lens as well. So yes, they definitely did a great job, but unfortunately, the expertise, for example, as many of us know, during the COVID-19 pandemic, a lot of the gender-based violence advocates and organizations on the front lines were dealing with immense capacity issues around this particular issue. Domestic violence rates and violence against women were very high at the onset of the pandemic and continue to rise. So for us, we weren't able to have a specific consultation around this issue. And also, as per my delegation and from Octiva, is that in the original design of the survey, the issue of violence was not brought up. So for us, that was a flaw in the design of the survey. We understand that other priorities, such as housing and such as discrimination and racism, are very important, but we would also like to kind of pay attention to the fact that there are very gendered elements to those priorities as well. The way that women and 2S LGBTQI+ folks experience barriers around housing and discrimination has a gendered impact and a violence impact. So to not add this as an additional priority would be very detrimental to the community. Hopefully that answers your question.
Thank you, Madam Chair.
Terrific. Thank you very much, Councillor El-Shantiri. I don't see any further hands raised. So thank you very much, Dylan. Appreciate you taking the time to join us and for the important work you're doing.
Yes, thank you very much.
All right, so we will go back to questions of staff. And now I'm not seeing any hands raised at the moment, but I can revert back to what was up there prior to the delegation. I know Councillor Luloff was next. Did you still have questions?
Yes, very briefly, Madam Chair, thank you. Lisa, I'm really glad to see that substance abuse and mental health are together under mental well-being. You certainly don't get one without the other. No one who's doing really well decides to pick up a hard drug habit, like just for fun. So, I mean, I think that it's very important to recognize that substance abuse is a mental health problem. It's not a you know, a criminal problem. It certainly needs to be captured in that way, and I do really appreciate that. You can also say that physical fitness really does contribute to people's mental health as well. So I'm glad to see that that's broadly in there. Forgive my ignorance, please, but is 2S LGBTQ2+ captured within the discrimination priority? Or is that a separate priority that certainly needs to be added today based on what we've heard?
No, in that category, we would be considering any form of discrimination that we were talking about. So yes, the 2G LGBTQ plus would certainly be included as part of that consideration.
Is there a way to make that perfectly clear in the title as well? And when we talk about racism, and are we talking about violence against racialized people as well? And when we talk about 2S LGBTQ plus, are we talking about violence as well within that category?
So certainly that is what we heard as part of the consultations, is around, in this category, we heard about violence, we heard about systemic issues around different forms of racism. We heard about a variety of different concerns when we were actually looking at that, and those would all be considered as part of this category. It's quite broad. We've actually heard a number of people now talk about different ways to actually call that particular priority. And so that'll be something that we'll consider as we go forward through the rest of the development of this plan.
We certainly want to make sure that it is included. Absolutely. All right. Thank you very much. I appreciate that.
Thank you very much, Councillor Luloff. I believe Councillor Deans is next.
Thank you, Councillor Suds. And I just wanted to start by thanking Tony and Lisa and Valerie and Paula for all of the work that you've done on this. I know that this is an immense amount of work, and thank you for your efforts. And I have a question, and then I just have a couple comments to make. And the question's around the motion that Councillor McKenney alluded to. Can you agree to adding gender-based violence as a priority?
So no, at this point in time, staff recommend limiting the priorities to the 5 priorities before you today to realistically scope the plan and to ensure that it's manageable and successful. Staff followed a robust evidence-informed process to identify the priorities that were identified by participants as the most meaningful and pressing to the participants. And gender-based violence and violence against women were not identified as standalone issues for people, but rather were included as part of the issues that people were talking about when they talked about the priorities that were before you. So staff recognize that gender-based violence and violence against women are important issues that need to be considered and addressed. And we feel that we would be able to cover those within the proposed priorities that are before you today.
Yeah, I'm a little concerned about that. I'd like to hear what Councillor McKenney has to say. But just moving on, I just want to talk about the plan overall. As you all know, I'm the chair of Crime Prevention Ottawa, which is the advisory board for this plan. I'm also the chair of the Police Services Board. And here are my thoughts. I think that the community right now is looking to this plan to see some significant change. I think that COVID-19 in particular has highlighted areas that have not had the kind of focus that local government needs to give them, like mental health and addictions issues, like poverty issues, like homelessness. And I really believe that we need to do a better job on those issues. And I think that's what you're seeing coming out of the consultation, that the community recognizes, say, COVID has highlighted it. And to Councillor El-Shantiri's point, I mean, I agree. We're mandated to do this work by the province and they didn't send money. It's not unlike them, but it is frustrating. But having said that, it's a provincial mandate, but it's also a local necessity that we need to get on with doing this work. And even in the absence of provincial funding, and I think, yes, we should ramp up our efforts to ask for provincial funding to go with the mandate that we're required to do. But I really have a problem with implementation not coming to 2022. Like, we're in a pandemic now. And I don't think that we have to wait until every I is dotted and every T is crossed to start implementation. I think we can do some, for lack of a better term, quick wins. We can start some projects now and we should fund them, and there should be money in the budget to fund some of these projects. I think the community is actually pointing to the community safety and well-being plan to be a substantial guiding document for this community, and to not sit on a shelf and collect dust, but rather to be something that we use to guide us in the work that we do locally. And so I'm just worried that with all the good work that has been done, if we don't even start implementing till 2022, that's a long time off. To me, that doesn't make sense. So I've had this conversation with Tony and I've had the conversation with Mr. Kanellakis. I really think this committee needs to light a fire under whoever it is that's going to put money in the budget to start some priorities and get this plan moving. Because I know from police, we see the talk about defunding police. Well, you know what? If we fund housing and poverty and mental health and addiction issues and those kinds of issues properly, there will be less need for police. But we need to start working on that. And that starts with this plan. And this plan has to start implementation, not waiting until the plan is all completed and put on a shelf somewhere. So that's my pitch. Thank you.
Terrific. Thank you very much, Councillor Deans. And maybe just to build off that, if I can, and I'm not sure if it's for Tony or yourself, Lisa, but is moving forward the implementation timelines feasible?
Lisa, I know you have a lot of the work. I'll just, I think Councillor Dean's chair raises a very good point, and I concur with her, and I know that I've communicated with council about, as we were doing this during COVID, it was clear that the responses we're getting back from the community had an undercurrent of, Black Lives Matter, defund the police, all those other societal problems that we're not only seeing locally here, but I mean, they've become a world phenomenon. And I think that's creating what Councillor Dees is describing appropriately, a pressure, and we have to get on with it. Not an excuse. COVID certainly derailed timelines. The province then changed their plan, saying that the timeline was no longer at the end of the year. We had to have our plan completed. I think there, and Chair and Councillor Deans rather did mention, we've had a preliminary meeting, and following that meeting with Mr. Kanellakis, I had committed to some work, and it's already begun with our communication staff, because there is a lot of work that's being done, and right now in some of the communities that I don't think we're communicating as well as we could. So to Councillor Deans' comment when she met with us was taken at heart, and we've gone back and looked at some of the stuff, Donna, and some of the teams approaches that we're having in some of the communities, et cetera. We're going to kind of, I think market's the wrong word, because that sounds like we're trying to sell people something, but celebrate the work that's being done on the ground by some really good people. So we're going to do that as a first step. I had a chat with Lisa and the team about how how realistic it is, you know, currently. Can we move some of these timelines forward? And I don't want to commit right now, but I think there's some work that can be done. We can look at some of that. I want to remind that the evaluation plan and performance measures have to be completed Q2 of next year. So I think when we have that in hand, maybe it'll be easier for us to have this more broad debate and say, look, here's some of the plans that, you know, the 5 priorities. Here's some very, very tactical, operational things we can do and some opportunities. And then maybe we can have this debate and say, look, let's invest in these things right away, these 4 or 5 things right away, and let's get that up and running. I think that's a possibility. But you know, to get ahead of ourselves without going back to the community and reconsulting on the priorities and what they feel are the plans, I think there's a bit of a danger there, but we're working on that. We've taken it hard to some of the comments of Councillor Deans, who was actually repeating things that she had heard at the advisory committee, which is a broad-based committee, Crime Prevention Ottawa, with some very both influential and very important people in our community. So it's something that we're currently looking at. And I know I'm not giving a clear answer of like tomorrow morning we're gonna do something, but we're currently working on that, and we're more than willing to come back at committee, but even more importantly to some of you individually to see if this can help move this thing forward.
Terrific. Oh, I appreciate those comments, that context, Tony. Thank you. So next we have Vice Chair Eglai.
Thanks very much, Madam Chair. We're on our way to breaking the record of yesterday's meeting, but it's all good discussion. So I guess, first of all, I just want to take this opportunity publicly to thank Lisa and her team. I had a number of interactions with them leading up to this, and we had a very good community kind of outreach roundtable kind of piece that went on that I got very, very positive feedback from my community on. So kudos to you, Lisa and Tony, and everybody engaged on this project. I think that it was done really, really well. We don't always get consultation done well in this city, but I think in this particular example, and in light of everything that's going on and how, you know, we don't communicate the way we would normally do, you've done an excellent job. So I wanted to put that out there. One of the things, Lisa, that you and I had spoken about, and I apologize if you referenced it in the presentation. I had to jump off for a minute to take a call on another matter, but we had talked about, I was a little concerned about the length of the plan, not necessarily the implementation, but whether it was nimble enough, whether with everything that's happening and all the changes that we see almost on a daily basis now about things happening in and around our community and our society, I thought that the time between when the plan would start and when we'd go back to it was a little bit long. And so you said you were going to think about that a little bit. So I'm wondering where we are on that now. Have we built in some of that nimbleness, some of that flexibility to respond to things that are sort of coming down the pipe at us almost, as I say, on a daily basis?
So certainly, Councillor, and thank you for the feedback. The team, I think, has been working very, very hard. So thank you for that. But to answer your question, yes, we certainly have heard what you said and looked at that. And I think as a team, we've talked about it quite a bit about how do we actually do that. I think one of our advisory committee members has actually talked about it as, you know, you're walking through the rainforest and what's the next jaguar that's going to come out and kind of derail what it is that you might be thinking about doing. So one of the things that we're looking at, and part of what we'll propose as we're coming forward, that is how do we actually do that, and how do we build in mechanisms to allow for course correction as we're going through. And so we took to heart what it was that you said around, you know, a 10-year time frame or even a 5-year time frame is quite a long time in this day and age in terms of the world and those pieces. So that's something that we will be coming back to, and certainly we'll be looking at what are all the different ideas and options that are available to us as we look at that and look at the implementation plans and look at short, medium, and long-term objectives and goals as we're going forward. So that is part of our expectations about our development.
Chair.
Good. No, that's helpful, and thank you for. Tony want to say something?
Yeah, Chair, if I may, I think the councillor is bringing up a good point. I just want to put a bit of context. I know, and rightly so. This committee, you're all very action oriented. Just put a bit of context. The community safety well-being plans prime objective is to be a foundational piece of work that sets the city on a path and a course based on the consultation we've done, based on your approval of what we believe will be the right levers to improve this community. And it's actually the vast majority of levers, and we're clearly hearing it, are things that you've all been already talking about, housing, homelessness, racial discrimination, all those things. So I want to caution you, we still need to do the work properly. So it's a good, scientifically evidence-based foundational piece that'll outlive these one-offs that we'll continue to do, and we'll have to adapt and be nimble. I agree, but we want to ensure that you have and you approve, and that we as a community have a strong foundational piece of work that stands alone. It is evidence and scientifically based, and then it clears the path forward for us in the future as well too. So I know they can be almost diametrically opposed priorities, but I think we can achieve what you want. And Councillor Dean's comments, your comments now, Vice Chair, about being nimble and everything and finding some quick wins, and still give you at the end of the process, as it's defined by us in the roadmap that you've directed us to do, have a good foundational piece of work that's got some good evidence, scientific based process for you.
Oh, and I appreciate that, Tony. And it's not so much about quick wins. I want us to get it right, but I also want us to, if suddenly we realize 2 years from now, you know what, that's not really relevant anymore, or it's morphed into this, I want us to be able to respond to that. Lisa, I think this question's back to you. You were asked about where you were on this proposed motion and whether you were supportive. And the answer you gave was you felt that this, I think I'm getting it right, this sixth pillar or platform could be worked in, merged with the other pieces. So if that was your approach, I guess 2 questions. Why is that your preferred approach as opposed to simply making it a 6th piece? And secondly, how do you achieve what you're suggesting in such a way that this very real concern is given its due seriousness and attention? So how would you flag it? How would you highlight it to the delegation that we heard from, and the community at large, that, yeah, we did hear you, and while we haven't made it part of the platform per se, we are doing something with it, and this is how you will know.
Mm-hmm.
Sorry, there's a lot of questions in that.
Yeah. So I'll start with your first question about why it is that we believe that we can address it within the existing priorities, and why it is that we feel that. One is we're trying to make sure that the scope of this plan is manageable and successful. And by adding another priority, it then stretches those resources even further to actually looking at those pieces. And again, through our consultations in terms of the pieces in the process that we followed, the priorities that we're presenting to you today were identified as the most meaningful and pressing to the participants. But however, staff do recognize that gender-based violence and violence against women are important issues, and that given the broad nature of the priorities that are before you, we believe that we can cover those elements within that. In terms of the specific priorities, we believe that gender-based violence and violence against women could already be addressed under the priorities of housing, financial security and poverty reduction, mental well-being, and the integrated and simpler systems. And we don't want to duplicate any work that's already being done in these areas. So there is work, and there already is some recommendations that came out of the Women and Gender Equity Strategy that we believe could be highlighted and addressed through these priorities that we're putting forward to you. in terms of highlighting the particular pieces and really looking at that as we move into the next phase of consultation.
Yes, what I meant by that, Lisa, is how will I see myself? How will I see my concern in the report if it's not one of the, because there's going to be others, right? There's going to be lots of things that people are going to say, I wish this was a pillar, I wish this was a platform. So how, in this particular case, or any of the others that come down the road, will you be able to say, yes, you are in here and we have heard from you?
So one of the pieces that we're trying to make sure that we actually do as we go forward through this process is that we are identifying the different inequities within the systems, because that is something that we heard about quite clearly, and that often that is amongst those different our Indigenous groups, our equity groups, women, and that gender lens. And those different pieces being applied, and that we need to look at all of those specific issues. I can't give you at this point a specific action that I can point to say this is the one, because we're not at that particular point in time, but we are making sure that we're looking at addressing each and every one of those different groups and making a point of trying to reach out to as many different cross sections of the population to make sure that we get those perspectives. And we are trying to work with a wide variety of groups, and we'll continue to reach out with groups like Octiva to be able to actually get that input and include it as we go forward.
Well, that was my next question, whether you're going to, from what you've heard today, are you going to stay in touch? Are you going to work with the delegation going forward? And you seem to have answered that with an affirmative that they will be part of the process. So thank you for that as well.
Yes, thank you.
Okay. I'm done, Madam Chair.
Thank you very much, Vice Chair Aglai. Next is Councillor McKenney.
Thank you, Chair. Is this to the motion? That's what I was going to speak to, or I don't know if there's a...
Let me then just clarify, is there any further questions for staff before we go to the motion? Not seeing any hands. So yes, let's go to the motion then. Councillor McKenney, if you want to say a few words, and then we'll have an opportunity for questions before we vote.
Sure. I'd rather wrap up if there are others who want to speak. I've already introduced it, so.
Okay. Are there any questions then on the motion? I see Councillor Meehan has raised her hand.
Yes, thank you. I just want to clarify. We don't have the opportunity to add a sixth priority. Is that accurate? Did I understand that correctly?
We can do whatever we want as elected officials. Staff are saying they don't want to add it.
Okay. Okay. Thank you. Okay, thanks.
Okay. And next I'll go to Councillor Luloff.
My question's for the mover. Councillor McKenney, are you satisfied with what you heard today about how the inclusion priority encompasses what your motion is asking for? Are you satisfied with what you heard?
I'm not satisfied that we should just blend gender-based violence and violence against women through another group of priorities. No, I don't think that it will get the attention that it rightfully deserves in our community.
Okay, thank you.
Okay, I think I just want to make sure I can get clarity here for myself as well. I'll take the opportunity to ask a question. So I understand that gender-based violence is a pillar and a priority in the Women and Gender Equity Strategy plan, excuse me. And, you know, it's my understanding through Lisa's work in leading the development of the Community Safety and Wellbeing Plan that there is some obvious synergies there and collaboration that I think has materialized throughout the consultation. My concern, and I guess my question for Lisa or Tony is, by adding, what would we be achieving by adding this as a sixth priority? Because I feel like what I'm hearing is that the work is happening, and and that as we go now to strategies that we're going to be seeing this permeate throughout the plan. So I'm trying to understand what we're missing. What would we be adding by supporting this sixth priority?
Chair, I'll let Lisa speak a little bit. I guess I just want to add a bit of a thought. Council approved a methodology, a process by which we followed. We went out and did these consultations and we ranked priorities. And Councillor McKenney's absolutely right. Council, you are sovereign. If you direct us to if your motion, if the motion passes, or you direct us to do that work, we'll do that work. That's not a problem. I think Lisa will talk to you more about the work and what that means and how that can impact things. We were attacking this by doing what we heard, the top 5, and the percentile ranking of each of those are there. So you can see why they're the top 5. This one didn't rise. The delegation talked about their thoughts, and I respect and hear that. And the other issue of this is, as we looked at this community safety wellbeing plan, one of the things that became very evident for me is, as a community, there's tremendous challenges across the board and some very complex issues, from financial security to food security to street level violence and gang issues. We can't take them all on at once. So the work was done to bubble up what the community thought, and everybody, the stakeholders, what are the top 5? We attack those 5. We identify priorities and work that needs to be done, and we attack those, and then the plan keeps going and we keep moving forward and advancing what we want to do as a community so we can have a community safety well-being plan. This one is one of those. It's like, this is such an important issue. Violence against women is like, I don't even want to debate that, and I want to become almost a bureaucrat and debate. If you do this, then the next group that comes up with some of these other issues that rank lower and want their issues, like, we're going to get to a point as staff is, I don't know how we achieve all that if we don't have a process by, let's knock off the first 5, let's go on to the next 5 and move forward. How does that? But we live in a democracy, and as elected officials, you can decide to move that around. I just caution you, the problem is there may be another group that comes up with just as valid and as important issue that this delegation and their very important issue has come up with. So that's just a bit of insight for you to consider as you're making your decision, and we will do as you wish.
Thank you. Can I ask, from what I'm hearing, the work is going to happen. It's going to trickle through as this moves forward and as the strategies are developed. So is there any reason why we can't capture this? I don't want to suggest, I know that Councillor McKenney is proposing a 6th priority, but, and correct me if I'm wrong, I feel like this is in large part already captured by the priority discrimination, marginalization, and racism.
No.
No? Sorry. Can I ask staff to comment on that?
So we believe as staff, as I mentioned before, that the 5 priorities that we're proposing were the priorities that bubbled up to the top as being the most meaningful and pressing to the community. In terms of gender-based violence and violence against women, these weren't identified as standalone issues. However, we do recognize the importance of these issues, as Tony mentioned. And so we do believe that we could capture them not just within that priority, but also within the other interconnected priorities around housing, financial security, and poverty reduction, and in the integrated and simpler systems. A number of things that we had heard about from the sector were about some of the things that we also heard from other sectors in that integrated and simpler systems, such as, data sharing, asset mapping, pulling different information together, and we believe we can address them in those areas.
Chair, if it helps too, I want to remind you, like, I know Donna's team is doing a lot of work, and it's captured in the Women and Gender Plan as well too. But again, you're having a debate. We're providing you with the information as you continue to discuss as committee what you wish us to do.
Thank you very much. I do see Councillor Luloff's hand. Questions with respect to the motion, Councillor Luloff?
Yes. Tony and Lisa, are we arguing about priorities here, or are we arguing about nomenclature? I mean, if this is something that you are telling us is already captured by this, is there any harm whatsoever of making that perfectly clear by carving it out of the discrimination and creating a sixth priority? If the work is already being done, are we arguing about what our priorities are right now, or are we arguing about nomenclature? Because I think that's a very important distinction that we need to figure out here before we vote on this.
Mhm.
I think for staff, our feeling is about the importance of the process that we were actually undertook and what we were told by the community were their top priorities in terms of those pieces. So that is why we proposed what it is that we put forward.
Understood, and you know, I get that, but we're also being told that this is something that you did hear from the community. I mean, you guys have just told us that gender-based violence is something that was identified throughout this process, and it's been placed in this category. So is there a really big difference in the work that's going to be done by city staff if we just have it as a standalone priority? Is there really a big difference?
No, no, Chair. I mean, we're not going to die on this hill. If again, no, and you know, and it's, let me be really clear. I don't want anybody to leave. Lisa and her team, myself, we've heard, and there's so many challenges that we have in front of us, and this one is absolutely one that you know is in our community, and you know, I think as Councillor Luloff said earlier. As a former medic, I saw the tragic, you know, results of some of the horrible things that took place in the community. So on this issue as well. So you know, if that's what you want us to do, and if that gets us there, that's fine. Work's being done. There's different groups, and we'll regroup it there. That's not what we wanted to do. We just wanted to ensure staff that we told you the integrity of the process that you set us along with is now being usurped a little bit, but that's fine. As long as you're doing it with all the information in front of you, we're comfortable.
You guys did a great job. Like, don't get me wrong here. I'm not trying to pick at you. I just want to make sure that we get to the heart of this so that, you know, I understand really what we're doing. And okay, I'm very satisfied with your responses. Thank you.
Perfect. Thank you very much, Councillor Luloff. And lastly, I see Councillor Eglai.
Yeah, just one quick question, I guess back to Tony. So following off of Councillor Luloff's question to you and your answer, is there any resource issue with this happening? Like, I wouldn't want to vote for something, ask for something to be done and get it on the list if you can't give it proper due, if you're following me.
Yeah, I do.
So I heard Lisa say, look, we can talk about this. We heard about it in homelessness and various other pieces. So it sounds to me like it can be done, but I just want that clear that we're not giving you a project and under-resourcing you to do it if we add this on.
No, and perhaps I'll go back to the response I gave earlier to where we are in our journey that you've set us on. We're going to be going back now with these 5 or 6 priorities. We're going to be going back, and then there'll be sub programs identified with objectives and clear benchmarks to achieve, etc. So we can do that. It's the same team that'll do that. I think that question is very valid in the next. And when we come back with you with the work to be done, and you know, Councillor Deans, when she brought it up earlier, the answer was to that. So when we come back and say, okay, in this subcategory, here's what we heard, and here's what we have to achieve, or here's the projects that we need to achieve as a community. We got to get them done. That's where the boots are going to hit the ground, and we're going to need money to achieve that. So whether there's 5 or 6, I guess that could be done. And this one in particular, I just want to repeat again, the Women in the Future Plan already has this captured. So we'll be working with the team there because we're being very careful not to duplicate work in this plan that's already been done. So in the housing, which is the top priorities identified, we're going to go to that team and see Shelley and say, okay, what are we doing? That's going to be part of the presentation we're going to be telling you. We may modify that, or we may hear from the community they want a little bit more. So you'll have that information. So we're going to be careful not to duplicate, and we can do the same with this one because it's being done in another plan.
No, I appreciate that. Thank you. Thank you. That gives me some peace, if you will, in terms of, like I say, I don't want to give you a project and then not give you the tools to be able to do the project. So thank you for that.
Thank you very much, Vice Chair Aglai. Not seeing any other hands raised. I really appreciate this discussion we've just had, and thank you, Councillor McKenney, for raising this. You know, my concern at the outset was, frankly, much to what Councillor Aglai just raised, whether we were putting something on the table that wasn't achievable. But I think through this discussion, we're hearing that the work is underway anyways, and I wholeheartedly agree. This is certainly a priority in our city. And so, you know, I do support us naming it as such. So again, thank you for raising it, Councillor McKenney, and giving us this opportunity to debate it further. So with that, on the motion, is the motion carried?
Carried.
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 Fantastic. Excellent. And then lastly, is the report carried?
Carried.
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 Excellent. And again, my thanks to staff, Lisa, your team, Tony. I certainly, you know, appreciate this. Has been a tremendous amount of work so far, but there's still a long ways to go. So we're here to support you as you move this forward, and look forward to discussing it and debating it in the months to come. So thank you.
Thank you, Chair.
Thank you, Chair.
So we have no in-camera items. Any notices of motion for consideration at the next meeting? Not seeing any. And sorry, as with respect to inquiries, I just want to confirm with Councillor Fleury, if he's still with us, that we have addressed his earlier questions with respect to the his past inquiries. I don't see him at the moment. I believe we have. If not, I guess we'll have to revisit, but I believe we did during the questions to Donna and her team. Are there any inquiries today? Not seeing any, or having received any other business? Seeing none. On adjournment, is the motion carried?
Okay.
Excellent. So we are adjourned. I should mention we are doing media availability. I believe that starts in about 10 minutes, if I'm correct. But thank you, everyone, for your time today. The next meeting is on Thursday, November 19th. Right? Thank you very much. Take care.